Good morning, ladies and gentlemen. I extend a warm welcome to all of you. I extend a warm welcome to all of you to Kutch Convention 2024, one of its own kind and our first regional conference of the year 2024. Ladies and gentlemen, as you all know, in daily hustle and bustle of life, we hardly get time to update ourselves. In our clinics, our OTs, we rarely get time for these things. So, today I assure you, you will have a great day of academic feast. There will be talks, there will be updates, and there will be panel discussion on various topics. To begin with, हर काम उन विघ्न हरता की वंदना के बिना अधूरा है. तो just remembrance of that विघ्न हरता, we will start this event. वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा. So, to carry over the proceedings, I invite Dr. Nirmala Sharma ma'am to invite the chairpersons of the session. Thank you.
In this session of From Confusion to Clarity, the first session will be started, and I would like to invite the chairpersons. I would like to invite Dr. Urmila Ben Mehta ma'am and Dr. Panna Ben to please chair the session. And I'll give this mic over to Divya for the first lecture. She will give the details of it.
I invite Dr. Sagar Thakkar sir to throw a light on male infertility. He is consultant gynecologist at Bhakti Women's Hospital. He is MBBS, MBDGO, reproductive medicine and infertility specialist. He has done MBBS and DGO from Siyusha Medical College, Surendranagar. His fellowship in reproductive medicine and infertility from Radhakrishna Multispecialty Hospital, Bangalore and Natkani Institute and Nagauri's Institute, Ahmedabad. He has participated in faculty in various national and state conferences. I welcome you, sir.
Thank you, ma'am. Thank you, everyone, for coming. So, my today's topic is male infertility. What a gynecologist should know. It is one of the probably one of the most neglected part while managing infertility cases. So, these are the points that we'll cover. We'll cover introduction, male reproductive tech anatomy, history taking, clinical examination, causes of male infertility, how to evaluate an infertile male, treatment part, and approach to an azoospermic male. So male infertility usually contributes to the 40 to 50% of all the infertility cases. In the era of IVF and ICSI, very little importance is given in the treatment of infertile male. Especially people who are not practicing IVF, we should know very detailed how to evaluate infertile male, how to improve the sperm count. Objective of treating an infertile male is to convert the ICSI cycle into IVF cycle, of patient is for IVF, then convert it into IUI, or IUI to the natural conception. So this is the standard anatomy of male reproductive tract. It usually starts with the testis. The function of testis is the spermatogenesis and steroidogenesis. Then sperms will get stored in the epididymis, and ultimate final maturation will be attained in the epididymis. Then it will get transported through the vas deferens to the prostatic urethra. In between, seminal vesicles will drain seminal vesicular fluid, which contributes to about 50 to 80% of the semen volume. It contains the fructose, which provides the energy. It contains it is alkaline in nature. It is protective against the acidic pH of the vagina. It is a coagulating factor, and prostatic secretion contributes to about 20 to 30% of the semen volume. Then evaluation usually starts with the history taking. We should see the age of the patient, sexual history. In sexual history, we should ask for coital frequency and any erectile or ejaculatory disorder or any use of the spermicidal lubricants, which is very common nowadays. Environmental agent exposure, surgical history, any history of infections like Mons orchitis or filariasis, substance abuse like tobacco, alcohol, or anabolic steroid, any history of prolonged use of any drugs like antidepressant or antihypertensive, any history of chemotherapy or radiotherapy, or systemic illness. Physical examination usually starts with general examination. We should see the signs of virilization. It will be very less developed or very less developed in case of Klinefelter and non-developed in case of hypogonatropic hypogonadism. Systemic illness we should see for diabetes mellitus and hypertension. For local examination, it starts with this scrotum. We should see the skin. It will be thickened in case of filariasis. Size will be enlarged in case of hernia or hydrocele. Testicular examination, it starts with the position of the testis to rule out ectopic testis. Many times we have seen patient presents with the mild oligospermia or moderate oligospermia, and it has been given. He has been given antioxidant for 3 months, 6 months, and nobody has done clinical examination. One testis will be absent. It is very common. So we should see each and every case of male infertility. Male infertility should be examined. If we are being a male, we can examine female. We must examine a male also. Size should be measured. It should be measured ideally with the Prader's orchidometer, or ultrasound will be sufficient. While examining a penis, we should look for the meatus epididymis. It will be turgid, soft, turgid in case of obstructive azoospermia, which is called as Bell's sign. Vas deferens, we should see the presence or the absence of the vas, or it will be beaded in case of tubercular infection. On perrectal examination, should be ruled out to see the enlarged seminal vesicles or enlarged prostate, and we should look for the palpable varicocele. Now, these are the causes of male infertility. It is usually divided into pre-testicular, testicular, and post-testicular, and other causes. In pre-testicular, there are endocrine causes, psychosexual causes, drugs, and genetic causes. In testicular, there are if there is any history of toxins exposure, any history of varicocele, undescended testis, or primary testicular failure, or infections like mumps or cuttings. While post-testicular causes, it is most common is CBAVD or any infections like tuberculosis or gonorrhea, or any history of surgical procedure like vasectomy or herniorrhaphy. Ejaculatory disorders, severe ejaculatory disorders will present with the infertility, not the mild one, okay, and any signs of hypospadiasis. So this is the ultimate chart. It shows that oxidative stress is the main cause of the sperm damage. Anything like male accessory gland infection, drugs, varicocele, smoking will ultimately lead to the increased oxidative stress. Ultimately, it will lead to the lipid peroxidation, protein damage, and biomembrane damage, and ultimately will lead to the sperm damage and infertility. Now, how do we evaluate a case of infertile male? First and foremost, it is a semen analysis. It is the gold standard. It is a gold standard. Other thing, hormonal assay, FSH, LH, testosterone. It should be done in the case of moderate to severe oligospermia, not in the every cases. Estradiol should be done in case of obese, if the patient is obese, to rule out any T2E ratio reversal. Prolactin and TSH should be done ideally in the every cases. Ultrasound examination is indicated in case of severe oligospermia to rule out varicocele, and transrectal ultrasound is done in case of obstructive azoospermia to rule out any enlargement of the seminal vesicles or the ejaculatory duct obstruction. Okay. Genetic testing, there are only three genetic testing that is done in case of male infertility. One is karyotype, YQ microdeletion, and CFTS gene mutation. YQ microdeletion and karyotype is for non-obstructive azoospermia. CFTR gene mutation is for obstructive azoospermia. You can advise karyotype for severe oligoasthenospermia, but it will be present, positive rate will be like 8 to 10%. It will not be present in each and every cases. Abnormality will not be present in each and every cases. YQ microdeletion will present in 30% of the non-obstructive azoospermia cases. If patient is a AZA or AZB microdeletion, then retrieval by microtisa will not be also possible. If it is AZFC deletion, then 70% of the chances patient will get sperm by microtasy. This is a normal semen analysis WHO reference chart. Latest one has been published in 2021. There is not much change in between 2010 and 2021. Just there are few changes like ejaculatory volume they have decreased to 1.4, while sperm concentration they have increased to 16 million per ml. There is not much of increase. Total sperm number remains the same, 39 million spermatocyte per ejaculate should be ideal. Percent in motility, it is now 42% should be motile. Out of that, forward progression motility 30% is considered to be normal. Rest everything remains the same in 2021 criteria. So this is the classification. Normozoospermia if patient has more than 15 million per ml of count or 39 million sperm per ejaculate. If it is 10 to 15 million per ml, then it is called as mild oligospermia. If it is 5 to 10 million per ml, then it is called as moderate oligospermia. If it is less than 5 million, then it is called as severe oligospermia. Now, ultrasound in varicocele, it is most important because it is to judge when to operate a varicocele. Okay, each and every case of varicocele should not be operated. Ideally, palpable varicocele will end with deranged sperm parameters should be operated. Varicocele becomes palpable usually around 2.7 to 3.5 millimeter of size. Surgical treatment of less than 3.5 millimeter without altering the semen parameter, it is not indicated. But if there is a presence of reversal of the flow in the prognostic sign, it is a good prognostic sign that suggests that it will increase the chances of sperm concentration post surgery. This is ultrasound classification that is more important for radiologist, how to classify varicocele. Grade 2 and grade 3 varicocele should be operated if it is deranged sperm parameters. Severe cases of varicocele, it will not give you the good result. Improvement in the sperm parameters will be present in like almost 30% on cases only. Now we'll discuss the treatment part. Treatment part is divided into two things. One is specific treatment, another is empirical treatment. Specific treatment includes for hypogonadotropic hypogonadism. Hypogonadotropic hypogonadism is diagnosed by low FSH, low LH, low testosterone. It will be seen in case of Coleman syndrome, trauma, tumor, on hypopituitarism. Treatment usually starts with the 2000 international unit of twice a week or 5000 HCG fifth day. Till testosterone remains normal. My usual cutoff for testosterone is 600 to 800. If it goes beyond 800, I reduce down the dose of HCG. Then if testosterone will become normal, then HMG or RFSH should be introduced 75 units thrice a week. For varicocele, varicocelectomy is advised in case of grade 2, grade 3 varicocele. Microsurgical varicocelectomy is ideal method of choice for surgery because it has a very less chance of recurrence and post-operative lymphocyte formation. For hyperprolactinemia, it is usually associated with the macroadenomas. Symptoms will be like loss of libido or optic symptoms, and it need to be confirmed with the MRI. Macroadenoma requires the surgical treatment, and if a prolactin level is between 100 to 200, cabergoline is given 0.5 to 2 milligram twice a week in the divided doses. Now, genital tract infection, chlamydia infection is the most common. Antibiotic Leoflox will also work, doxycycline will also work. Doxycycline is the ideal thing. It is usually given for 15 to 20 days. Ideally, it should be given for 3 to 6 weeks because it is required at least 3 weeks to get into concentrated into prostatic plasma. Immunological causes, steroids are not given nowadays. IUI is the modality of the treatment. Now, empirical therapy. For empirical therapy, we have clomiphene citrate, HCG. Clomiphene citrate is a very cheap drug, a fairly safe drug. Many people give 25 milligram daily for 25 days, then followed by 5 days of break. Many people give alternate day. Result doesn't differ much. It is useful in the case of partial androgen resistance or mild hypogonadotropic hypogonadism, where FSH will be like in 2 to 4, similarly LH, and testosterone will be in 300 to 400 range. HCG is usually given 2500 twice a week or 5000 every fifth day. Indications are the same, mild oligospermia with the partial androgen resistance. HCG acts on the LH cell, Leydig cell, and it acts as a surrogate of the LH, which ultimately lead to the increase in intratesticular testosterone level, which will help in the spermatogenesis. Testosterone, it is not recommended for infertility. If patient is for donor IUI, or he just wants to restore the sexual functions, then only testosterone injectable or oral is recommended. Letrozole or anastrozole, it is usually given in case of obese male, where T2E ratio will be reversed. Letrozole 2.5 milligram alternate day or anastrozole 1 milligram daily can be given. Zinc, it will be useful in case of delayed liquefaction. 120 to 220 milligram twice a day for 3 months, and it increases also testosterone level, and it improves the accessory gland functions. Now, antioxidant, it is given right and left to each and every male patient. So what is there any specific role of the antioxidant, or it is just empirical therapy? It is usually complementary to the treatment of the varicocele or antibiotic treatment for infection, or the anti-estrogenic treatment in case of idiopathic oligoasthenospermia. It should be combined with the diet that is rich in fruits, vegetable, poultry, skim milk, and etc. Now, what are the antioxidants that are readily available? If patient is non-affording, we can give vitamin E also, we can give vitamin C also. Okay, that will work. We can give Zincovit also, that will work. Zinc will work. Okay, vitamin E 300 to 600 milligram daily for 6 to 12 weeks. It improves the sperm motility and sperm oocyte fusion. Vitamin C, the dose is 1000 milligram daily. Folic acid 5 milligram daily. Selenium 225 milligram per day, and it acts as an anti-inflammatory agent. Highest concentration is seen in the prostate, and it improves the sperm motility. L-carnitine and L-acetyl-carnitine. L-carnitine brings the acetyl coenzyme A in the mitochondria, which will ultimately help into increasing cell metabolism. L-carnitine will get concentrated in the epididymis, which will ultimately improve the sperm motility. The dose of L-carnitine is 1 milligram BD, on acetyl L-carnitine is 500 milligram per BD, and it is usually given in case of prostatitis and epididymitis, where the sperm motility will be affected due to the infection, and it should be associated with the NSAIDs. Now, coenzyme Q. Each and every company is coming up with the coenzyme Q. It helps in the mitochondrial respiratory chain. It is a protective role in case of antioxidant for the lipoprotein cell membrane. Natural sources of coenzyme Q is broccoli, spinach, soya, palm oil. It is available as 50 to 100 milligram soft gel. Now 300 milligram is also available. Ubiquinol is a reduced form of coenzyme Q. It improves the kinetic property of the sperm, which will ultimately improve the sperm motility. It is indicated in case of oligospermia and mild OATs associated with the varicocele. Vitamin D, it increases the intracellular calcium concentration, which will help in the sperm motility and induces the acrosome reactions. So this is how to manage a case of mild to moderate oligospermia we have discussed. Now, how to evaluate a case of azoospermic male. So azoospermia it should be labeled ideally when there is absence of the sperm in the ejaculate, even after the centrifugation of the semen sample at 3000 rpm for 5 minutes, and pellet should be examined. If there is no sperm, then it is labeled as azoospermia, and it should be ideally examined at least twice at 2 to 4 weeks apart. The incidence is 10 to 15% in male infertility. History taking is very much important to rule out history of any mom's orchitis or cryptorchidism, or any history of surgery, exposure to the gonadotoxic drugs, or recent high-grade fever will lead to temporary azoospermia. So any history of hypogonadism like delayed puberty or loss of libido or erectile dysfunction. On the local examination, secondary sexual characteristic will be very well developed in obstructive, while it may be not that developed in case of non-obstructive azoospermia, and it won't be any developed in case of hypo. testicular volume, it can be measured with the Prader's oxidometer or ultrasound. In case of obstructive azoospermia, volume will be normal. In case of hypo, volume will be very low. In case of non-obstructive azoospermia, it can be low to normal anyway. So, while evaluating azoospermia, we'll see the semen analysis. If it is fructose negative, then it will be 100% obstructive azoospermia. Okay, 90% of the time it will be CBAVD, 10% of the time it will be ejaculatory duct obstruction. Fructose negative, low volume, acidic pH is obstructive azoospermia. If it is fructose positive, it can be obstructive, it can be non-obstructive. For that, we need to see FSH, LH, testosterone, and we need to see testicular volume also. If it is obstructive azoospermia, FSH, LH, testosterone will be in normal range, while in case of non-obstructive, FSH will be high, LH will be high, and testosterone will be low or low to normal. For obstructive azoospermia, retrieval technique PISA and TISA is indicated, while for non-obstructive azoospermia, testicular sperm aspiration, like fine needle aspiration, it is success rate is like 15-20% only actually. And ideal technique for the sperm retrieval in case of non-obstructive azoospermia is microtessive. So in the era in the today's era, while we give so much of importance to the female, we should give little importance to the evaluating a male partner also. Thank you.
Thanks a lot, sir.
Thank you.
Thanks a lot for your great
Thank you.
endeavor. You had prepared a very good lecture, throwing every fine detail to such an ignored topic. We usually have so many male infertility patients, but we are not able to judge the condition properly and give the proper treatment to the patient. But now we have a very great insight on this topic, and we'll be able to treat our patients better after your lecture.
Thank you.
So now I invite the chairpersons for their comment on that topic of sir, and audience if they have any questions related to this topic to sir.
Give good information about male infertility. Today's era, almost we have neglect male infertility. So give good. Give good information about male infertility.
So informative lecture, Dr. Sagar. We are almost neglecting male infertile patient, but today we got so much information. Thank you.
Treatment HCG is there. But what is your experience on giving letrozole?
Frankly speaking, hypo? It will not work for letrozole, will not work. હવે પેરિફરીમાં સાહેબ પ્રોબ્લેમ શું થાય છે ખબર છે? Once we'll start give HCG ના, patient sexual desire will increase. And patient name કે બધું normal થઈ ગયું. And he will not turn up. Actually, spermatogenesis will start after adding up HMG or FSH.
And what about clomiphene?
It will not work because pituitary is shut down.
So in varicocele patients, does the surgery improve the sperm count? Is it like a permanent increase in the sperm count? That we operate a patient with varicocele, because many patients they come to us and they say varicocele and it is operable. So they think if we get the operation done for varicocele, the count is going to increase. So what is actually the practical thing which you are noticing in such patients?
Frankly speaking, I'm very judicious about advising surgery for varicocele because many of patients will get operated, they'll come with the decreased parameters. One of my patients has almost like 15 to 18 million count, almost 20% motility. Someone has advised varicocelectomy, then he came up with like 1 million or 2 million. I don't remember exactly, but it should be judiciously advised. If it is altered parameter like low moderate oligospermia, normal volume, very little high FSH of like 8 to 10. It should not be 15. If it is 15, then testicular volume will also be less. Okay, in those cases only we should advise varicocelectomy.
But the Euro people are telling that it will 40% is the result. Grade 3 varicocele, if it is getting operated.
Depend upon grades of varicocele.
But grade 2, grade 3 surgery, vaginectomy has accident.
Grade 2, grade 3 should.
Eventually or by IVF. Within 6 months. Yeah. Yes.
Within
So
6
it has
months.
better effect. In our
હા એટલે એવા કેસમાં એટલે આયુ ઘણીવાર શું છે કે માઇલ્ડ ઓલિગોસ્પર્મિયામાં લોકો એડવાઇસ કરી દે છે ને
But
એ ઇટ
because
શુડ
the
નોટ
grade is not been seen. If you have done a good Doppler,
હા
the flow study has been done,
હા
and if it is operated by a
Good
good
urologist,
urologist,
then it will improve.
High
हाँ,
dilation
हाँ.
will be much better.
हाँ.
Excellent result. You are rightly said,
हाँ.
grade 3/4 mortality is doesn't give result.
Hmm.
But it is really you should advise.
Yes,
Really.
yes.
Grade two,
Excellent
grade
result.
three.
Because some the
And
spots are
left
improved.
side one.
And
हाँ.
we can
Left
say
one.
for vaccine.
Left has
Left
better.
one, in grade 3, grade 4, at a nice neurosurgeon operates, like certain high grade ligation is done, then the count is really improving.
Adding of the letrozole in the male prescription reduces the libido some of the times.
हाँ.
Yeah.
That also
Sometime
needs to be addressed properly.
it will be estrogen will go down because of so ultimately it will lead to sexual dysfunction.
Anti-estrogen.
But patients have come with decreased libido, erectile dysfunctions and many other things very frequently.
એટલે અલ્ટરનેટ ડિસાઇડ કરી નાખશો ને તો સિમ્પટમ્સ ઘટી જશે. હા
Basically, the regime what they say is alternate day or letrozole and alternate day clomiphene 25. One day
हाँ.
clomiphene, one day letrozole.
हाँ.
So that you
એવું
give
પણ
for 1
કરે
month
છે.
therapy. But how much it is increasing or how much it is.
આઈ હેવ નેવર કમ્બાઇન્ડ લિટોઝોલ. હા કરી શકે.
Hormonal is the issue. That's why actually they're claiming.
હા
In what type of what type of oligospermic male we should advise the DNA fragmentation?
DNA fragmentation should be advised in case of recurrent implantation failure or recurrent pregnancy loss. Okay, if it is multiple IUI failures, હવે ઘણા લોકો છે ને તે if it is available, patient is ready to spend, people do it before starting IUI treatment also. હવે એનો ultimately interpretation is more important, slide preparation is more important rather than just giving
So
DA.
DNA fragmentation sometimes might be pathological or
Ah.
sometimes are physiological.
Physiological.
So there is a long abstinence,
Ah.
then the damage sperm will be more.
More.
So by reducing the abstinence, reducing the abstinence, frequent ejaculation can
It will help.
cure the physiological DNA fragmentation. And DNA fragmentation is basically DNA damage by free radicals.
Yes.
The antioxidants will and lifestyle modification will definitely work.
Yes. Thank you.
So after this great insightful lecture, we come to our second speaker. I invite the young and dynamic Dr. Himangiba Zala for her next topic. She will be speaking on recent trends on obstetric color Doppler.
Good morning everyone, I am Dr. Himangini and today I am going to talk on changing concepts in obstetric Doppler. So initially we used to use Doppler whenever we suspected FGR or in early pregnancy to see fetal heart rate. But now the use of Doppler has been seen in each and every trimester and it's very useful in different ways. Starting from the first trimester, that is the NT scan. First, we do the most important, that is the uterine artery Doppler, because it is the best screening test for suspecting preeclampsia and FGR. Combining the uterine artery Doppler with the patient's BMI, and if we are doing the double marker test, adding the PAPE report, with that increases the sensitivity of the test. Especially when we do the double marker, we should keep a habit of seeing the MOM values of beta HCG and PAPI. When the PAPI value is less than 1 MOM, then definitely that patient is going to end up with fetal growth restriction, especially when it is less than zero point 0.5 or zero point 0.5. So it is a very great tool. Other thing, when the PAPE is zero point 0.5 and beta HCG is more than 2, then that baby has a very high risk for chromosomal abnormalities. So the MOM values in the double marker test are very much important. Not just looking the low risk or high risk is important. Okay, so whenever we suspect that there is high risk for this patient to go into preeclampsia or fetal growth restriction, we start with aspirin 150 mg at bedtime. Also, this is very important in predicting the severe growth restricted fetuses than the mild growth restricted fetuses. Second one is the ductus venosus. I know ductus venosus is very difficult task to take because this small baby is very moving, especially when we keep pressure on it, it just jumps. But when the baby is not moving, just take a sagittal section of the baby, and then the continuation of the umbilical to the right atrium of the heart, the aliasing part is the ductus venosus. Why it is aliasing? Because the umbilical vein is very much dilated, and then when it bifurcates and it just forms the ductus venosus, it has a very narrow lumen, and that's why the aliasing is created. So why the ductus venosus is important? Because it is one of the marker in chromosomal abnormality assessment. Second one, ductus venosus is providing 80% of the oxygenated blood flow from the umbilical vein to the heart. So whenever there is any high resistance or there is absent or reversal in the A wave of ductus venosus, there is a possibility of a baby forming congenital heart disease or going into fetal growth restrictions or abnormality of the venous system, especially when there is ductus venosus agenesis. There is very much chances that baby is going to form abnormalities in the venous system, especially the portal one. So in these babies, early echo fetus is suggested at 16 weeks. Third one in anti-scan is the tricuspid regurgitation. We take it by spectral Doppler by keeping a wide gate, one in the right atrium and other one in the right ventricle. The angle is very important. We can't keep the heart like in 2 o'clock or 3 o'clock position and then we keep the gate. The heart has to be in apical position or in the basal position so that the angle correction is correct. Otherwise, the whole regurgitation flow which we are measuring will be incorrect. When the tricuspid regurgitation is more than 100 centimeter per second, then that baby can have some type of congenital heart disease, or and also it is an important marker in chromosomal risk assessment. So in these fetuses also early echo is suggested at 16 weeks. So we can diagnose any type of congenital heart disease which are developing in the fetus very early, and decisions can be made accordingly. So this is all about first trimester. Then comes the second trimester. Of course, uterine artery is also important in second trimester because it helps in comparison of the uterine artery PI trending, which we had taken in the first trimester. Is there any effect of aspirin on it going on, or other changes can be seen? Also, whenever in like low socioeconomic community, when the anti-scan is not done, uterine artery PI helps us in diagnosing fetal growth restriction or the preeclampsia. Of course, we can't prevent it afterwards, but at least we can keep them in close vigilance that these are to be seen in the late second and third trimester for these things. Also, whenever the uterine artery resistance is very high in second trimester, that lady is going to land up with oligohydramnios. We have not thought of that because we thought of other reasons like there must be leaking or something else. But yes, uterine artery high resistance can lead to oligohydramnios. Second one is ductus, of course, because some type of congenital heart disease, especially the right side ones like right side tricuspid regurgitation or stenosis or anything else, can form an abnormal ductus venosus. I had one patient which had fetal bradycardia, in that I was getting reversal of A wave. The first thought came to my mind was that patient must be in like a growth restriction, maybe the fetus is going into acidosis. But after detailed examination of that baby, the diagnosis came out to be fetal bradycardia, which was forming the abnormal ductus. So the ductus is not just important for fetal growth restriction fetuses delivery purpose, but it is also important for some type of congenital heart disease, because it is an indirect sign for it. Uh, Now, the other one which we do in the anomaly scan is the cardiac analysis. So, in cardiac analysis, not analysis of the heart is not just to be done by 2D. The color is very, very much important. So, 2D and color is to be done simultaneously. Reasons: first of all, the pulmonary artery insertion into the left atrium cannot be seen alone with 2D, because sometimes we get fatty patients, sometimes the vision is not clear and all that. So color is very helpful in seeing that insertion. So, the other one is the septal defects. When the septal defects are very small, less than 3 it can be missed with just 2D. So like I've seen given in the picture, this was a very small 2.5 defect. So most of the time, this small defect gets closed automatically after the fetus is born. But there are possibilities that this defect can enlarge with the gestational age and land up into a large defect. So we can't miss that. The third thing is regurgitation. So whenever we are seeing the heart in color, we see opposite flows in the one going to the right atrium, from the atrium to the ventricles, other from the ventricles to the atrium. When the opposite flow is more than the ingoing flow, there is definitely regurgitation there, and then we can measure it with spectral Doppler. If we have not seen it with color, then initially, like in 18-20 weeks pregnancy, the ventricle and atrium size would look equal in both the sides, but with advancing gestation the size will differ. So seeing the color is very, very much important. Other thing, stenosis. In stenosis, in like I said, in early like 18-20 weeks, the vessel size will not be very small as expected to be in last trimester. So in stenosis, when the flow is going, there will be aliasing because of that narrow lumen, and that will click our mind that there is something wrong and we should look at detailedly. So for heart, color is very, very, very important. The other thing are, we generally use it to see the cord around neck or false knot in the umbilical cord. Also to diagnose vasa previa, in for documentation and detection of the renal vessels, because sometimes when the vision is not clear or when there is very fatty patient, sometimes renal kidney can be missed, because sometimes the intestinal loops are adjusted so well that it can predict like it is a kidney. But when the gestation advances, the proper shape of the kidney is not seen, and then we go back and see the anomaly scan, we come to think, yes, it was not actually kidney, but it was just the intestinal loop. So by seeing the renal artery bifurcation and documenting in color is cherry on the top. You can save yourself from misdiagnosing anything. Also, in duplex kidneys, its bifurcation is different. In horseshoe kidneys, the renal vessels are bifurcating differently than it appears in normal. Also, whenever there is an intracranial cyst which is diagnosed, you can differentiate the cyst from AV fistulas, because AV fistulas color will be seen within the cyst, but in normal cyst the color would not be seen. So many diagnoses can be differentiated. Color helps in differentiating the things like this. Also, it will help in diagnosing corpus callosum agenesis, partial or complete. Also, when there is diaphragmatic hernia of right-sided, it will help in diagnosis the content of the herniating thing. Also, in abnormalities like left isomerism, aorta and one more vessel will be seen parallel to the aorta. Generally, IVC is not parallel to aorta either in the axial view nor in the sagittal view. But in isomerism, left isomerism, one more vessel will be parallel to aorta, and it can be seen both in axial and sagittal view, and that vessel is azygous, which is doing work of IVC. Also, in sacrococcygeal teratoma, as I told, the color flow helps in diagnosing teratoma, which is highly vascularized from meningocele. So, in many more like fetal abnormalities, color is much more helpful in coming to the diagnosis. Third thing, in second trimester, umbilical and MCA is like not 100% compulsory to take. If you have taken, it would be helpful in third trimester, but it is not compulsory. Only in two matters you have to take it. First, when you are suspecting early IUGR, and the second one, when you are suspecting fetal anemia, you should take MCA, because PSV value, which is given on the top of the MCA, it is very helpful in diagnosing fetal anemia. When the MCA PSV value is more than the double the gestational age, then that baby is definitely having fetal anemia, and you can calculate it by going on FMF site. Okay, so most common are like RH incompatibility and fetal infections, which can lead to fetal anemia. The rarest one which I have seen is ABO incompatibility, and it was diagnosed at 32 weeks. Because I had an habit of seeing MCA PSV each and every time, I was able to diagnose it, and that baby was saved from NICU admission and going into phototherapy and all that. Of course, that babies, APO incompatibility babies, would not require blood exchange like RH incompatible ones. But yes, of course, they would need phototherapy because of increased bilirubin. So that baby was saved. So looking for MCA PSV each and every time is very, very much helpful. Now coming to the third trimester, uterine artery, yes, of course, in third trimester also, because it is of very low resistance in third trimester. Also, sometimes the uterine artery is normal in second trimester and first trimester, but its PI increases in third trimester. So that can indicate that fetus is going to go in late FGR. The other one is umbilical. Umbilical has to be taken in free loop, because the umbilical artery resistance is high near the fetal and low near the placental end. Only in cases of multiple pregnancies, the umbilical is measured at the fetal end of the cord. Angle correction is not much of importance, because we don't look at the velocities. Yes, velocity is of importance in uterine and MCA. Whenever we take uterine, if the MCA velocity is less than 60, then you are taking the wrong vessel, because uterine velocity is always more than 60. So whenever you take uterine, just see the velocity. If it is less than 60, then you have taken the wrong vessel, or either the angle is the wrong. Okay, so that is one more good thing. Second, umbilical artery and MCA alone are of not much importance. I'll talk about that later. Like I said, middle cerebral artery, it is taken at the axial view of the transthalamic plane. We switch on the color Doppler, and the vessel going anteriorly towards the cranium is the middle cerebral artery. The angle correction is very much important, because it will change the PSV value. PI value is never changed by angle correction, and that's why the PI value is very much important, but the PSV value will change with angle correction. So angle correction is very much important in uterine and in MCA. Coming to the CPR ratio, CPR ratio is the cerebral placental ratio, that is the MCA PI value divided by the umbilical PI value. If it is more than 1, then the fetus is still not in hypoxia. That's why MCA and umbilical alone are of not much importance in deciding the delivery of the baby. The fetal hypoxia is whenever the CPR is more than 1, we can still wait for the fetus to achieve a gestational age, and we can still extend the pregnancies. But if we have reached the gestation like 37 weeks, at least we have reached that gestation, we should not just put baby into that high risk. The other one is ductus venosus. So, why is ductus venosus very much important? Because in severe hypoxia, there will be redistribution of the umbilical venous blood flow towards the ductus at the expense of the hepatic blood flow. So whenever there will be normal venous flow, whenever there is fetal hypoxia, but still there is normal flow in ductus, then it indicates that the fetal compensation is still going on. The fetus is still, it can be extended, especially when in preterm babies. But when there is abnormal flow in hepatic artery, that is very high resistance or absent or reversal in A wave, then it indicates that the hemodynamic compensation has broke down. So that baby needs to be considered for delivery, depending on the steroid coverage is given or not. Whenever there is high resistance in ductus, you need to keep that baby into close monitoring, like you call her in a day or two or something. But if there is absent or reversal in ductus, just deliver the baby, give her the steroids and just deliver the baby, because the fetus is in acidemia. One more thing I forgot to tell, we have to keep, whenever we are suspecting fetal growth restriction, just take a habit of writing down the umbilical and MCA and ductus PI values in your notes, because if you have to keep a measurement trend, because sometimes what happens that the fetus is in hypoxia, MCA PI trend is going down, 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 but still the CPR is normal. But sometimes what happens that suddenly one day the PI value of MCA goes high. So we get happy, wow, we can still extend the pregnancy, but actually no. The fetus has developed cerebral edema, which is causing compression on the vessel, and that's why the PI value is getting high. So in a downward trend and again the upward trend, actually we don't have to get happy. Fetus is in acidemia, just take that baby out. Okay, so that's why keeping a trend on PI values is very much important, because we can't get the patient to get her Doppler again and again. It's not affording. But if we know how to take Doppler correctly, we are keeping that trend. It would be very helpful in that fetus survival. Uh, okay. Now in twins Doppler, like in dichorionic twins, the Doppler is just kept in trend like a singleton pregnancies. But in monochorionic, yes, dichorionic twin, Doppler should be done every month. And in monochorionic twin, Doppler should be done every 15 days, unless and until any abnormality is suspected. Okay, so like in twin to twin transfusion, the umbilical artery PI will be high in both the donor and the recipient. In donor, because there is abnormal placental development, and in recipient, because of the polyhydramnios related compressions. The MCA PSV will be high in donor, and PI will be reduced in the recipient. And the ductus venosus PI would be high in both. The other thing that will be seen is the flow velocity across the AV valves in donor will be reduced, but there will be regurgitation, tricuspid regurgitation seen in the recipient. So Doppler is very, very much helpful in twin to twin transfusion syndrome. Last one, the postpartum pregnancies. It is Doppler is not much helpful in postpartum pregnancies, because the most common thing seen in postpartum is oligo, because of decreased renal perfusion, and it may lead to non-reactive fetal heart rate, which lead to subclinical hypoxia. And because of that hypoxia, there can be seen a low resistance in the umbilical, which is the only thing which can be seen in Doppler, but it is not much helpful in taking the decisions for the delivery of the fetus. Last one, the diabetes. The IOD cannot be prevented by Doppler, because the Doppler findings and the sudden IOD of the fetus has no correlation. Even if you would have seen the fetus just a day prior to her IOD, the Doppler would be have normal. So like gestational diabetes, Doppler is of not much use. Thank you so much. I hope you will take Doppler measurements in your notes each and every time when you suspect abnormalities. Thank you.
Any prediction of meconium stent lacquer through Doppler or anything?
No, sir. It would be normal. It would be normal.
Whenever we see echogenic lacquer, so when should we interpret with the tremiclosis?
Sir, we have to reduce the gain.
Gapchi hai, gapchi. Gapchi hai. ऐसा ecogenic, whenever there is so many times I've seen
Ecogenic lighter is
ecogenic
usually
lighter,
normal.
and we keep on monitoring
It
patient
is
and when we
Lanugo
rupture the
actually.
membrane, it is clear.
It is Lanugo.
It is
When I
because of
saw-
work
yeah.
experience.
Yes, yes.
What I want,
One ex-
what I want to ask, whenever we see ecogenic lighter, what other parameter we should watch?
Okay.
Sir, whenever there is ecogenic liquor, you just reduce the gain. If it is vernix, then it will be of black color. But if even on that it is not gone, then it can be meconium. And other thing, meconium would not be like splitted like tinka everywhere in the flow. It would be in clumps. So that way you
Fetal,
can.
like fetal Doppler approach.
No, 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 of course.
No, not Doppler. But fetal movement, fetal breathing movement, that we need to monitor every day. Like in the, it could be meconium. We cannot anticipate meconium by ultrasound only. But we can
Yes.
suspect at least.
Yes, yes.
Is there any role of NST in the era of
No, yes.
Well, it is, but how many do you have NST?
આપણે છે ને મારો personal experience,
You have, but
NST ના ultrasound મારો experience. એટલે બધા for example આપણે 2, 3, 4 કે 5 મિનિટ ડ્રોપ મૂકી રાખો અને તમે ખાલી લાઇકર અમાઉન્ટ જો
Exactly.
બેબીની મૂવમેન્ટ જો
હા.
એને એની બ્રીથિંગ મૂવમેન્ટ જો
હા.
you will come to know exact environment around the fetus.
yes.
Does LICAR has any role in planning the time of delivery?
It will
Yes, ma'am, because LICAR provides the nutrition to the fetus. Also, it prevents the fetus from the uterus compression.
No, no. What my question is, if suppose there is specific, is there any specific guideline? This amount of LICAR you should take out the baby.
No, 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 no. There is not.
There is no
No,
guideline.
no, no.
This amount of
It's
LICAR
not
you should
an
take out.
indication.
No, no, no.
there is a lot of
Clinic-
controversy regarding improvement of LICAR.
Yes.
Whoever agrees that LICAR can be improved.
I have improved, sir, I have improved LICAR by amnio infusion. But
Nowadays they are saying no to
We
amnio.
give
yes, they are saying.
The studies have been no to
If
amnio.
we monitor daily, what
Because I
we
had a
get,
patient,
many times
was
exercising,
and I asked the fetal medicine experts, she was 26 week IVF conceived, and I wanted to ask, give her amnio infusion so that I can pull on the pregnancy. But I asked 2-3 fetal medicine experts and they say that amnio infusion now we are not doing. It has no role.
Yeah, because the risk of getting aborted is very high in amnio infusion. So most of them are not doing. But yes, you can do one thing. You can improve the LICAR, but not to a normal range. Like you are having MVP 1.5, you can improve it to 3 or 4. That you can extend the pregnancy at least like 30 weeks or something.
What are the
But
drugs generally we give to increase the LICAR?
ma'am, actually we don't suggest. Fetal medicine experts are against that, but maybe some have seen results. You can give whatever you are using, but actually fetal medicine experts are against this. They tell that it is of no use in improving LICAR, because reduced LICAR has some or the other reasons behind it. Either uterine artery is increased, or the maternal infection, or leaking or something. So you have to find the cause and treat that patient like accordingly. If the cause is not treated, then it is of no importance.
Look for kidneys and all.
Yes,
But if the kidneys is normal, we are not finding any cause in water.
the structure can be normal, but
That is
we.
idiopathic.
I had a very unusual case many years back. Patient was having severe IOG, severe oligomeals. I did torch titer. It was very high. IgM,
Yes.
IgG, everything high. And I supplemented spiramycin and monitored weekly. The growth improved and LICAR also improved.
Yes, yes,
Definitely.
of course.
LICAR also
Maybe
improved.
that
Yes.
can help us.
Only in things when you can't find the cause, we can do amnio infusion. Otherwise, the first thing is to find the cause and treat accordingly. And wait, because reduced LICAR will never lead to IUD or any type of fetal compromises. Of course, when the reduced LICAR is extended very much long, it can lead to umbilical cord compression. Otherwise, nothing.
Achha, one more question I had, ki in this era of NIPT, what is the role of double marker in first trimester? Should
It
we
gives-
do double marker in all the patients?
Two things. First, it is affording. And second thing, it gives the MOM values. Like I said, PAP-A and beta-HCG MOM values. Whenever you are doing NIPT, you can't get that MOM value. So preeclampsia and FGR, you can't suspect. The other thing, if you are getting a high risk of something in NIPT, you have to do confirmatory test. And there are few cases in which there was high risk in NIPT, but the like KT or chromosomal microarray came to be normal. So double cost, high cost things.
That is why I'm asking you ki, like first trimester we did anti-scan is normal. So should we prescribe this double marker to all our patients? Suppose patient is affording. So should we prescribe double marker to the patient?
Yes.
And again in NIPT, if at all patient is
No,
affording.
if double marker, if double
If he is
marker,
affording, prescribe both.
Assurance for patient as well as doctor.
Doctor.
કેમ કે અમુક
Just to
લોકો
keep
આવે છે એના માટે
ourselves
આપણે
safe.
પૈસા ખર્ચ કરાવો.
In the range of low risk, then it would be reassuring for both.
Maybe
Just, she already said that to predict if uterine artery, suppose uterine artery with double marker, that chances of IUI and taking, you can predict it.
If Pepe mom is less than 0.4, no? I think
less than 0.5.
0.5.
Less than 1, high risk, but less like 0.5 or less than it, then that definitely
Prediction
is
of,
going to be
platelets.
No,
yes,
I
FGR.
agree with this, and I really like this concept. Ki we should see the MM value
Yes.
and we should see the pattern.
Yes,
So that
yes,
means ki
right.
we should do double marker to
Yes,
all our patients.
yes.
Yes.
Because
The confusion is ki we should do
But
double
yes,
marker.
yes.
At
Lot
least
of
should be
times
a
there is
uterine
in
artery
anti-scan,
चाहिए,
there is a
mean
slight
arterial
peaking
blood
of
pressure
ductal
of patient.
thickness.
आप
But
भी
if you go
parameter
for
ऊपर
double
भी
marker,
prediction
it comes
चालू
as
करते हैं।
negative. Screen is
No,
negative.
if it is like screen
Huh.
positive, then it is a different case.
Huh.
But suppose the NT scan is normal, and then should we advise double marker to
Yes,
all
ma'am.
our patients?
Yes, yes. Because the combination of both gives a sensitivity of 70 to 80%. Yes, NIPT has much more sensitivity value, but at the same time, it doesn't give these values to us, and also it is a like a giving us risk, not the confirmation.
Biochemical investigation.
So it is better to take these two tests, and if there is a high risk in like double marker and NT combined, we
Then
can
we
go
can-
directly to confirmative test rather going to NIPT.
So when should we do NIPT?
Patient
NIPT
जिसमें पैसे
can be
होंगे,
done and
when patient has money in his pocket, then NIPT.
Ma'am, when you had a patient with a history of trisomy 21, or if by NT scan you are getting some factors like there is enlarged NT or there is an
Some
hypoplastic
screen positive, whatever,
lesion.
huh, screen
Yes,
positive.
then you, and if the patient has a pocket, then you can advise that patient NIPT.
One more question I had. See, in the case of so we have time.
Yes, lot of time.
This therapy is for you only.
Actually, we wait for this purpose only.
In a patient with absence of ductors, then what should we do? Should we wait to give the patient a steroid coverage, then we should take out the baby, or we should take out the baby anyways the steroid is given or not?
No, we should give steroid and then deliver the
Can we
baby.
wait for 2 days to, if the ductus is absent?
Like one day, we can give the betanzole in one day, 12 hours apart, and whatever the effect of it is there, but at least in a day we have to take that baby out, because baby is already in acidosis. The chances of survival of the baby are like 50-50%. So we can take a chance that we'll wait for the betanzole coverage and then let the baby come out. So whatever we can prevent is helpful.
But in today's scenario, when NICU are developed, we
Ah,
can
I
even
see.
take a chance to take out other
But
things.
actually તો હું એવું કહીશ કે છે ને જો બહુ જ પ્રીટમ ના હોય ને લાઈક 25-26 વીક્સ તો છે ને એસિડોસિસ માટે વેઇટ પણ નહીં કરવાનું. Whenever the baby is in hypoxia, steroid coverage આપો ને કાઢી લો, because the neonatologist will like hypoxia than acidosis, because survival is very much.
They usually tell
Every
that
neonatologist used to tell.
એ જે theoretical thing છે કે ના ડક્ટસ બગડે ત્યાં
એટલે
સુધી
આ કેવું,
ખેંચવાનું,
બેટના
actually
તો આપણા
practical is
દિમાગમાં એવા
not
નાખેલા
working.
છે ને કે આપણને એમ થાય કે આપી જ દેવાનું.
હા
ડાયાબિટીક મધરમાં કોઈ સિનેરિયો અલગ હોય છે?
ના સર, ડાયાબિટીકમાં ડોપલર હેલ્પફુલ નથી.
હા.
ડોપલર બિલકુલ હેલ્પફુલ નથી.
ડાયાબિટીકમાં રોજ કોઈ ઉછાળવા.
સડન આયોડિન થઈ શકે.
કેટલા છે ડોક્ટર નોર્મલ?
यस એટલે ડાયાબિટીકમાં ડોપલર ઇઝ નોટ મચ.
So at least में हम कुछ कर सकते हैं कि हम IOD ना हो उसके लिए कुछ कर
नहीं,
सकते
कुछ नहीं कर
हैं?
सकते।
એના માટે
आज डॉपलर किया, कल देखा तो IUI था।
से मतलब एक-
કંટ્રોલ
ડાયાબિટીક
ડિલિવરી કરવા ડાયાબિટીસમાં કાંઈ
હા
32 weeks
It is
के बाद
regarding
37,
control.
38 weeks.
અને Uncontrolled.
Uncontrolled ठीक है, but if it is
हाँ.
controlled, then
Control.
also there is control.
Yes.
આટલા બધા incident આવે છે, control તો થઈ જ
Sir,
જાય.
hypoglycemia is
For
more
diabetic,
deleterious than
everything is
hypertension.
unpredictable. Even if it is
IUD,
controlled,
hypo
just
the
wait
latest
for
time.
37 to 38 weeks for female to go into labor. Otherwise, induce her or just do LSCS, whatever you like, whatever is your habit. But I'll not suggest it extending after 38 weeks because Doppler is unpredictable, has no value in actually diabetes.
And one last question.
ये मैडम थर्ड लास्ट है.
ના, આપણે ઘણો time છે આપણી પાસે.
अरे CM is all fans होती थी मतलब इधर है वैसे लोग बड़ा बड़े
हाँ, मजा आवे.
मजा आवे.
એની કરવાય કે
कि जैसे आपने बोला कि फर्स्ट ट्राइमेस्टर एमटी में देयर आर सम reversal tricuspid regurgitation and we are suspecting some fetal cardiac problems. So what is the earliest time we can send a patient for fetal echo?
16 weeks.
16 weeks. 16 weeks में ऐसे तो बोलते हैं
नहीं, नहीं.
20-25
લોકો accept જ નથી કરતા
Fetal
मैडम.
medicine
આપણે
people
તો
tell.
પગાડી દે છે.
A follow up after 4 weeks for reassessment for 2DA4. That is the standard statement written.
मैंने पूछा है क्योंकि वो
Standard statement.
हमें तो मैडम भगा देते गांधीधाम में. 20 weeks पे भगा देते कि अभी fetal echo नहीं होता.
Fetal actually sir ideal fetal echo 22 weeks 24 weeks બરાબર એ થાય છે બીકોઝ ત્યારે બધું જોવું બહુ ઇઝી એસ્પેશિયલી ધ વાલ્સની જે મુવમેન્ટ એ બધું હોય છે ને એ બહુ પહેલાં જોવું બહુ જ અઘરું હોય છે એટલે 20 to 24 વીક્સ પર ફીટલ ઇકો બહુ જ સારો થાય પણ એટલીસ્ટ 16 વીક્સે આપણે જોયું તો બેઝિક એબનોર્માલિટીઝ આપણને ખબર પડી
તો
જાય
મેડમ fetal medicine expert should make a habit કે 16 ઉપર પેશન્ટ આવે ને તો એટલીસ્ટ એક્સેપ્ટ કરી લે. એ સ્ટાર્ટ રિપોર્ટિંગ કે ભાઈ આ અર્લી છે હું તને 4 અઠવાડિયા પછી ફરીથી બોલાવીશ હું તને ફરીથી બોલાવીશ. ના ના એ લોકોએ કહેવાનું કે પૈસા નહીં લો ખાલી 4 અઠવાડિયા આવજો ચેકઅપ કરાવી દેજો શું વાંધો નહીં.
ના બરાબર છે
પછી જે પેશન્ટ એવું થાય કે આપણે ગાયનેકોલોજિસ્ટને ખબર નથી પડતી
એક્ઝેક્ટલી સાવ સાચી વાત છે.
તો અત્યારે recently any change in the trends of choice of steroids for lung insurance અત્યારે હાલમાં મારા pediatrician એવું કહેતા હતા.
एग्जाम
એ લોકો હવે એક્ઝામ પર શિફ્ટ થયા.
છેલ્લા જે ડેટ્રીઝોલ આવે છે ને એમાં છેલ્લા 1 વર્ષમાં કે છેલ્લા 10 વર્ષમાં સસ્પેક્ટેડ નથી આપવા પડ્યા ને એટલે છેલ્લા 1 વર્ષમાં આપવા પડ્યા. એટલે અત્યારે એવું છે એઝોપ્લાવ જે બેટનેઝોલનો સોલ્ટ કયો આવે છે એ અત્યારે નથી આવતો. બેટનેઝોલ નથી આવતો.
Betnesol available in India is phosphate, but in foreign it is a short acting. So they require phosphate and sulfate is there, so it is a long acting. So Betnesol is the ideal drug, but Betnesol is not available in India. So now they switch over to the Dexona. So it is 12 hours. You see, this is a newer one.
છેલ્લા 1 વર્ષમાં આ
6 kg पहला दफा
टेक्सोना हम लोग पहले रेसिडेंसी में देते थे फिर टेक्सोना बंद करा दिया बेटे
Yes.
પ્રાઇવેટ માં બધાને બેસ્ટ અપાઉન્ટ.
Either is salt is not available.
It is phosphate. Sulfate should be kept. So it is a long acting.
આપણે એવું હોય તો
हम लोग पहले 12 hours में repeat करें.
સોસાયટીમાં આપણે રિલીઝ
विशेष माय बस है
Betnesol is a very good drug.
સોલ્ટ નથી મળતો.
આપણે નોટ કરી રાખીએ. સર આનો કઈ કોઈ ગાઈડલાઈન હોય ને તો આપણે થોડું સર્ચ કરીને સોસાયટીમાં બધાને
હા
આપીએ.
એટલે બેટનેઝોલ આવ્યું છે સાહેબ એગ્રી
and the role of magnesium sulfate in preterm
હા, એ
न्यूरोलॉजिकल માટે એ લોકો આપે
before 32 weeks
But its delivery should be within 24
24
hours.
hours.
yes you have to deliver
પોલીમેટ્રોલોજીમાં ટેપિંગ ક્યારે આવે
ગમે ત્યારે
કેટલી વખત મલ્ટિપલ ટાઈમ ટેપિંગ
હા મલ્ટિપલ ટાઈમ ટેપિંગ કરી શકીએ
શુડ ડુ ઓર વી શુડ નોટ
હા કરી શકો પણ હા એની પહેલા બેટનાઝોલ કવરેજ આપી દેવાનું બીકોઝ જેટલું એમનો ઇન્ફ્યુઝનના રિસ્ક છે એનાથી વધારે રિસ્ક છે પોલીમાં
एम्ब्रियल फ्यूजन का सच में मैम मैंने दो डॉक्टर्स को पूछा
मैंने-
मैं जस्ट रिव्यू से डोंट
मैंने फीटल मेडिसिन किया है हमारे सर भी नहीं करते हैं लेकिन
ટર્મ સાઇઝ દેવી
yes
હું શું કરું છું એને સાઈડ વાપરવાના ચાલુ કરવાના ડાયગ્લો અથવા તો ઇબ્યુપ્રોફેન એનાથી લાઇકર ધીમે ધીમે નોર્મલ થવા માંડે અને પેશન્ટનું ડિસ્કમ્ફર્ટ જતું રહેશે.
पोलीमर
પોલીમર હોય છે પણ કઈ નુકસાન નથી થતું. યુરિન મેન્ટેન નથી શકે. બ્રુફેન તો ટીડીએસ આપેલી પણ કોઈને હજી સુધી તકલીફ નથી.
16
Is it Brufen is a better drug or Brufen? What you will prefer?
સર બ્રુફેન ઇબ્યુપ્રોફેન
થેન્ક
ના
યુ
બાજી
હા
બેનો બેલર માર્કર એટલે ડિટેક્ટ થઈ શકે છે કે
ના
લેટર
થર્ડ ટ્રાઇમેસ્ટર
એનું કેવું પ્રોગ્નોસિસ કેવું છે
વેલ જો બહુ લેટ થયું હોય લાઈક જો 36-37 વીક્સે ડાયગ્નોઝ થયું હોય, હાઇડ્રોપ્સ ના થયું હોય તો એનું આઉટકમ સારું છે. પણ જો હાઇડ્રોપ્સ ફોર્મ થઈ ગયું હોય છે એને લીધે તો પછી જે એસોસિએટેડ કાર્ડિયક ને બધું ઇશ્યુ આવે છે એને લીધે પ્રોગ્નોસિસ નથી સારું હોતું એવું છે. એટલે મેઇનલી વેઇન ઓફ ગેલેનમાં કાર્ડિયોમેગાલી અને હાઇડ્રોપ્સ ના ડેવલપ થવું જોઈએ તો એનું પ્રોગ્નોસિસ સારું છે. પણ એનીવેઝ તમે એટલું લેટ ડાયગ્નોઝ થાય છે કે તમે કંઈ કરી જ નથી શકતા.
ઓપરેટિવમાં જવું પડતું હોય છે.
હા, ઓપરેટિવમાં જવું પડે.
100% હોય તો બી માઇલ હોય તો
હા, કારણ કે ઇન્ક્રીઝ જ થવાનું છે એવું છે. કદાચ તમે એના માટે અર્લી ડિલિવરી કરી પણ લો તો નહીં ઓપરેટ કરો તો વધવાનું છે. તો બેટર ટુ ઓપરેટ ઇટ ધેન ટુ વર્સન ધ બેબી.
One last question.
Yes, yes.
One
Sorry,
last
sorry.
question. Patient को आपके
I clapped very
patient
early.
हो तो कहाँ भी भेजें?
उसको हेमांगिनी को नहीं पूछना चाहिए. That you should ask the question to Mr. Sakti Singh rather than asking to him.
Patient आपके पास भेजना तो भेजेंगे कहाँ पे? That is
Very good.
I'll soon come to Kutch like in 2 years.
Very good, very good.
But
Bye, Semi.
till then,
Welcome to Bogs.
Thank you, Dr. Himangini, for such an insightful talk. We all enjoyed the talk, and it is really every time a pleasure. You give us talk; it is always a very pleasure. So now we invite our next speaker.
With the all advancement of new ultrasound machine, all the high-tech machines, diagnosis of ectopic pregnancy has become the earliest. Whatever during might help you to see an acute abdomen, in shock and all these cases have been reduced. So we'll proceed to our next topic, that is the conservative management of tubal ectopic pregnancy. For this, I like to invite our own Dr. Madhav. He's a young and dynamic surgeon, and he has got a great interest in laparoscopy. He's an undergraduate from Karad and postgraduate from Devangiri, and he is at present working for Dr. Hirani Hospital. That is his own setup. And plus to that, he has spread his wings to Africa also, Dar es Salaam, where he is a technical director in his New Life Hospital. And he has been treasurer to the Bhuj Obstetric Gynec Society. And we all know all his hard work for SOGOC 2021. He has been really a backbone of that. And he has been joint secretary for SOGOC 2021 and 22 also. And to add feather in his cap, he had got the first 3D Ascalep Einstein first in India and Asia for heads up. Over to Madhav.
Thank you so much.
Actually, I first met Madhav when he was in 9th standard.
Yes.
He was so small. At that time I had gone to Dr. Hirani and it was just Madhav was roaming in his hospital. That was my first meeting with Madhav, and now he is giving a lecture and I am anchoring it.
Wow. Truly, it's my pleasure for this all things. Definitely, after an intense lecture, first and second on male infertility by Dr. Sagar and on Doppler by Dr. Hemangini, my topic બહુ નાનો છે. બધાને ખબર ટ્યુબલ એટલે કાપી નાખવાનું બસ. remove the salpings, and in the era of IVF, major of the people prefer to go for salpingectomy. But let's brush up our MBBS and PG રેસિડેન્ટશીપ આપણે થોડુંક બ્રશઅપ કરી લઈએ કે થોડીક દવા પણ મળે છે જે સમૂરી બંધ થઈ ગઈ જે લોકો યુઝ જ નથી કરતા. There is something called methotrexate. There are something surgical procedures which people are not doing, thinking it's a very micro surgeries. But let's convert that micro into macro. So I'll just do it in brief. Approximately, we all know that ectopic has a very less incidence. There is only 1%, like 1 of our 100 patients are, we can see which are they are ectopic, and we know what is ectopic, that the usual implantation site of embryo is endometrium, but anything outside endometrium is, we consider it as ectopic. There are different names to ectopic depending on the site. But most of them ectopic, most of them are tubal ectopic pregnancies which continue to grow. It is very difficult to diagnose at early stage. Usually we come to know when either they grow into a rupture ectopic or the patient comes into a hypovolemic shock or something. So ectopic is defined as concept as implanting outside the endometrium. As I said, there are different implantation sites: tubal, ovarian, abdominal. 95% consists of tubal ectopic pregnancies, and tubals also we have ampulla, which are almost compromise of 73%. Isthmus has 12.5%, fimbrial has 11%, and interstitial have 2%, 2.6. So, is anybody, I just want to ask one question, other than tubal ectopic, has anybody encountered some, nowadays we have scar ectopic, other than scar ectopic like abdominal or ovarian, anybody is lucky to see, because these cases are once in lifetime cases which we usually, ovarian. Nice. Yeah. Abdominal is very rare, if anybody is. And sir is most luckiest gynec we can say, because it's might be once in a millennium case we can say.
16 weeks abdominal pregnancy and uterus was empty and there was a mass occupying all of the. Uterus clear cut dekha TDS માં અને ઉપર આખું pictures ને આખું બધું.
So, interesting to know what was the blood supply to that. It was directly from aorta?
It's a placenta and a peritoneum.
Okay.
Okay, did you remove the placenta?
Placenta.
Then did you give methotrexate after
I
that?
have seen the 8 months abdominal pregnancy.
Oh,
8
wow.
months abdominal pregnancy.
So how did you manage then later? Because these all cases I don't think we are.
There was no sonography.
Yes, exactly. That's it.
With the X-ray only.
Okay.
And it was at Dr. Pancholi Hospital. In Pancholi, I was diagnosed of Anjar.
Okay.
And when I have opened the abdomen, fetus came out from the abdomen.
Okay.
And the placenta was on the mesentery.
Okay.
Placenta was covering all over the mesentery.
Okay.
So we kept the placenta as such. We don't dissected it, and then we have ligated the cord, and we have left it.
And post delivery methotrexate, did you use?
Methotrexate given, antibiotic given, we take
Okay.
follow-up for 1 month.
Oh, great.
And second, I have seen the fundal corneal pregnancy.
Corneal pregnancy.
The corneal pregnancy was managed by conservative management of
Okay.
Akatrana patient.
Yes.
For 1 month follow-up, methotrexate is a medication, and color changes in the uterus by color Doppler by Dr. Hadia for at least 1.5 months.
Okay.
Then conservatively, patient was managed.
Wow.
And after 1 year, patient again became pregnant.
Yes. Definitely, conservative management is somewhere helping here and there. So the incident rate and the risk factors, we all know that in India, ectopic pregnancy incidence is around 1%, 0.9%. The major risk factors, as we all know, there are some congenital factors which can say that there is some partial stenosis or maybe tubal hypoplasia. Even previous ectopic pregnancies also leads to recurrence of ectopic pregnancies. Previous any PID infections or anything, or previous any tubal surgeries like tubal ligation is there and tubal recannulation is done. That surgeries also can lead even endometriosis for previous endometriosis, then leading to hydrosalpinx can also lead to that. Infertility, smoking, and any assisted conceptions like maybe IUI or IVF can. Initially, there was, I think, a scenario when you do IVF, just clip the salpinx and then go ahead to avoid ectopic, but nowadays I think that's not necessary. Then next comes why. But now, as we all know that the incidence of ectopic has raised. Maybe if you can see in past few days that in your OPD, initially when you were maybe 10-15 days previous, 10-15 years previously when we used to do, hardly we used to get ectopic. But nowadays, incidence has definitely increased, but the mortality or the morbidity rate of patient has decreased. So why? Why all this has happened? So we all know that because of, we just previous lecture that there was Doppler that high-end resolution machines and Doppler, we have great doctors. Due to them, due to early multimodal diagnosis, we have come down to decrease the morbidity in the patients. Early scanning, early ultrasound scannings, even the beta HCG levels. If beta HCG level is usually, we all know that the cutoff value is around 1000 to 1500 when we are able to see the gestational sac inside the intrauterine. But in that scenario, till 1500 we have to wait, we have to find. But in that scenario, sometimes we can predict when the beta HCG levels are slow rising, then we can predict some. Along with that, even serum progesterone level, they say that if you can get it done, if it is less than 5, can also give you some indication that it might be an ectopic pregnancy. Definitely the CBC levels, but that will only reflect when patient is into a rupture or tubal abortion. Then definitely we all know laparoscopy and laparotomy I think hardly would be doing, but laparoscopy is the gold standard for all these things. So all these combinations we can only do when patient again is in hemodynamically stable. If a patient comes in hypovolemic shock, we cannot do all these things. Then the laparoscopy or laparotomy, depending on surgeon, is the choice. So now let's directly jump to the management, the topic of mine, conservative management on tubal ectopic pregnancy. Usually we classify into medical and surgical, but I have classified into different way. Let's classify from now that it is a conservative or non-conservative. Non-conservative, you all know, salpingectomy ultimately is the gold standard treatment, but conservative management, we can again divide into medical and surgical. Medical and surgical, just because, as I said, there are many surgical procedures which still we can save the tubes. So let's start with conservative management, medical conservative management. We have different methods. Methotrexate, we all know, single dose, multi-dose with combination of folinic acid. And I was just going through some papers and publication which say methotrexate with mifepristone combination. I have never preferred till now, but if anybody has used in their practice, definitely can share their experience. And the surgical, there is something called salpingotomy or salpingostomy. I can just ask the residents who are sitting, do you know the meaning of, the only S is difference between the two. So anyone can say what is the difference? What is the difference between salpingotomy and salpingostomy? Yes, yeah. So we'll come to that. So let's, as I said, that when it is ruptured or you have pregnancy which has progressed till 6 weeks, or when the tubes doesn't, when you go laparoscopically and if you feel that tubes are not that worth saving, salpingectomy stands as a gold standard treatment for tubal ectopic. But when it comes to medical management, again precautiously selecting the patients. Patient first and foremost thing, patient should be hemodynamically stable. Beta HCG level should be less than 5,000. Adnexal mass should be less than 4 cm. This is one of the most important criteria which decides. If adnexal mass is more than 4 cm, usually the patient will end up into a rupture, or the tubes are mostly dilated, which are not worth saving. Absent cardiac activity, this is almost when you see for the cardiac activity, it would, before that patient would have landed up into rupture. And the hemoperitoneum less than 100 ml. Definitely आपको abdomen भरे हुए तो ना कराए. So let's start with first methotrexate single dose regimen, which I think almost everybody would be preferring nowadays, which is 50 milligram per one single shot IM without folinic acid. Just pre dose, you get the beta HCG level done, give the dose today, maybe 48 hours, repeat the beta HCG level. If the beta HCG level drops, the dropping trend starts, then it's but obvious that we are on the right track. Initially, the older method which was there, methotrexate, again multiple dose with folinic acid, they used to give injection on 0246 and adding folic acid tablets on 1357, or folinic acid injection used to come, which they used to add. If that is not available, you can give folic acid tablets also. As I said, methotrexate and mifepristone combination, they have preferred, there are studies which they have done, and they have seen that it gives equivalent results comparison to combination therapy of folinic acid. They used to give, there is one more, there is a single dose 600 mg of oral mifepristone with methotrexate. Along with that, even they used to give, I think 75 mg of injection, tablet, TID or BD, that is also one of the study which they have done. But again, single dose or multiple dose of mifepristone have the same effect. But we have never used in our practice. Anybody has used this combination past? Yeah. I think in India, maybe probably nobody use this thing. This was the medical management we preferred. Now let's come to the surgical and the definitive management. Even whether it is a ruptured or unruptured pregnancy, tubal ectopic, definitely this will going to help you. As I said, Only the S is different in the word salpingotomy and salpingostomy. Salpingotomy is usually is the one in which, if it is unruptured ectopic pregnancy, give an incisional incision to the tubal ectopic, remove the conception, product of conception, and resuture the tube. So that is salpingotomy. But some people, as I said, initially we used to think it is a microsurgery. Even after doing laparotomy, it is tubes are very small, it is very microsurgery. People prefer to leave it open. Whether if you give a small incision, they believe that the primary healing, secondary healing will help in maintaining the integrity of the tube, reducing the stenosis part, reducing the infection part, reducing the pregnancy rate. But that is not the scenario. Whether you do salpingotomy, salpingostomy, it's the same. But nowadays with laparoscopy era, as we said, salpingotomy is much preferable, much advisable, and much safer. So I have two cases to share with you in which one was unruptured ectopic pregnancy for what we did salpingotomy, and one for ruptured pregnancy we did salpingotomy. Ruptured pregnancy, we'll start with the ruptured tubal ectopic pregnancy. You can see this was the first instance when we went inside. Almost patient came in hypovolemic shock with hemogram of 6 HB, but still we prefer to do salpingostomy because, as we said, nowadays people are preferring to save that. Some people doesn't want to go for for IVF, they still prefer. And as we said, before going to salpingotomy, there are some few things which should we keep in mind. This is the tubal pregnancy, ruptured tubal pregnancy. You can see the whole tube is here. From this whole tube is destroyed. The down you can find out the fibria. Fibria was intact, but other than that, this whole part has got destroyed. Can you see? If you can appreciate well enough. So for salpingotomy, keep in mind that first, all consents should be taken. Patient should be informed, and like this is the fibria. This is the part from where it was ruptured. Fibria is down intact. So fibria was intact and ruptured, and the upper part fully was ruptured up to the whole almost 1/3 length of the tube was ruptured. So as I was saying, once you go inside with laparoscope, see the condition, how it is, and then explain the patient. This is the scenario. Even if we go for salpingotomy, save the tubes, these are the chances. The chances of repeat ectopic are higher when you go for salpingostomy. But when patient insists to save, again, it's patient's choice. So, repeat ectopic, then chances of, again the same situation, chances of infertility also, chances of hydrosalpinx, everything should be explained to patient. After finding out the completely cleaning the clots and everything, just clean the tube so that each and every product of conception, even the minute, are cleaned, and even the saline will help in stop the bleeding and also. So initially assess how the tube has been ruptured, how it is damaged. Then bits by bits you have to start taking. Again, as I said, it was a microsurgery. We are using Proline 50, which is almost thinner, almost equal to our hair follicle. So nowadays these microsurgeries are not that micro because we have macro instruments for that. We have magnifications which can even turn into a big thing. And again, laparoscopically, as we all know that it is, patient can be very well managed by anesthetist also, so that you have enough time to do that. So this was the how we sutured. It was totally in a zigzag manner which was ruptured. But again, even if we could have left it open in salpingostomy, I think we couldn't have achieved this much of healing. So this was the final picture. When you see the needle, that is the last gap near where I hold down, that is the fibria. So that even if we think, as I said, we have to inspect the properly, even if we might feel that inner structure looks like fibria, but that was not the thing. If you maintain the integrity of the tube, then it is the healing helps better. Then after this, we have one more case which was unruptured ectopic. This is one more case. there are, if you can see, there are bilateral ectopic. This was diagnosed on ultrasound and we thought it was a ruptured ectopic, so we took it, but it was rupture. It was about to verge on rupture, but more of a tubal abortion. But if you can see here on the other tube also, there is a small gestation which is developing. So again, as I said, bilateral ectopic, I don't know how many have encountered. One sec, charger.
Meanwhile, if in audience anybody has any questions, they can continue with the question.
As Madhav said, that a rise in the beta HCG level should decrease after 48 hours. But ample times I have seen that it is not decreasing. Initially for 3 days, at least 4 days it rises, and from the 5th day it decreases. So that 48 hours is a query. So we should not just jump. We have to wait. If the patient's condition is normal, you can wait and you keep the patient well informed that in case of any emergency you can come. So that 48 hours, if there is no decrease in the beta HCG, don't haste. Just wait.
I agree with madam. Even on 4th day when you repeat the beta HCG, sometimes it is increased. What was the previous value? The patient, if patient is symptomatically okay, then you can just wait. You no need to give extra dose of methotrexate.
Usually you use a single dose methotrexate or multiple?
Single dose.
Single dose.
I use multiple.
No, we give single dose.
Single
Single
dose
dose
only,
generally
but
goes
it's
good.
if it is going to be okay, it's going to be okay. Single dose. If you are diagnosed early, single dose is ample.
But,
No,
Letrozole.
No, I have not used letrozole.
એવું નાગોરી સરને ત્યાં તો
Mifepristone
started
cervical
using
letrozole
letrozole
વાપરેલી.
and they don't do beta HCG at all. They just measured it with the help of color Doppler. Everything is by color Doppler.
Letrozole in how much?
5 milligram BD.
5 milligram BD for 5
At least 7 days.
7 days.
Letrozole we have not tried. We have tried the methotrexate only.
એ લોકો
Single dose
methotrexate નથી use કરતા. They have shifted to letrozole exclusively.
So for how many days?
5 days.
for
5 days.
Then you don't
નારે તો બી ને રહી જાય તો બી એમ.
હા.
then you don't repeat the beta HCG levels.
They monitor it with the help of color Doppler. Everything by color.
Monitoring important.
Hello.
So why to use this non-absorbable suture material over fallopian tube?
Usually
Less
less tissue damage, fibrosis ઓછું થશે સાહેબ, because when you use Vicryl, probably I feel fibrosis will be more probably. Then proline mark, at least intact, તમારી integrity of the tubes will be maintained.
અચ્છા.
Oma fibrosis, there are chances of stenosis again.
તો કન્ટિન્યુઅસ ઇરિટેશન ના કરે કે? નથી કરતા.
Sir, it's very small. By naked eye, it is very difficult to see on trolley also.
में क्या use करते हो आप? What you are using for recanalization?
We are suggesting IVF.
So again, that's what I'm saying. So again, that's what I'm saying, sir. When patient comes and refer to you for not going to IVF and other optionality, then they ask. Definitely, you have to again nowadays. Now you have to give them a menu what they want to go, and they are the one who choose, and you have to go on who have to give the
We are the
treatment.
one who guide them.
Yeah, but still. સાહેબ એવું કરશો અમારા ધંધા નહીં ચાલે લેપ્રોસ્કોપીના. But still.
Dr. Bhavik wants to tell that nowadays the patients who come for recanalization, their age is much. So even if you do a recanalization in an elderly patient where the AMH level is low, there's no use. It's directly go to
The
that is why he's
question
directly
that I
telling
asked,
go to IVF.
the question that I asked to them is કે આ ઓપરેશન કર્યા પછી બચ્ચા કેટલા કરવા છે તમારે? So they say one. So then go for IVF. Why to
But
take
there are
risk?
some people who cannot afford IVF. So in that scenario, definitely this one will be the.
હવે અમારી પાસે આવશે તો તમારી પાસે પેપર
હા,
હશે
બનાવો.
તો પછી તમે અમારી
હા,
પાસે પાછું
બનાવવા મોકલજો. We do that business.
આમાં એવું થાય કે જે પેશન્ટ આપણે જે ઇન્ફર્ટિલિટી ટ્રીટમેન્ટ આઈવાઈ ને એ બધા ચક્કરને વીકિંગમાં જાય ને એનો એટલો ખર્ચ
આવી પતી જાય. You are such a-
મને શિક્ષણના શબ્દો ન થાય.
બટ અગેન જેવું સાહેબ જેમ મેં કીધું ને કે આ પેશન્ટની ચોઇસ છે. ઇફ પેશન્ટ વેન દે આસ્ક યુ ડેફિનેટલી યુ હેવ નો થિંગ ટુ સે નો. સો અગેન ધ ઇન્સિડન્સ ઓફ IVF is more comparison to salpingostomy obviously.
One tube is there, then so they opt for conserving one.
Yes.
Do you assess another fallopian tube while operating on the ectopic part?
In
While operating?
for checking the perfusion.
Yeah, just to see if it is beaded or not, femoral end is good or
Yeah,
not.
that will be definitely. The outer thing, not the inner.
Okay.
Yeah, we don't check for the CPT and all, but outer.
From cultivation.
Should
So-
be one question on this one. Should we do our chromocultivation in this kind of
No,
patients?
no,
it
not,
is
not.
We should not do.
It will hamper by doing chromocultivation at this stage when there is a unruptured or ruptured
It is
ectopic.
just like bladder suture કર્યા પછી
હા,
વળી તમે
ગરબા
ફુલાવો.
ફુલાવો.
અને પોતાને જ કામને બગાડો એને જ.
Not to check the integrity of the thing, just to check whether the opposite side of tube is good or not.
No, because if you do something for
In-
the opportunity, this will also be getting hampered.
No, but in that scenario, I'll give you one option, madam.
એટલે diet
In
test નથી કરવા માંગતા ને તમે?
No,
ના, ના.
ડાઈ ટેસ્ટ એટલા માટે ધારો કે હવે એક સાઈડની આપણે સેલ્ફેન્જેક્ટમી કરી દીધી. આપણે
એટલે
આમાંથી
આખી ઉડાડી દો તો.
આખી ઉડાડી દીધી તો what should be like? Should we counsel the patient to check the opposite tube?
we can do.
એટલે secondary
And I think
infertility હોય તો કરવું
I have
જોઈએ.
never done, but we should do probably. But in that scenario, when what you are saying that it might hamper the right side, if you everybody who are doing laparoscopy will be doing hysteroscopy. There is a hysteroscopic cannulation set comes. Yeah, in that that is the selective thing which you can do. You got to go put it in the internal os inside the where the ostia opens up and just push the dye. It hardly takes 1 ml. 1 ml will come out. 2 ml dye will be very much helpful for you. In that, even one see when if you have seen in the previous video, we had flushed the tube with the saline completely clean. So in that scenario, even if you do dye testing, it won't hamper. And because the sutures are not taken so tightly, they are just an approximation so that the integrity is maintained. So even if you check, it is not going to harm you. But many people say that you don't check after 1 or 2 months once he heals, repeat HSG should be done. But I think what I'm saying with the cannulation set, you can on table you can do. This one is more eye catching for the patient. Oh, they're sutured and my tube are okay. So that is thing. Again in this scenario, see this is the second ectopic which was developed. On left tube, if you can see, it is not worth saving, so we did salpingectomy. So this is the gold standard, as I said. So on one side we did salpingectomy for this patient, and on other side we did salpingotomy. This is for unruptured tube. If you can see, again this patient had came after 5 days of amenorrhea, and she opted for methotrexate. We gave 1 shot of methotrexate, and after 48 hours we had called her for follow-up. But before she came for follow-up, she came in hypovolemic shock on the day morning. She was supposed to due on Sunday. It was Sunday. She was supposed to come around 10, but she came at 7. Got admitted with hypovolemic shock. We operated in morning. Almost she had lost 2 liters of blood, which was HB was 7, and again we directly took her for OT. And in our picture was this. On the other side, again, after this increase, this is the one which we give in mesosalpinx, we give, what we say? Vasopressin, sorry. Yeah, we give vasopressin so that it is believed that the blood will be less, but it's not that. But still, that's the preferable thing to be done. Ample amount of outer layer of the fallopian tube is cut. There is no use of any thermal energy or anything. Use cold scissors so that the approximation or the damage of the tubes are less. And the inner lining should be cut only very small, preferably whatever out of that you can get the product of conception, so you don't damage the tube. Minimally you damage the tube. That's the thing. So because as you outer side માં જેટલું મોટું દેખાતું હોય એટલું અંદર નથી હોતું, અંદર નાનું જ હોય છે. બાકી તો ઇન્ફ્લામેશન ને એના કારણે થોડું તમને મોટું પિક્ચર દેખાય. So after again cleaning, that is the inner tube where we are taking the suture. Hardly it takes 2 to 3 sutures which we had taken, and again the tube was sutured properly, salpingotomy was done. Again, in this case, in both the cases, I didn't do the CPT test after the surgery, assuming it's normal, and it was normal because this patient conceived after 3 months. So it was normal. Yeah. So in definitely, as Dr. Bhavik said, in today's scenario, we directly refer them to IVF, but there are still many patients who are very conservative. They don't want to go for IVF, maybe social or maybe economical, whatever the scenario is, but still they prefer that when they conceive naturally, the babies are natural. They are normal. That is still the scenario or belief in 2024.
Imagine the fertility potential of this patient, bilateral ectopic and then again conceive after 3 months.
There are some, we get some of the patients.
Fecundity and fecundability.
So, in the if you have noticed in this patient, we didn't take the outer part. We just took, again, as I said, that it is not that we don't have to tighten it too much. It is just an approximation to stop the bleeding. So that healing happens with primary healing, and again the whole product of conception is taken out under observation and into the endo bag. So this is the conservative management which we have almost, everyone has stopped doing this. Everyone directly either go for self-injectomy or refer it to IVF. But I think we should give patient a choice. A menu should be given right now, and let them decide what they want to do. Whether we are according to what we are doing, what facilities we have. If we are not, definitely everyone have people are doing around, so you can call them anytime or you can refer to them. But if patient asks them that they want to go for conservative management, I think we should give a try rather than directly pushing them to IVF part or pushing them to self-injectomy. But most important thing, patient should be hemodynamically stable. Otherwise, we are the one who will be behind the bars, not the patient. Yes. Yeah, that's it for conservative management.
Thanks, Madhav. Now we will move to the next topic. As the case of home deliveries are out of picture and the rise in the hospital deliveries and the transfer patients has been decreased and awareness of the patient also has increased, the amount of forceps deliveries which are we seeing in nowadays is on a decreasing trend. And our young generations are also afraid of applying it. And second thing is patient also nowadays in a forceps, they don't want forceps. So to speak on this vanishing trend of forceps delivery, I would like to invite Dr. Kundan Modi. He is undergraduate and a postgraduate from MP Shah Medical College, Jamnagar. He is the president of IMA Mundra, and he is a joint secretary of Bogs. And he has got his own hospital setup, Geeta Hospital at Mundra, Kutch. Special interest is 3D and 4D laparoscopy and endoscopic surgeries. So over to from Paris of Kutch, Dr. Kundan Modi.
Wow.
Good morning, everyone.
Today I am going to talk about a vanishing trend. There are so many vanishing trends in obstetric practice. One of that is forceps vaginal delivery. During my PG, our forceps is our teacher said there is no role of forceps in modern obstetrics. એ લોકોએ ફોર્સેપ કાઢી જ નાખ્યા હતા, લેબર રૂમમાં જ રાખતા નહીં એમ. તો અમે બધા સિનિયર્સ બધા ભેગા થઈને એક ફોર્સેપ પસાર અને પછી અમે ટીચર્સની એબસન્ટમાં ફોર્સેપ એપ્લિકેશન કરતા. હવે મારે હું જે પેરીફેરીમાં પ્રેક્ટિસ કરું છું ત્યાં આગળ અત્યારે સારું છે. જે મેં ચાલુ કરી દીધી ત્યારે એટલું બધું એનેસ્થેસિયાની ફેસિલિટી નથી અને ત્યારે મારે એક એડેપ્ટેશનની તરીકે ફોર્સેપ વજન ડિલિવરી જે તે સમય કરવી પડી, વેક્યુમ ડિલિવરી, ફોર્સેપ ડિલિવરી. અને ધીરે ધીરે મને લાગ્યું કે ફોર્સેપ ડિલિવરી ઘણું સારું અત્યારે મતલબ કરી શકાય. જો તમે એક ક્રાઇટેરિયા સેટ કરીને જો ફોર્સેપ ડિલિવરી કરો ને તો કોમ્પ્લિકેશનનો રેટ ઓલમોસ્ટ ડીલ જેવો હોય છે. પણ તો એક વેનિસિંગ ટ્રેન્ડ છે જે અત્યારે મોડર્ન ઓબ્સ્ટેટિક્સને એપ્લાય કરવો જોઈએ પોતાના માટે અમુક ક્રાઇટેરિયા સેટ કરીને પછી. ફર્સ્ટ ઓફ ઓલ ડેફિનેશન. Obstetric forceps is a double blade metal instrument used to extraction of fetal head. This instrument is applied on fetal head and then operative used to traction to extract the fetus, typically during contractions while a mother is pushing. Basically, there are two parts. Each part has 4 components. Two blade, part blade, shank, lock and handle. અને પ્લેટના 2 કર્વ હોય, pelvic curve અને cephalic curve. Pelvic curve which sets in the maternal pelvis and cephalic curve occupies the fetal head like this. It is Simpson's forceps. Classification of forceps delivery. There are 5 classifications. Like it is outlet forceps, it is Wrigley's forceps. Then outlet and low forceps, it's Simpson's or Elliott forceps. Mid cavity forceps, Tucker's, McLean. Mid cavity rotational forceps, Killian, and forceps after coming head in bridge is Piper forceps. Just for આ બધા ખાલી નામ છે, પણ અત્યારે મોસ્ટ ઓફ જે આઉટલેટ ફોર્સેપ યુઝ કરતા હોય છે. Outlet forceps. What is indication? When what is the scenario? When crowning station is more than +2, +3. Example like exhausted mother, like in epidural anesthesia for painless delivery. Today આજે કેવું છે કે એપિડ્યુરલ એનેસ્થેસિયા વાળા પેશન્ટ વધી ગયા છે તો એ લોકોને પેઇન ફીલ જ ન થાય, ફીલ ન થાય એટલે પુશ ન કરે તો પછી લાસ્ટ જો કેપટ સક્સેડિન થઈ ગયું હોય તો ફોર્સેપ ડિલિવરી કરવી પડતી હોય છે. Then low forceps, when station is +2 and sagittal sutures in AP diameter, like in borderline CPD, in way back to cut short the second stage of labor. And then mid cavity forceps, when the head is engaged, like station is 0 to +2, but less than +2, and sagittal suture is not in AP diameter. હવે આ છે ને બહુ રેર સેનારીઓ છે, અત્યારે લગભગ યુઝ નથી કરતા હોતા. પણ એનું ઓલ્ડ ફૂલ ટર્મ આવ્યું, અમારી હોસ્પિટલમાં અમે ઓલ્ડ ફૂલ ટર્મ આઈઓએફડી થઈ ગયા હોય, કોઈ ડાયાબિટીક મધરમાં આઈઓએફડી કાતે તો એમાં પ્રોગ્રેશન ધીમું થઈ જતું હોય છે, ઘણીવાર રોટેશન ન થતું હોય તો સજેટલ સુચર એપી ડાયામીટર એપી પ્લેનમાં હોતા નથી, ત્યારે આપણે આ એપ્લાય કરી શકાય. હવે આ મારું એક અમે જે પ્રેક્ટિસ કરીએ છીએ એના માટે છે કે ઇન મોડર્ન ઓબ્સ્ટેટિક્સ વેર ફેસિલિટીઝ ઓફ સેફ સિઝેરિયન સેક્શન ઇઝ ઇઝીલી અવેલેબલ and also due to awareness of complications of instrumental deliveries to mother and newborn. એટલે બધાને ખબર છે કે આ કોમ્પ્લિકેશન થશે એટલે એ લોકોને આપણે કન્સેન્ટ લેવાય ત્યારે એ લોકો ના પાડી દે મોસ્ટ ઓફ ધ. એટલે આવા સિનારીઓ છે ને તો આજે મોડર્ન ઓબ્સ્ટેટિક્સમાં trial of forceps vaginal deliveries are avoided by obstetricians. But as per my opinion, many cesarean deliveries can be avoided if outlet forceps delivery, only outlet forceps delivery is attempted in selected cases. Although I am also not in favor of mid cavity and high forceps vaginal delivery, except in old IOFD kids and quad prolapse cases where cervix is fully dilated. Indication of forceps delivery. Maternal indication, as you all know, prolonged second stage of labor more than 1 hour after cervix is fully dilated due to borderline CPD, poor voluntary bearing down in epidural anesthesia and rigid perineum, malrotation and POP or DTA. And the medical conditions, maternal conditions like heart or lung disease, preeclampsia, to cut short the second stage of labor. Okay. Fetal condition, fetal indications, fetal distress, prolonged prolapse pulsating cord, preterm babies to protect the brain compression. In preterm babies there are useful forceps delivery are also useful to protect the brain compression. After coming head in breech, non-progressive second stage of labor due to full-term IOFD. Some contraindications are also there, like clear-cut CPD, previous history of 2 LSCs or myomectomy, extreme medical conditions like heart-lung disease, severe anemia, કંઈક સિવિયર એનિમિયામાં કેવું છે કે અંદર પીપીએસ થાય, ટ્રોમેટિક પીપીએસ, તો કંટ્રોલ કરવું ઘણું મુશ્કેલ થઈ જતું હોય છે. હેન્ડ પ્રોલેપ્સ, એમાં બેબી ટ્રાન્સવર્સ થઈ જાય એટલે પછી ખેંચવું મુશ્કેલ થઈ જાય. હિસ્ટ્રી ઓફ સીપીટી, પ્રીવિયસ હિસ્ટ્રી ઓફ ફોર્સેપ ડિલિવરી કેવું હોય અને સીપીટી થયું હોય તો આ વખતે સીપીટી થવાની શક્યતા મેક્સિમમ હોય. એટલે સીપીટી હોય તો ફોર્સેપ ડિલિવરી બેટર, વેજાઇનલ ડિલિવરી અવોઇડ કરવી છે, પણ ફોર્સેપ ડિલિવરી અવોઇડ કરવાની. બેબી હેઝ જેનેટિક ડિસઓર્ડર લાઈક ઓસ્ટિયોજેનેસિસ ઇમ્પરફેક્ટ ઓર હિમોફિલિયા, એટલે બેબીને કોમ્પ્લિકેશન થવાની શક્યતાઓ વધારે હોય. This is the important slide. Prerequisites for forceps vaginal delivery. First of all, written consent. આ સૌથી ઇમ્પોર્ટન્ટ વસ્તુ છે, કારણ કે ગમે તેટલું એક્સપર્ટ હેન્ડ હોય, ગમે તેટલું મધર હોય, પણ એમાં કોમ્પ્લિકેશન થવાની શક્યતા હોય ન હોય. Written consent explaining complications of instrumental delivery to mother and newborn also. Second thing is head is engaged. Head floating હોય ક્યારે forceps delivery ટ્રાય નહીં કરવાનો except fully dilated તો. Cervix is fully dilated. Membrane is ruptured. Station is more than +2. હાઈ ફોર્સેપ લગાવી શકે પણ એ 0 થી બહુ કોમ્પ્લિકેટેડ કરતા હોય છે. આઈઓએફડી હોય તો કે એમ જ કરવાનું. સ્ટેશન ઇઝ મોર દેન +2. સજેટલ suture in AP diameter. Bladder and bowel should be evacuated. Pelvis clinically adequate. Before applying forceps, we should recheck the pelvis. Ischial spine ને જોવું પડે કે એ પાછું કોન્ટ્રાક્ટેડ નથી ને. Labor analgesia or pudendal block should be given. Episiotomy should be given, but episiotomy એકદમ વાઇડન એપિસિયોટોમી આપવા. નોર્મલ આપણે જે 2 to 3 સેન્ટીમીટર 4 સેન્ટીમીટર આપતા અને 5-6 સેન્ટીમીટર સુધી એપિસિયોટોમી આપતા, અંદર મ્યુકોઝા વેજિનલ મ્યુકોઝા પણ થોડો વધારે ટેર અંદર સુધી કરતા હોય છે ફિંગર નાખીને. ટીમ ઓફ પીડિયાટ્રિશિયન વિથ ટ્રેન્ડ નર્સિંગ સ્ટાફ should be ready to receive baby in NICU. Be ready for emergency CS in case of failed forceps. આ બધા ક્રાઇટેરિયા પ્રી રિક્વિઝિટ્સ હોય, આપણી પાસે આ બધું રેડી હોય, ફોર્સેપ ડિલિવરી અટેમ્પ્ટ કરી શકાય. મેથડ ઓફ એપ્લિકેશન. આ મેથડ ઓફ એપ્લિકેશન એકદમ, અને ટ્રેક્શન, મેથડ ઓફ એપ્લિકેશન પછી ટ્રેક્શન, એ બંને વસ્તુ એકદમ ઇઝી આપણને ખબર હોય ને તો કોમ્પ્લિકેશન અંદર ટેર, ટ્રોમેટિક પીપીએસ થવાની શક્યતાઓ બહુ ઓછી રહે. આફ્ટર ઓલ એસેપ્ટિક પ્રિકોશન, એમ્પ્ટી ધ બ્લેડર ટુ એન્ડ ડુ પેલ્વિક એક્ઝામિનેશન અગેન. ગીવ ઓક્સિજન વાય નેઝલ કેથેટર ટુ મધર. Episiotomy after local anesthesia. Lock the blade outside to identify the patient side of blade. Patient સૂતું હોય ડોર્સલ પોઝિશનમાં, એની સામે બ્લેડ લોક કરવાની, એટલે આપણે પેલ્વિક કર્વ ખબર પડે ઉપરની સાઈડ પેલ્વિક કર્વ છે. રાઈટ ઓર લેફ્ટ બ્લેડ આઈડેન્ટિફાઈ કર્યા પછી હોલ્ડ ધ રાઈટ સાઈડ ઓફ બ્લેડ, રાઈટ સાઈડ ઓફ પેશન્ટ બ્લેડ ઇન લેફ્ટ હેન્ડ વર્ટિકલી. મૂવ યોર રાઈટ હેન્ડ ઇન posterior vagina, slip forceps blade in between fetal head and your right hand in vagina. સ્લીપ કરીને પછી એને રોટેટ કરીને લેટરલ કરી લેવાનું. એ સેમ રાઈટ સાઈડ ને લેફ્ટ સાઈડને બ્લેડ કરીને લોક કરવાનું. સેમ પ્રોસેસ વિથ લેફ્ટ સાઇડેડ બ્લેડ વિથ હોલ્ડિંગ યોર રાઈટ હેન્ડ. લોક ધ બ્લેડ્સ. લોક ન થાય ત્યાં સુધી ટ્રેક્શન નહીં આપવાનું, કારણ કે લોક ન થાય તો એ ફોર્સેપ છટકવાની શક્યતા મેક્સિમમ હોય અને એના કારણે ટેરિંગ, બેબીના ફેસ ઉપર ટેર થવાની શક્યતા, વજનલ ટેર થવાની શક્યતા મેક્સિમમ હોય છે. ગીવ ટ્રેક્શન. કોન્ટ્રાક્શન્સ આવે ત્યારે ગીવ ટ્રેક્શન અકોર્ડિંગ ટુ પેલ્વિક કર્વ, એન્ડ અકોર્ડિંગ ટુ પેલ્વિક કર્વ ઇઝ મોર ઇમ્પોર્ટન્ટ. અમારે જ્યારે ટ્રેક્શન આપવાનું હોય તો ઇનિશિયલ ટ્રેક્શન ડાઉનવર્ડ કે આપણી સાઈડ આપવાનું હોય છે. પછી જેમ જેમ બેબીનું હેડ પ્રોગ્રેસ થાય તો તેમ એ ટ્રેક્શન ઊંચું કરતાં કરતાં અને લાસ્ટ જ્યારે કાઢતા હોય ત્યારે હેન્ડલ અપ ટુ પેશન્ટ્સ એબ્ડોમેન, આખું કર્વ એ રીતે જે પેલ્વિક કર્વ જે અંદર બનાવેલો છે ને જે ફોર્સેપમાં, એ પેલ્વિકને સેટ થાય એ પ્રમાણે છે. જો આપણે સીધું ટ્રેક્શન આપીએ તો ઇન્જરી થવાની મેક્સિમમ શક્યતા હોય છે. એટલે પેલ્વિક કર્વ પ્રમાણે ટ્રેક્શન આપવાનું. હેન્ડલ જ્યારે છેલ્લે જ્યારે બેબી બહાર આવે ને માથું ત્યારેનું આખું હેન્ડલ પેશન્ટના પેટ ઉપર જતું રહે એટલું આખું કર્વ આપણે રોટેશન કરવાનું હોય. 180 ડિગ્રી આખું રોટેશન કરતા હોય. અને એક બીજી ઇમ્પોર્ટન્ટ વસ્તુ, ગીવ સપોર્ટ ટુ પેરિનિયમ. હા, આસિસ્ટન્ટને પણ કહી શકાય કે પેરિનિયમ સપોર્ટ આપેલે સીપીટી થવાની શક્યતાઓ મિનિમાઇઝ થઈ જાય. પછી જ્યારે બેબી ડિલિવરનો હેડ ડિલિવર થઈ જાય, અનલોક ધ બ્લેડ્સ એન્ડ રિમૂવ ધ ફોર્સેપ આફ્ટર ડિલિવરી ઓફ હેડ. ડિલિવર ન્યૂબોર્ન પછી તો બેબી જે રીતે ડિલિવર થાય, ડિલિવર ન્યૂબોર્ન ઇન વર્ટેક્સ એઝ ધ વર્ટેક્સ ડિલિવરી. અને એક્સપ્લોર વજાઇના એન્ડ પેરિનિયમ ટુ ટેર, કારણ કે મોસ્ટ ઓફ 70-80% ટેર થાય જ છે. એટલે લેટરલ વોલ્સ છે એ એક્સપ્લોર કરવી જ પડતી હોય છે. અને જે આપણને બ્લીડિંગ દેખાય ત્યાં આગળ વ્યવસ્થિત આપણે સૂચસ લઈ લેવાનું. આ એક પિક્ચર છે જે બતાવે છે કે કઈ રીતે આપણે ટ્રેક્શન આપવાનું હોય છે. બેબી આ રીતે પોઝિશનમાં હોય, આપણને પેશન્ટ સૂતું એટલે આપણને એમ કે બેબી સીધું જશે, પણ બેબી એ નથી હોતું. બેબી આ પોઝિશનમાં હોય છે જેને આપણે પેલ્વિક કર્વની ડાયરેક્શનમાં ખેંચવાનું હોય છે. કોમ્પ્લિકેશન્સ અમુક થાય જે મટરનલ કોમ્પ્લિકેશન લાઈક એક્સટેન્શન ઓફ એપિઝોટોમી, અંદર વજનલ ટેર થાય, ટ્રોમા ટુ સર્વિક્સ, યુટ્રસ, બ્લેડર, યુરેથ્રા, બાઉલ, મતલબ મલ્ટિપલ ટ્રોમા થઈ શકે, પણ એ આપણે અમુક સિલેક્ટેડ કેસમાં એને મિનિમાઇઝ કરી શકીએ. નર્વ ઇન્જરીઝ મે બી ધેર, ટ્રોમેટિક પીપીએચ, પર્પુરલ સેપ્સિસ આર વેરી કોમન. ન્યૂબોર્નમાં ટ્રોમા ટુ આઈ, સ્કાલ, ફેસ, બર્થ એસ્ફેક્ટ્સ લીડ ટુ સેરેબ્રલ પાલ્સી, ફેશિયલ નર્વ પાલ્સી. ફેશિયલ નર્વ પાલ્સી ઘણા કોમન એવું હાઈ ટ્રેક્શન આપતું હોય ને ત્યારે ફેશિયલ નર્વ પાલ્સી બેબીને થાય, જે સ્પોન્ટેનિયસલી થોડા દિવસમાં રિકવર પણ થઈ જતી હોય છે. ટ્રોમા ટુ સ્કલ લીડ્સ ટુ ઇન્ટ્રાક્રેનિયલ હેમરેજ, લીડ્સ ટુ ડેથ. આ તો કોમ્પ્લિકેશન્સ ફોર્સેપ વજનલ ડિલિવરી થાય છે. અમારી ફેમિલીનો ફોટો છે, મારા બંને બેબીઝ છે, એ બંને વેક્યુમ ડિલિવરીથી મારી હોસ્પિટલમાં વજનલ ડિલિવરી થયેલા છે. અને લીવર એનાલિસિસ હવે આપી દઉં મારી વાઈફને, અને પછી એટ ધ ફૂલ ડાયલેટ સર્વિસ વેક્યુમ ડિલિવરી બંને બોર્ન થયેલા છે.
Thank you, Kundan. Dr. Kundan has described the prerequisites for the forceps delivery. There are more residents I can see here. See, as laparoscopy has taken over laparotomy, everyone is now jumping to laparoscopy and they are not understanding the basics of laparotomy. If you are good in a open surgery, then your laparoscopy will be best. Like that only, this is the time in residency where you have to do all these things. Even if you come outside and start practicing, if you go for a cesarean section, it's well and okay. But there will be a time in that thing that you should know the basic things of forceps. So you should not like that ki every time you will land up with cesarean section, everything is available, kari nakhe. Nahi, you don't do, that's okay. But you should know, and especially for the residents, this is the time, and this is the situation also needs that you should do things and learn things. If you don't practice, it's okay, but you should know the basic things, you know, and when to do, and rather than when to do, when not to do. That is more important, when not to do. That you should learn during this phase only. Just I like to add this much thing.
Requirement of good obstetricians is more in the society rather than endoscopists and ART physicians.
Yes. Consent for forceps
And-
delivery must.
મારો એક એક્સપિરિયન્સ કહું તમને. મારે હું પહોંચાયો હતો 11 કરિયર સ્ટાર્ટ કર્યું એ વખતે નલિયાથી એક પેશન્ટ રિફર થઈને આવ્યું હતું, 7th 8th ગ્રેડ હતું, અને એક તો મેક્રોસોમિક બેબી ને ફોર્સેપ વોઝ અપ્લાઇડ એટ પીએચસી, અને એમાં હેડ વોઝ હેંગિંગ આઉટ ઓફ ધ વલ્વા, આઈ બોન્સ વેર હેંગિંગ લાઈક ધીસ. આ રીતે પેશન્ટ આવ્યો તો શોલ્ડર ડિસ્ટોસિયા આપે જે આપીને સિડેશન જે મેં સ્ટ્રગલ કરીને મચ્યો, એના પછી એટલી ગંદી રીતે બેબી બહાર આવ્યો. પછી એને યુટ્રાઇન રપ્ચર માટે મેં કેટલી વાર જોયું તારી બાજુ સોનોગ્રાફી કરી. આ રીતે ઇન ધીસ કન્ડિશન
શોલ્ડર ડિસ્ટોસિયા બહુ કોમન છે. એટલે અમે સર આમ 3.5 kg થી અપ જાય એટલે પછી તો આપણે ફોર્સેપ ડિલિવરી નથી પહેલાથી જ ના પાડી દઈએ, ફોર્સેપ શોલ્ડર ફસાશે પાછળ.
અને મેં એક કિલેન્ડ કોન્સેપ્ટ જોયો તમારી રેસિડન્સીમાં, મારા સાહેબે કર્યો હતો. પેશન્ટ વોઝ હેવિંગ ફૂલ ડાયલેટેશન, હાઈ ફ્લોટિંગ હેડ, ફૂલ ડાયલેટેશન, કાર્ડિયાક પેશન્ટ. The forceps, high rotational killing forceps was done under general anesthesia, and it was super forceps I have seen in my life.
પહેલા આટલી 100 વર્ષ પહેલા યુરોપિયન કન્ટ્રીઝમાં ફોર્સેપ
તમારે કહેવાનું
આ મેં જેમ ડિસ્કસ કર્યું હતું ને કોટરાવાળા.
In Killen,
અને અમારા એચ્યુડોસી સર અત્યારે જીસીએસ મેડિકલ કોલેજમાં છે, અને એ આજની તારીખે પણ ઓપરેટિવ વજાઇનલ જે ફોર્સેપ ડિલિવરીનો ટ્રેનિંગ પ્રોગ્રામ બી ચલાવે, વેક્યુમ ફોર્સેપ ડિલિવરી, અને એ બી કોઈને જોઈન કરવું તે કોઈ પણ જઈ શકે. એટલે ઓપરેટિવ વજાઇનલ ડિલિવરી should not be vanishing task.
No, it is the need of the time. You should know. Cesarean is available, anesthesia, everything is available. But sometimes you should know your basics. What I want to make the impact on these students is whatever is there, the basics should be strong.
Vacuum the outlet forceps is safer. For the baby, because it forms a protective cage around the baby. और वो rotation perfect है तो थोड़ा आगे पीछे तो चलता है, लेकिन outlet को निकल आता है.
actually in vacuum what happens is baby is more compromised.
More
When you see the facial pediatricians, they are not happy. So they prefer to have a forceps delivery. And particularly clearance is anytime more helpful when there is malrotation of the hair. So just use apply anterior posterior and just you go down. This way at that time it is very helpful. And another thing, okay, whenever do you forceps, if anesthetic available, do suturing under spinal anesthesia. So any care, anything, you will be, and by ease, anything might be
Exposure must
care, anything. So you can very well suture, but there are very less chances of PPS. Otherwise, you will be half-hearted. Because patient is only in panic condition, they are not allowed to hire up any vaginal tear is there. And vaginal tear is really notorious, very notorious. So,
Two things I would like to tell regarding forceps.
that's why better to suture, better don't take risk, better to suture. And I tried even with petrosal, but we are not happy. Only spinal is happy.
And it's one more advantage of giving anesthesia, the anesthetist is also available. So in case there is any hemodynamic issues or something, so there you have someone to help you.
But when you suture under this spinal, then the suturing becomes easy.
Very easy.
So post there are many we also think अरे बेसिने कौन suture करसे 2 कलाक आते એટલે patient નથી cooperative. But when you do this, that will gain you more confidence, and then the instrumentation or operative at least you will prefer to do rather than under spinal or the CS.
I just like to add, see, whenever the day you become an obstetrician, 2 કલાક ki 3 કલાક, that કલાક should not come in your mind. This is basically for that young ones. Because the day you start thinking कि 2 કલાક કોણ બેસે અને 3 કલાક કોણ બેસે, then you understand that you will not go in a long run. I hope all my seniors will agree with me कि 2 કલાક અને 3 કલાક वाला क्वेश्चन कभी नहीं आएगा obstetrician.
प्राइवेट में कर सकते हैं वहाँ पे.
No,
कॉलेज में
I oppose. It is not like that. Sir, सही है कि नहीं? Sir, सही है कि नहीं? See, your father is not agreeing with you.
No, I'm saying that your preference towards obstetric instrumentation will improve because post when you deliver, આપણા બધાના માઇન્ડમાં એવું જોઈએ કે યાર આટલું બધું છે તો પછી મારા પેશન્ટ અટલ થઈ જશે. I have to write down the sheets and all. But when you do, it is very comfortable. So that will change your scenario of thinking. That is the thing. My first episiotomy was 1 hour and 15 minutes.
हाँ, take your time. So you are according with the फिर तुमको खतरनाक रजिस्टर नहीं मिला है हमारे जैसा. हमारा रजिस्टर होता
that was
one catgut and 10 minutes and out. Another catgut फिर तेरे को संडे के दिन जाना पड़ेगा ब्रेकफास्ट लेके सबको.
No, that was my first orientation episiotomy, I'm saying. But when I finished my orientation program after 1 month, I finished almost 179 episiotomies, which came down to 7 minutes. So that was
and typically for the residents also, don't crib. You need to work. Whatever work you do during these days will help you outside when you come. So never crib. वो मेरे से इतना कराता है, वो कराता है. Nowadays I'm seeing lot of trends coming. So don't crib. Do whatever. Take your time. This is the time to learn. And here, those who are just sitting quietly also know that you need to work very hard to get to the top over there.
Two things I would like to add. The one is કે ફોર્સેપમાં ઘણી વાર કેવું થાય આપણને બીક હોય કે એકવાર એપિઝો આપી ફોર્સેપ કર્યું પછી ના આવ્યું વળી પાછું સીએસ લીધું ઉપરના ટાંકા નીચેના ટાંકા પેશન્ટને કેવી રીતે સમજાવું નાવું કે ના નાવું અઘરું થઈ જાય સફાઈ ક્યાં રાખવાની પાણી નીચે અડવું જોઈએ ઉપર પાડવું
ઉપરની ચિંતા નથી નીચેની ચિંતા એટલે ઉપર સિઝેરિયન બધાને આવડે જ છે ચિંતા નીચેની એપિઝોટોમીની ચિંતા છે ને ઓપરેટિવ વધારે ડિલિવરીની
તો શું કરવાનું લોકલ આપી દેવાનું એપિઝો નહીં આપવાનું ફોર્સેપ લગાવી દેવાનું જોવાનું કે લોક થાય છે કે નહીં જો લોક થઈ ગયું તો ટેક ઇટ ફ્રોમ મી કે બચ્ચો આવી જશે then and then apply episiotomy and then just go for it and it will be done. Second thing કે આપણે વાત થઈ ને કે ભાઈ શોલ્ડર ડિસ્ટોર્સિયા યારો બહુ થઈ જાય ફોર્સેપમાં શોલ્ડર ડિસ્ટોર્સિયા અવોઇડ કરવા માટે છે ને યુ હેવ ટુ ફોલો ધ નેચરલ મેકેનિઝમ ઓફ લેબર નેચરલ મેકેનિઝમ ઓફ લેબરમાં જ્યારે બચ્ચાનું માથું આવે તો શું થાય છે કે બેબી બોર્ન વિથ એક્સટેન્શન ઓફ ધ હેડ પછી થોડું રિસ્ટિટ્યુશન થાય છે પછી ફ્લેક્શન થાય છે અને પછી સ્પોન્ટેનિયસ રોટેશન ટુવર્ડ્સ વન પર્ટિક્યુલર સાઇડ થાય. તકલીફ ક્યારે ચાલુ થાય કે જ્યારે આપણે પોતાની મરજીથી એક જગ્યાએ એને રોટેટ કરવાની ટ્રાય ચાલુ કરતી ત્યારે પ્રોબ્લેમ્સ ચાલુ થાય. સો વી શુડ બી વેરી પેશન્ટ ઇન અવર વર્ક. માથું આવી ગયું છે, બાકીનો આવી જશે. શાંતિથી એને ફ્લેક્સ કર્યા કરો અને એક વેઇટ ફોર વન પર્ટિક્યુલર મોમેન્ટ કે જ્યારે એ રોટેટ થાય ધેન ગો ફોર ઇટ. આઈ એમ ડેમ શ્યોર દેટ યુ વિલ બી પ્રિવેન્ટિંગ લોટ્સ એન્ડ લોટ્સ ઓફ શોલ્ડર ડિસ્ટોર્શન.
Particularly shoulder dystocia, if you flex the legs.
Hyperextension of the.
થઈ ગયું તો
Really helpful. You just take it and do it, no, automatically the shoulder will come down.
Some suprapubic pressure also.
It is also essential. When the
I would request our chairpersons, Pannaben Doctor and Dr. Urmilaben to come on the stage and facilitate our speakers. So Sagar, Dr. Hemangini, Dr. Kundan and Dr. Madhav, please.
Yes, look here now.
Dr. Kundan, please.
Yes, look here, look here. Okay. 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 Okay.
હા લઈ લઈ.
All come
ચારે
with a group
ચારે
photo,
સ્પીકર
please.
એકવાર
ચાર.
group photo બતાવી.
All four speakers with the chairperson, please come for a group photo.
Anchors please join. अरे
Yes.
cover both the sides.
थोड़ा सा आगे आना है.
हाँ.
मेरा फोटो है, मैं तो नहीं आऊँ
Okay, yeah.
तो
Done.
निकली.
One minute. Again, yes. Okay.
After this session, I think we need a tea. So there's a tea
Yes.
break for 10 minutes so we can re-energize ourselves for the next session.
अपडेट्स पाने के लिए बेल आइकन दबाइए.
Bhavi, so our secretary is here. Please, Puneet bhai. We'll start this with our inauguration ceremony. I would like to Dr. Badraka sir and Dr. Damayanti ma'am. Dr. Damayanti ma'am, please come. Please come on the stage. start with the lamp lighting, as is our traditional procedure to go. And then I will hand this mic to our President Puneet Khatri for his welcoming speech.
या ब्रह्माच्युतशङ्करप्रभृतिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदाम् हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्
Over to Dr. Puneet Bhai for his welcoming speech.
Good morning, sorry, good afternoon everyone, ladies and gentlemen, દેવીઓ और સજ્જનો. તો ગુજરાતીમાં ભાઈઓ અને બહેનો આવી જાય છે, બહેનો ભાઈઓ. તો honorable President, past President BOGS, Honorable Dr. N.N. Padarka sir, past Secretary Honorable Dr. Gopal Hirani sir, respected Dr. Damayanti Ganatra ma'am, Dr. Bhavik Khatri, and all my dear BOGS members and senior colleagues. I heartily welcome you all in this CME. And this is the first kind of CME by BOGS, for BOGS, and of BOGS people. So we organized, last year we organized the P2 scan 2023. And it was a super successful one-day conference of fetal medicine. And after that, we all are meeting for the first time after almost 7 to 8 months. The purpose of doing this CME is to empower our unity by more frequent gatherings and to bring out the hidden talent of our young BOGS members. And we also can learn something new from each other as well. I had been planning a ART workshop this year in January or February with a live demonstration of ART procedures by inviting renowned faculty from outside. But somehow it could not become possible because of their prior commitments and ISAR conference in first week of February in Bhubaneswar. આપણને હંમેશા એવું લાગતું હોય છે કે બધા CMEs અને કોન્ફરન્સીસમાં લગભગ બધા એકના એક ટોપિક ડિસ્કસ કરવામાં આવતા હોય છે, એમાં કંઈ નવું હોતું નથી. પણ ખરેખર જો આપણે આપણા કલીગને, સિનિયરને કે કોઈ પણ સ્પીકરને જ્યારે સાંભળીએ ત્યારે એમાંથી ખરેખર કંઈક નવું શીખવાનું મળતું જ હોય છે. અને તમે લોકો નોટિસ કર્યું હશે કે હું લગભગ મોટાભાગની કોન્ફરન્સીસમાં હું હાજરી આપતો જ હોઉં છું. પછી એ સોગોગ હોય, AICOG હોય, IVF ની ISAR કોન્ફરન્સ હોય, એન્ડોસ્કોપીની IH હોય કે યુરોપિયન સોસાયટીની એસરે કોન્ફરન્સ હોય, અને દરેક કોન્ફરન્સીસમાંથી હું કંઈક નવું શીખીને આવતો હોઉં છું. અને એ જ મને મારું નોલેજ કન્ટિન્યુઅસ અપડેટેડ રાખવાની મને ઇન્સ્પિરેશન એમાંથી મળે છે. અને આ વખતે BOGS ઓફિસ બેરર્સ કમિટી તરફથી એક નવું ઇનિશિયેટિવ શરૂ કરવામાં આવ્યું છે. And that is to honor senior patron members of our society by honoring them lifetime excellency award for the first time. And this time we have selected 2 dignitaries from the East Kutch and 2 dignitaries from the West Kutch. Honorable Dr. Nimaben Acharya, Dr. N.N. Badarka sir, Honorable Dr. Damayanti Ganathram ma'am, and Dr. Chandrakant Thakkar sir. But unfortunately, Dr. Nimaben and Chandrakant sir is not here in this CME. So I am looking forward to host more CMEs and big conferences in future by inviting renowned faculties and dignitaries to our society. And for that, I need all your wholehearted support to bring the BOGS to a new horizons. Thank you very much. Let's continue with the CME. Jai Hind, Jai BOGS.
I would like to invite Dr. Badraka on the stage, and he will be awarded. And to take this privilege, I will call Dr. Gopal Hirani sir, Puneet Bhai, and Prafula ma'am to please come on the stage.
Dr. Padaka sir is MBBS and MD from MP Shah Medical College, Jamnagar. He had worked as class 1 gynecologist at JK General Hospital, Rambagh Hospital. He has done 60,000 laparoscopic TL surgeries. He has worked as Dean Medical Faculty at KSKV University, Kutch for more than 5 years. With the support of all gynecologists, he remained as president of Bogs for many years. Successfully managed various complicated obstetric cases with limited faculties at JK General Hospital. Member of Advisory Committee, member of Rogi Kalyan Samiti, worked as an assistant professor, associate professor, and professor in OBG department in Games Medical College, Bhuj. He has worked as associate dean at Games Medical College, Bhuj for 2 years, worked as head of department OBG for 3 years at OBG department at GK General Hospital, Bhuj. And sir, now I request you to share your experience, whatever vast knowledge you have, whatever tips you can give to the upcoming youngsters, whatever knowledge sharing you can do with us.
So society is really feeling proud for you, for your untiring efforts and noble contribution towards the society for betterment of the women health. Please.
Welcome and thanks Dr. Puneet Khatri, Dr. Bhai Khatri, my colleague Damayanti Ben, Dr. Hirani. I am very much pleased today that the Dr. Puneet Khatri and Bhai Khatri have taken this good initiation to activate the society. That is the great thing. I will place 2 scenarios of the box of the Kutch. One upon a time, whenever any pharmaceutical company were arranging a CME, we have a very much difficulty to collect the 3-4 members for the meeting. And every time we fail because most of the obstetricians, around 8 to 10 were there. They were busy with their obstetric practice. Many times pharmaceutical company tell us to organize a CME and all these things, but we all fail in that. And so many times we have arranged a CME on the laptop and a table. There were 3 or 4 members were there. After that, and that was the we have a many problem also at that time because we have a less gynecologist. We all were most of them were busy with the practice and hardly to get a time to get all these things update themselves to get the other services, social services. It was very difficult. And after that, the new team from your side came, an emerging team came with the full updation in the equipments, particularly laparoscopy. At that time, laparoscopy was there, but we have a only single puncture laparoscopy, and we were using only for the tubal ligation or tubal occlusion. That was the only level. So we were not having practice of the double puncture or a portal or this laparoscopic surgery. And nowadays, the second scenario, you are updated with the everything. You are updated with the laparoscopy, sonography, fetal echo, Doppler, and each and every equipment is advanced, and you are all doing very good things. And particularly in Kutch region, I have not expected this type of this facility what will be updated and this public will get benefit of this all these thing. But benefit of this thing is definitely goes to society because we have faced many obligation in maternal side, in fetal side, newborn side, and with the lack of facility and lack of the teamwork and lack of the updation. But nowadays, I can mention that we have a maternal mortality was more than 150 in a year in this Kutch area. Now it is reached around 50. So you all have done a great job. And really, you have prevented the mortality and morbidity and the great social work. That was the thing. And third thing is this time, this initiation, that you are activating each and every gynecologist of the society. That is the great job. They all should get interested in this type of CME. They all will be activated. They will, and by the time they all should have a time to speak against all of us. So they will have a good practice. They will be good orator, and will be a great job. So I am very much thankful to Dr. this society, my office bearers, and I wish them a bright and good future, and I congratulate them for doing all these things. Thank you very much.
Now I'd like to invite Dr. Damayanti Ben ma'am on the stage, and to do the honors I'd like to invite Surbi Ben, Prafu Panna Ben Rudani ma'am, Dr. Hiradi sir, and Puneet bhai. Please.
Yes, sir. Yes, yes, ma'am. Look here.
I feel highly privileged to speak about MAP. In fact, I am short of words what to tell. I have been looking at her since 20 years. I know her as a very strong but yet a soft lady. Extremely cool but extremely hospitality also. She is always a lady in pastel shades with a flower in her hair. You can never change her style, but a motherly figure for all of them I have ever known since then. Ma'am has been an undergraduate and postgraduate from Bombay, And imagine at times like 1975 to come from Bombay and get settled in Kutch and to make her name in Kutch, it must have been extremely difficult. I can understand the pain, the hard work she has undergone to make a lifetime excellence award she is getting. This is very short thing, but it is an inspiration for me and as for all my juniors also to look upon to her and follow the path and take all the things which she can give to us. She has been a pioneer of a non-descent vaginal hysterectomy that time. She has been pioneering in delivering painless for epidural. She has still got the highest number of delivery. If you go to the municipality, they will again tell that no one can beat the She works with this rate of delivery also. She is still working for the Chiranjeevi Yojana and the Rashtriya Bima Yojana. To other technical sides on her, she has been a president of Bhuj IMA, she has been secretary to Bhuj IMA, she has been a deputy mayor also to the Bhuj municipality, and she has been an ex-charter president to the Rotary Club Hall. And she, in spite of doing all these works, she is still visiting Mundra, where she is going to Jindal and CGPCL and MICT. And she used to visit Panandro also. I have come to previous years when I was new, she used to go to Panandro also. See the wings she has spread slowly in whole of Kutch. That's why she is queen of Kutch now. All other social activities, this is not only work. Work house is there, but other social activities is, she was ex-member of All India Radio Bhuj. She was for Kutch Kalyan Kendra also. She is a member of National Blind Association also, Jankar Club Bhuj and Indira Club Bhuj. She used to work as a consultant for the Post and Telegraph, Income Tax Department and the MIES and the Air Force Department. This has been her social side, academic side and the technical post she has held, and been a mother of 2 children, that is separate. And she has got a philanthropy side to her also. She has donated some around 21 lakh rupees for the education and medical facility for the Lohana Samaj. And not her only Samaj, she has given a donation of around 25 lakhs to the Bhuj Babs Swaminarayan temple. So in all these various stages of life, whatever she has led, so it is an inspiration for us to look upon her like this. So ma'am, go to you for this excellence. Go to ma'am for few words.
She's a great swimmer also.
So see, this thing is added also. Please.
Hello. Namaskar. Hi. Ya Devi Sarvabhuteshu Matrurupena Samsthita Namastasyai 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 Namo Namah Ya Devi Sarvabhuteshu Saktirupena Samsthita Namastasyai 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 Namo Namah. President Dr. Puneet Khatri, his team and all of my friends. I think whatever today is because of the blessing of the God, my main Guruji, Param Puja Pandurang Shastriji Athawade, my parents and my in-laws family. I think when I came to Bhuj in 1975, it was like a hill station. After 6 o'clock, nobody was moving on the hospital road. And when I started my work, I was very big. I'm new, my instruments are new, my assistant is new, there is no anesthetic. So I had a very big means I was telling my husband, I'll call somebody and do. My husband was talking, did you do anything? I said, I have done many things, but here I'm afraid. And he was telling me, I am with you, why you are afraid? And he has given me a bundle of confidence, and that has made me to work very independently and very well. Actually, I think wherever my husband is there, he must be remembering and he must be listening there. So, and whenever I used to do hysterectomy, my husband was giving me anesthesia and we were working. And when initially I joined I was as a gynecologist. I was doing more of the gynec work, and vaginal hysterectomy was my favorite, and I was doing many things.
But sometimes no patient comes after 10 days, 15 days and tell, madam, some doctor told me that તમારા અંદરના બધા ટાંકા ખુલી ગયા છે. હવે હું શું કરીશ? And that was the reaction of our colleague also sometimes. That time I was feeling very bad. Why we don't become united and make insan instead of cutting somebody else? And but anyhow, that time has passed, and then slowly my work I started, and I was becoming obstetrician. Initially, I had hardly 5 to 10 deliveries per month only, and I was having a very watchful expectancy, and we were delivering the patient. But demand came, and I started working as it for the epidural anesthesia, and that gave me very good result. Patients were very happy. I was also very happy. But at the same time, it was a very costly, and my patients are middle class, low middle class. For them, it was a very costly affair. So and meantime, I attended the workshop of the Dr. S.N. Daktari, our Odissilva of the India, and he active management of the labor, what I have learned from him. And that active management of labor has helped me a lot for my obstetric work, and I started using ketamine, injection ketamine, and that has given me more means the fetal maternal mortality is reduced, and even the cesarean section rate was decreased because of the injection ketamine. Time was the delivery time is reduced, and patients are very happy. And same thing, still I am continuing the injection ketamine, and my patients are happy. I am also happy, and my cesarean rate is only hardly 20%. And same thing, I think whole life I am learning that my hard work and my motto that I should be friendly with each and everybody. Everyone, when I joined it, I was laughing to some my gynecologists. They will just never laugh at me, and they will just turn their face. So we should not be like that. We should be ek bano and nek bano. That should be our attitude towards our society. And I hope we all unitely stand, and we pray to the God for the better progressment of our society.
This is the first time I have seen Madam emotional also in this period of 24 years. Now I like to give this mic hand over to our secretary, Dr. Bhavik Khatri, for the Thanksgiving.
हेलो ચાલુ છે કે બંધ છે અચ્છા મને તો કંઈ એવું લાગતું નહીં હાલો આમાં વધારે મજા આવે Hello everybody, this is Dr. Bhavik Khatri. I am here to say a few words about this inauguration ceremony. First of all, I would like to thank Dr. N.N. Bhadarka sir for accepting our proposal of accepting this BOGS Lifetime Excellency Award. કે આપણે કોઈને આવો અવોર્ડ આપવા માંગતા હોય કોઈ એક્સેપ્ટ કરે ને એ પણ મોટી વાત છે. ભાદરકા સર ઇઝ સચ અ ગ્રેટફુલ પર્સન. આઈ ટેલ યુ સ્મોલ સ્ટોરી અબાઉટ હિમ. કેરિયરની શરૂઆતમાં છે ને કંઈક 1.5-2 વર્ષ પ્રેક્ટિસને થયા હતા અને ડીએની કરવા એક પેશન્ટનું ડીએની કર્યું હશે તો એનું કંઈક પરફોરેશન થઈ ગયું, પછી એને પેઇન ઇન એબ્ડોમેન થયું, પછી ધીમે ધીમે પેશન્ટ હાઇપરટેન્શનમાં ગયું. 2-3 દિવસ પેશન્ટ સાચ્યું ઇન્જેક્ટેબલ એન્ટીબાયોટિક સાથે, પણ સુધર્યો નહીં, ધીમે ધીમે સેપ્ટિસેમિયામાં ગયું. તો ખબર પડી ગઈ કે ભાઈ આને હવે આગળ ઓપરેટ કરવું પડશે. તો એને બધું એક્સપ્લેન કરીને વી રેફર્ડ ટુ હાયર સેન્ટર, દેટ વોઝ GKGH હોસ્પિટલ. તો સર ટુક ધ કેસ સો નાઇસલી. હી કોલ્ડ મી. ત્યારે તો હું સરને મળ્યો પણ નહોતો, પણ હી કોલ્ડ મી કે ભાવિક આવું ક્યારે બી થાય ને તો શરૂઆતમાં કહી દેવાનું. અને તે ફાઇલમાં છે ને MTP ડન એવું લખ્યું છે, એવું ના લખતો, DNE ડન લખશે અથવા ચેક ક્યુરેટ ડન લખશે. તો અજાણ્યા યંગસ્ટરને જે આટલું સારી રીતે પ્રોટેક્ટ કરી શકે એવા લોકોની છત્રછાયામાં જ છે ને સોસાયટી ફૂલે ફલે, સમજણો. અને મેડમે જે વાત કરી કે પહેલે કલીગ કાપવા નહીં કરતા, પણ હવે આપણી પાસે એવા સિનિયરો છે જે જુનિયરને પ્રોટેક્ટ કરે છે. સો everybody we should adopt this culture. We are thankful for Damayanti ma'am also for accepting these awards. એમના ફીદર્સ તો નિર્મલા મેડમે કીધા ને આમ આપણે તો ગડગડા થઈને સાંભળ્યા એવું લાગ્યું. We are thankful for all the faculties today. Sagar Thakkar sir, Hemangini ba, Kundan Modi sir, Gopal Irani sir, Surbi Venkar ma'am, અને હમણાં થોડા ટાઈમમાં પુનિતભાઈ હું અને બીજા બી થોડા સ્પીકર્સ એમાં જોઈન થશું. વી આર થેન્કફુલ ટુ દિવ્યા ટેકાણી મેમ અને નિર્મલા શર્મા મેમ જેણે આજની શરૂઆતથી કરીને લાસ્ટ સુધીની ઇવેન્ટમાં એન્કરિંગ સ્મૂથલી સંભાળી લીધું. We are thankful for the owners and the managing team of this beautiful place. જેટલા લોકો આજે આવે ને પહેલે મને એક જ વસ્તુ કીધી કે બહુ સરસ જગ્યા છે, જગ્યા બહુ સરસ. તો આ સરસ જગ્યા માટે આપણે we are thankful for the owner of Times Square Club, the Villa, Mr. Om Mehta and team, for providing this wonderful banquet hall, food, audiovisual support and cooperation at multiple levels. We are thankful to gynec department of all the three areas, that is GIMS Bhuj, CHC Anjar and CHC Rambagh Hospital, for sending their consultants and students for making this gathering a successful gathering. We are thankful to photography and videography partner Hasdil Bhai. Hasdil Bhai is like permanent partner with us since last 4 or 5 gatherings. We are thankful to all the delegates and students who have come from all the way. I will just name some of the talukas, and if any of the persons available here, you can raise your hands. We are thankful to the faculties from Anjar, Gandhidham, yes, Bhachau, Kinchit was about to come, Rapar, Mandvi, Nakhatrana. So we have this much strength in our society and almost 8 or 9 gynec. Gandhidham, we have got a huge strength now. We are around 40 gynecologists.
Total, we are, I think, 83.
We are 83.
With subscription which we paid, Booth Society has reached to 83 now.
We are 83 number. And we should pledge that in every gathering, at least 60 or 70% gathering will be there. So in this way only we will grow. We are thankful to our supporters, the Mayank Bhai Bhatt from Zydus Pharma Gynecs division. We are also thankful to Corona Remedies and Intas Pharma to support us in this event. Thank you very much.
Now over to the second session. I'll like to invite on the stage our chairpersons, Dr. Hirani sir, Dr. Jasmine Ben, and Sagar Bhai. दोनों है. हाँ नहीं पूरी.
So starting with the second session, I invite upon the stage our next speaker, Dr. Surbhi Vegar ma'am. She does not need any introduction, but for the formality's sake, she has passed MBBS and MD from NHL Medical College. She has done advanced training in laparoscopy at Germany, advanced training in infertility at Ruby Hall Clinic, Pune. She has practiced consultant gynec at Sadbhavna Hospital, practiced as a consultant gynec at St. Joseph Hospital, established in Management Department of Gynecology at MMPJ Hospital. She started private practice in 2013 and established Spandan Maternity Home. Now Spandan Maternity Home, as everyone knows, has been flourishing very well, and she has recently started IVF services in Spandan Maternity Home in 2019. Over to you, ma'am. She will be speaking on medical management of endometriosis.
Everyone who has just went to get the refreshment, please take the tea and come back to the hall again. બધાને કીધું ચાલીને આવી જા. દેખાઈ દો છો.
Better you solve it here.
You can start. आवाज सुनते ही आ जाएंगे सब.
थोड़े कोई तो आए खाली चेयर को क्या सुनो.
It is usually a never-ending dilemma. Always laparoscopy people will be in favor of surgery for endometriosis, and always IVF people will be in favor of medical management. So today we will have a proper guidance from you.
Actually, I have tried for it only because everybody knows what medical management we are doing. But I have tried to tell ki when you should go for a medical management and when you should go for a surgical management. Actually, that is the main dilemma in endometriosis.
That is a very thin line, and how to decide which management you have to do.
So basically, I have done this ASHRAE guidelines. So I find ASHRAE guidelines, they are very useful, very हेलो, इसकी आवाज़ ज़्यादा बुलंद है. So अच्छा So, जैसे कि we welcome you all for this Kutch Convention 2024. तो start the session. Before we start the session, 2 lines for Kutch. 2 lines for Kutch. भले असी डठो कच्छ, लगो असां के मठो कच्छ, मठा लगा माड़ो कच्छ जा, ने मठो हमीसर. मन भरी ने माणिया तेज, एड़ो असां ते वडो कच्छ. So, salt everywhere, पर सबके मनों में इतनी मिठास है कि वो पता नहीं नमक में से आती है कि चीनी में से आती है. चलो तो medical management of endometriosis. So the main problem, everybody knows which are the medicines which are available, though I am going to highlight some of the medicines which are available and which are the future prospects also. So the main problem in a patient with endometriosis are 2 things. One is pain and second is infertility. Sometimes the patient with endometriosis, they come with pain, and the other category is the this infertility. So let us see patients who are having endometriosis and having pain. So what we should do? Surgical management or medical management? So the PICO question about this is, PICO, what is PICO? PICO is problem. This is all ASHRAE guidelines. These guidelines are not made by me. This is ASHRAE who has decided what to do and when to do. These are the latest ASHRAE guidelines. PICO is problem, intervention, comparison, and observation. So this is PICO question. Are surgical therapies more effective than medical therapies in patients with endometriosis with pain? So what is GPP? Good practical points. Individual preference should be given. We should look upon the side effects, individual efficacy between hormones and the surgical treatment. So there was a study with Versalini et al. in 2018. What he did, he took 2 groups of patients. 50 patients were enrolled in medical management and because I committed it's okay. So 50 patients were enrolled for medical management and 36 patients were enrolled for surgical management. So in those 50 patients who were enrolled for medical management, 5-6 patients they withdrew because of the side effects of the medicines. And in those 36 patients who were enrolled for surgical management, 6 patients they had severe surgical complications, so they were withdrawn. So what he concluded is 78% women with deep endometriosis were satisfied with medical management, and 76% patients with deep endometriosis were satisfied in surgical group. So what are the pros and cons of surgical treatment? The pros is that it gives an immediate relief. The problem with surgical management, it is an invasive procedure, so the complications of surgery, risk of recurrence is there with surgical management. Second comes the medical management. The pros are it is a non-invasive thing. Anybody can give it. You don't need a very high level of expertise in giving medicines to the patient. The problem with this is that the short-term and long-term side effects are there. medicines to be used for long term. These are the problems with medical management. So we saw what to do in a patient with endometriosis with pain. So the conclusion is that both medical and surgical management are equally effective. You can choose, you can give the menu to the patient, you can decide on your own what the patient wants to do, telling them everything about the pros and cons of surgical and medical thing. Now comes the patient with endometriosis and infertility. The PICO question, again I explained you what is PICO question. Are medical therapy effective for endometriosis and infertility? Recommendation is that if a patient comes to you with infertility, you should not do ovarian suppression to treat the patient. If a patient comes with you with endometriosis and if you are operating a patient, then no to post-op hormone suppression. That we all agree. Previously what we used to do, if a patient, we are operating a patient with endometriosis, then we give post-op GnRH analogs or maybe whatever hormones to suppress the endometrium. But now what the recommendation is, you treat the patient surgically and immediately start the treatment for infertility. Suppose a patient comes in whom you have operated, but patient says, I don't want to become pregnant now. Then what to do? So in those patients, you can give hormonal suppression in those who you have operated, but at present they don't want to become pregnant. So next big question for endometriosis infertility is, does surgery improve the chances of natural conception? कि हमने बोला पेशेंट को कि हाँ आपको endometriosis है, you require surgery, we did the surgery, just telling them कि this will increase the chances of your natural conception. So the good practice is that surgery should be done depending upon the pain symptoms, patient's age, previous surgery, presence of other infertility factors, ovarian reserve, and the EFI. What is EFI? Endometrial Fertility Index. We will not go into detail of it. Suppose a patient with age like 36, 37, so we cannot say that we'll do the surgery and that will increase the chances of becoming pregnant, you becoming pregnant. Suppose there is already patient has undergone previous 1 or 2 surgeries for endometriosis, in those patients also we will not recommend surgery. Suppose there is a presence of male factor infertility, then in those patients we will not recommend you go for a surgery. And suppose already patient is having a poor ovarian reserve, then in those patients also we will not recommend surgery. Early stage, it improves the chances of getting a pregnancy. Endometrioma, the main hitch, whether we should operate or whether we should not operate before starting a infertility treatment. Actually, still, they also don't know what to do. There is no conclusive study that the endometrioma removal increases the chances of getting a pregnancy. In fact, you should talk to the patient that we will remove the endometrioma only if it is painful, only if it is symptomatic. Again, that will reduce the AMH, that will reduce the ovarian reserve. In patients with deep endometriosis, only if the patient is symptomatic, then we will go for surgery, if those patients who are wishing to conceive. Then, in patients with endometriosis and infertility, PICO question is medical artificial reproduction effective in assisted reproduction, effective in infertility with endometriosis? The recommendation in early stages, IUI with ovarian stimulation. IUI alone, no. IUI with ovarian stimulation is good practice. In women with endometrioma, if you get a good antibiotic coverage, then at the time of pickup, the chances of abscess formation is very low. So it's not that if there is an endometrioma and you are doing pickup in patients who are going for ART, there will be high chances of abscess. It is not there, the chances are very low. ART does not affect the chance of recurrence in endometriosis. Those who are practicing IVF, both agonist and antagonist protocols can be used. So what is the medical management? This is the main topic. अभी तक तो हमने ही सोचा कि इसमें क्या करना है. So the main topic is the medical management. The analgesics, we all know, NSAIDs, the paracetamol, I will not go into detail of it. Then the first line treatment. First line is combined oral contraceptive tablets. Very easily available, everybody is using now and then. The question is whether you use it cyclical or whether you use it continuous. Yes. The effect of continuous COCs, combined oral contraceptive tablets, is better.
The dysmenorrhea, chronic pain, dyspareunia is relieved more good with continuous COCs. If you are giving cyclical COCs, dysmenorrhea might be there. Chronic abdominal pain is like 50-50. So it is better you give continuous COCs in a patient with endometriosis. Progesterone. So the dydrogesterone. जब हम MBBS में थे ना, मतलब एटलीस्ट मैं MBBS में थी, तो मेरे को ऐसा था कि कोई भी क्वेश्चन हो ना, एस्ट्रोजन प्रोजेस्टेरोन लिख दो तो आंसर राइट होगा ही। कहीं पे भी प्रोजेस्टेरोन दो आंसर राइट ही होगा, उसमें कोई सवाल ही नहीं है। So progesterone anywhere you give, you are right. So dydrogesterone is a very good drug. Previously we had only one company, but now every now and then everybody is coming with dydrogesterone. The good point is it is better absorbed orally. It is similar to endogenous progesterone. The mechanism of action is its initial desensitization of endometriotic lesions and eventual atrophy of the ectopic endometrium. It causes atrophy of ectopic endometrium without affecting the normal endometrium. The dose is 10 milligrams twice a day. Now recently the pharma companies are coming with 20 milligrams sustained release, and I can see 30 milligram also sustained release. So one tablet for like you don't need to give it thrice a day or twice a day. So you can give. This slide actually is not related with the topic, but then also मैंने बोला ना वो progesterone कहीं पे भी दे सकते हैं. So the beauty of this progesterone, the dydrogest, is कि you can give it in threatened abortions, you can give it in recurrent pregnancy loss, you can give in patients with infertility, and again you can give it in patients with endometriosis. So beauty of this wonder drug कि कहीं पे भी लिखोगे तो गलती नहीं होगी. ठीक है. So next first line treatment in endometriosis is Dynogest. This is my favorite. Again one more favorite is coming, but this is again my favorite. Dynogest, it binds with the progesterone receptors. The binding capacity with estrogen and mineralocorticoids is less. Side effects are less. It has a very low half-life of 10 hours, so there is no risk of accumulation, and the dose is like 2 to 4 milligram daily. And the longest study with this Dynogest is like 60 weeks. Some people are claiming it is safe for 8 to 9 years also, but I found the best safety in like for 5 years. There are some कोई भी चीज़ बिना side effect के नहीं होते, डोज के साथ भी काटे तो होंगे ही ना. So Dynogest, the side effects are breast pain, headache, acne, weight gain. In some patients there is loss of libido, GI disturbances, hair loss, and sometimes patient may experience vaginal bleeding. There are some other progesterones which can be used, like medroxyprogesterone acetate, depot preparation. It is a very like cheap alternative. Antiprogesterones like gestinones. Danazol previously we were using, nowadays we are not using. And this is the one I like the most. अभी तो patient आके बोलते मैडम मेरीना डाल दो ना. So levonorgestrel releasing IUDs. It is used for 5 years. It has 52 milligram of levonorgestrel. It releases 20 microgram LNG daily. The best part is that once it is inserted, it's done for 5 years. It is good for those who are having endometriosis and pain. It is good contraception for those patients who are not wishing to conceive, and it is always a reversible option कि कभी भी चाहिए तो उसको निकाल सकते हैं. The side effects are कि initially you have to counsel your patients very meticulously because initial cycles will be very disturbed. Like कभी भी आएगा कभी भी जाएगा पता नहीं चल रहा मैडम पूजा करें कि ना करें. तो that is the main problem with the patients कि मैडम पता ही नहीं चल रहा bleeding कभी भी आ जाता है यहाँ जाती हूँ bleeding आ जाता है वहाँ जाती हूँ bleeding आ जाता है. What to do? Whether it is menstrual blood, whether it is abnormal bleeding, what ये है क्या? So you have to counsel the patients very meticulously कि the periods will be irregular for initial cycles. It may cause 1 or 2 kgs of weight gain, but if you do regular physical activities, physical exercise, there's no much of weight gain. It may cause like fluid retention, breast pain and all. And the major disadvantage, it reduces the number of hysterectomies. So the ones who are having this laparoscope in the hand, including me also, so that is the main problem with the LNG IODs. Since second line treatment is GnRH agonist, it is second line, considered to be second line. It can be used for 6 months only because of the side effect profiles. You have to prescribe a add-back therapy. Add-back therapy जैसे हम पिछले पहले सोचते थे कि like calcium, vitamin D. It is not the add-back therapy. Add-back is the combined oral contraceptives or maybe progesterone, estrogen. Tibolone can be used as add-back therapy. The dose is 3.75 milligram for 1 month depot preparation. or 11.25 for 3 months. GnRH agonist, in spite of having more side effects, decreases their pain lesser than the LNG IODs. So patients, once you insert LNG IODs and you counsel them nicely, so they are really happy and they come to you after 1 year कि मैडम वापस से कितने सारे पेशेंट आके मैडम 5 रुपए मैंने वापस रख दो ना अभी इसकी बिना तो मज़ा नहीं आ रहा है. So they come back, they get it inserted next again also, and they are really happy. Then second thing is GnRH antagonist. The one we know is cetrorelix. It can be used. The initial flare-up with the GnRH agonist is not there. And the best part of it is that there is a small amount of estrogen which is released in the blood. So only thing you need to do as an add-back is like calcium or vitamin D. You no need to add estrogens and all. In most of the cases, 60% cases, regression occurs. Dose is 3 milligram once a week over 8 weeks. And it's a good practice. You can use this. This I didn't know before. When I was making the PPT, I came to know about this. There are oral and GnRH antagonists also available. And this is available in India also. I didn't know that. The one is elagolix. This is, the trade name is Orilissa. The other one is Religolix, Orgovix, and the last one is Lisagolix. So these elagolix and Religolix is available in India also. The only problem is the cost. Surgery theja na yaar. Patient is happy and we are also happy. Surgery theja. The cost is very high. It is like 32,000, and the maximum duration you can use it for 24 months. As I said, the add-back is only calcium and vitamin D, and the symptom relief is good. 75% patients have a good relief in symptoms. The side effects are hot flushes, acne, and nausea and headache. देन सेकेंड लाइन में एक और है एरोमेटेज इनहिबिटर. लेट्रोजोल अभी जैसे प्रोजेस्टेरोन देते हैं ना, ऐसे लेट्रोजोल भी कहीं पे भी दे देते हैं, ऐसा लग रहा है मुझे. तो एरोमेटेज इनहिबिटर्स वी कैन गिव like 5 milligram per day. It inhibits aromatase activity and thus the biosynthesis of estrogen is decreased. In last sessions we were discussing that. So that way they are helpful in treating the patients with the endometriosis. So these are the things in medical therapy which are available. Some things are available in India. This is very costly, but the two things which I can rely on is Dynogest and levonorgestrel releasing intrauterine devices. The take-home message is कि medical ऐसा नहीं है कि आपके हाथ में scope है तभी आप कर सकते हो. Endometriosis can be managed equally well medically and surgically, even in cases of deep endometriosis. Treatment is tailor-made. It is according to patient's need and symptoms. A clinician should have both the modalities of treatment in their armamentarium to give the best outcomes to the patients. Thank you so much.
Any questions from the audience?
પણ હવે ડાયગ્નોસ્ટિક્સના સેફ્ટી ડાટા હવે આવડા લાંબા થઈ ગયા છે, તો એ લોકોએ બી આ ઇન્ટ્રાયુટ્રાઇન ડિવાઇસ 5-5 વર્ષવાળાને એવું ના લેવું જોઈએ.
So
डायनोजेस्ट का आयुर्वेद
डायनोजेस्ट का हाँ ले तो आना चाहिए, ले लेके आ रहे हैं जब तक. पर लेकिन ये लेवोनोजेस्ट्रल आयोडीन सच में इट्स रियली वर्क
પણ એના
वंडर्स.
પછી કોઈ આયોડી આવ્યા જ નથી એમ કહેવા માંગુ છું.
નહીં, નહીં, તો-
LNG ના આવ્યા, એના પછી બીજા કોઈ પ્રોજેસ્ટ્રોનના આયોડી આ લોકોએ કાઢ્યા નથી.
ये तो ठीक है હવે तो
ટેકનોલોજી બીજા પાસે નહીં.
हाँ मे बी ये लोगों ने नहीं
એ
हंसे.
લોકો તો લ્યા,
પેટન્ટ એક્સપાયર થાય ની રાહ
કાઢ્યા
જોશે.
ને, આપણી પાસે
बाकी
real
अपना
iodine.
ड्रग नहीं फार्माकोकाइनेटिक्स फीलिंग करते हैं.
हाँ ये कई हंसे दैट वी डोंट नो कि व्हाट इज द रीजन दैट वी आर नॉट गेटिंग एनी अदर IUDs. बट LNG IUD इज वर्किंग वेरी. और ऐसा एक पेशेंट था मेरा, एंड इन पेशेंट विद एंडोमेट्रियोसिस ऐसा भी होता है कि लाइक वंस वी हैव पुट ऑन वन ऑफ माय पेशेंट, शी वाज 37 व्हेन वी डायग्नोस्ड endometriosis, so she was having severe pain. So I put her on Dynogest. She took Dynogest for 7 months. After 7 months she again came कि मैडम अभी अच्छा नहीं लग रहा, पेन हो रहा है. So what we did, we inserted intrauterine device. So she was spotting for 6-7 months. But patient was educated, she was not having any problem with that spotting. The blood loss was not there, only spotting was there for maybe 6-7 months. But she was okay with that. So after 7 months she said कि अभी Dynogest बंद किया, LNG IUD रखा. After 7 months she said कि मैडम अभी इससे भी थोड़ा सा spotting है और पेन वापस बढ़ गया, अभी क्या करें. So what we did कि because she was spotting, so what we did, we added Dynogest along with the LNG IUD. She was comfortable for 3-4 months, but the problem of spotting was still there. So what we did, we removed the IUD, we did a DNC, we took all the pap smear, DNC, endocervical, everything we did. Then we reinserted IUD and she was fine. For 3 years, she is very happy with the, again, reinsertion of IUD. So it is tailor made in the sense कि it is actually tailor made कि like एक बार काम किया तो नहीं किया तो दूसरा रखो, दूसरे में नहीं किया तो फिर वापस से वही करो, कैसे न कैसे पेशेंट को अच्छा हो ही जाता है. It's not always necessary that you come with the scope, you come with the gun if you see a patient with endometriosis. Second patient had endometriomas, bilateral endometriomas. One set is for 10-12 centimeter, the other was 3-4 centimeter. So patient came to my OPD, she was just crying कि मैडम आप मेरे ओवरीज निकाल दो, मुझे चाहिए ही नहीं, मुझे इतना पेन है, मुझे चाहिए ही नहीं. तो उसने कहा कि आई विल गो फॉर ओनली 1 cycle IVF, ओनली 1 cycle आई विल डू. If I conceive, it's fine. Otherwise, you remove my ovaries. I don't want them because I'm in so much of agony. So उसको कहीं से सुन लिया था कि हाँ IVF कर सकते हैं इसमें. तो she said कि 1 cycle chance लूँगी. Luckily, in first cycle she conceived. In first cycle with 10 centimeter endometrioma and 4 centimeter endometrioma on the other side, she conceived in first cycle. रेडियोलॉजिस्ट के पास जब सोनोग्राफी कराने के लिए गए तो रेडियोलॉजिस्ट से बोला कहाँ पे ट्रीटमेंट चल रहा है आपका?
मैडम इसमें फ्रेश ट्रांसफर किया था या फ्रोजन किया?
नहीं, हमने फ्रेश ट्रांसफर किया था. हाँ अभी ये लोग ऐसा है कि फ्रोजन ट्रांसफर के रेट्स बहुत चांसेस अच्छे हैं. No, it's not नहीं. Ashray, what Ashray says कि it is हाँ.
There are many more than one schools of thought. But according to recent guidance, like if the endometrioma is having less than 5 centimeters, then we can go without removal of the endometrioma. We can do pickup. Then freeze the embryos, and after downregulating it, we can do frozen.
Frozen trans. हाँ, we can do frozen. That also we can do. मतलब anything we can do what we want to do.
But 10 centimeter is like
10 centimeter is a very big, very big. It was actually exceptional. That was very big, and fresh transfer we did, and the patient conceived in first cycle, and that was a first IVF case. That was a first IVF case.
पहले ये बोलते थे कि when you are doing wrong pickup, it doesn't matter if you puncture endometrium. Just give IR antibiotic. अभी क्या बोल रहे हैं? You should not puncture the endometrium. नहीं तो you will end up with a pelvic abscess.
You try not to puncture the endometrium. You try not to. That is for sure. You try, don't puncture the endometrium. Endometrium puncture होता है तो it gives rise to some complications you can come across. You will try that you don't puncture the endometrium, but with good antibiotic coverage, the chances of abscess formation are low. We are doing ovum pickup, that is, and if patient is having endometrium, that is not the only criteria that you do a surgery before doing IVF, because again that decreases the reserve.
आप ये मेरा भी एक ऐसा था, राइट ओवरी में 2 एंडोमेट्रियम, 2.53 से छोटा छोटा 2 एंडोमेट्रियम, 5 years of married life, एक तो रिस्ट्रो लेब्रोस्कोपी, नेक्स्ट आफ्टर पीरियड बुलाया तो उस पीरियड में एमेनोरिया प्रेगनेंसी लेके आया.
Any experience with spontaneous expulsion of Mirena?
I had 2 patients who had spontaneous expulsion of Mirena. एक में हमने वापस से रीइंसर्ट किया कि उसको ब्लीडिंग हुआ, पूरा का पूरा निकल आया, बाहर ही निकला, पेशेंट हाथ में लेके आया, मैडम बाहर. हाँ, देयर आर केसेस, तो उसमें हमने दोबारा से उसको रीइंसर्ट किया एंड शी इज फाइन. वो दूसरे वाले को निकाला तो शी वाज नॉट विलिंग कि नहीं अभी मुझे नहीं रखना है, एंड शी लॉस्ट द फॉलो. बट देयर आर चांसेस कि Mirena कैन बी एक्सपेल्ड स्पॉन्टेनियसली.
Beyond what size of uterus LNG IUD expulsion rate will be more, or you won't recommend to put LNG?
I think I don't think there is a specific size ki beyond this the chances of expulsions are more. I don't think so. And any size of uterus, if the patient is willing and if patient, you can put LNG IUD because there's no harm in putting it. You can at least before going for a surgery, you can give it a try. If it works, then it's good. If it doesn't work and the patient is not having any mechanical discomforts, then it's fine. If the patient is doing good, you can just keep it there. And the patient, if there is mechanical discomfort, कि urine में problem है, constipation है, XYZ mechanical symptoms हैं, then you can go for a surgery also. Otherwise, there is no specific size कि beyond this, the chances of expulsions are more. It's not that.
I have got one question. A female 26 years old, primary infertility case, uterus is normal size, male factor is normal, has got bilateral chocolate size is 2.5 and 3 centimeter, AMH level is around 3, 6 cycles of treatment taken, ovulation is still not pregnant. Whether we need to go for a laparoscopy or wait?
You can, basically the treatment is, it depends. जैसे बोला ना patient को सब समझाने का कि ऐसा ऐसा है. Let the patient decide what she wants to do. You can tell her कि you have 2 endometriomas in both your ovaries. The problem with surgery is that she will be, if she is painful, if the endometriomas are painful,
Not painful.
Not painful. Suppose it is not painful. You have this endometriomas. तो पेशेंट को समझाने का कि देर आर चांसेस कि बिकॉज ऑफ एंडोमेट्रियम देर माइट बी सम adhesions and all, so tubes might not be good. If you want, we can remove the endometrium, but the problem with removal of endometrium is some normal tissue is going to be removed, so the image can come down. Otherwise, if she you gave her like 3 cycles of ovulation induction. So you can try, as I said, you can try ovulation induction with HMG, and you can go for an IUI. HMG tried, you can go for an IUI. If she is not conceiving with IUI, then you can just tell her that there are 2 options: either you remove your endometriomas and we can go try for a natural conception, or else you can straight away go for an IVF.
26 years female patient directly IVF.
Actually, it is a myth. It is a myth. No, but you have to tell them it is a myth कि when you are 35 or 36 at that time only you need an IVF, because earlier the better.
But usually patient at 26 won't accept. So Indian treatment, if we go, they usually prefer to go with laparoscopy.
So you have to tell them कि उसको ये नहीं बोलना चाहिए कि भाई आपने मुझे बताया क्यों नहीं.
Exactly. So everything has
You have to tell them. You have to discuss with the patient कि these are the treatment options.
Shortest option of IVF should be offered in the first visit of infertility.
Yes, exactly. You have to tell them that these are the treatment options for infertility, and now you choose what you want to do. Because I may be ready to wait for like 3-4 years, but she might not be able to ready to wait for 2-3 years also. My husband is going out of town, so I need a quick result. So it depends upon the patient's. But you have to tell them. जब तक आप बताओगे नहीं कि 4 कलर की साड़ी है तो पेशेंट सेलेक्ट कैसे करेगा? You have to tell them कि ये कलर भी है, ये कलर भी है, ये कलर भी है. Then let her choose.
I know just continuously then 1 year.
Continuously you can give for 2-3 years. 5 years तक का डेटा है. देखो, this is when I was in Leva Patel, when I joined Leva Patel, the cost of Mirena was 8,500. 8,500. उसमें पेशेंट को काउंसिल करना मिरीना के लिए, पेशेंट यूज्ड टू टेल कि मैडम 8,000 8,500 की मिरीना रखाऊंगी, इससे अच्छा ये नहीं कि मैं सर्जरी करा लूं.
But now even the study which was done, which you showed, that definitely I feel not because I'm left surgeon, but I feel it is biased because at one point initially the study was done at a stage when laparoscopy or any surgeries were evolving. If similar surgery,
It is the latest tertiary guidelines, 2022. After this, the guidelines are not published.
When you do surgery, there are many in bias in what I say, feel like in surgeons, whether same surgeon is being operated or not, whether it has been operated by the same center or not. So there are many things which we should connect, because this same guidelines was even discussed at IIG also. And definitely, lab surgeons will never promote
medical management.
They don't want to give it to pharma.
5-6 centimeter endometrium 35 years to patient तो पहला IVF करने 10 है तो पहला डायरेक्ट IVF करते हैं एंडोस्कोपी पर देखिए हार्डकोर एंडोस्कोपी से पहला एंडोमेट्रियम
रिमूव कर से. हाँ.
So that definitely, but endometrium
ऐसी दवा पड़ा.
ना.
See, when
endometrium remove करेंगे IVF करते हैं.
Endometrium is all whether they conceive or not, but at least their quality of life will improve. The
patient is having pain, she doesn't want fertility.
મેડમ 22-24 વર્ષની છોકરી હોય એના મેરેજ નક્કી નથી થયા તો શું એને સફર કરવાનું? દવા જ ખાશે ને?
હા તો you can
અને
give time
એન્ડોસ્કોપી સર્જરી કરાવ્યા પછી શ્યોર થોડી છે કે
recurrence નહીં થાય. હા
સાસરામાં જઈને ફરીથી ઓપરેટ કરવાનું?
ઓપરેટ કિતની બાર
હવે સાહેબ હવેની જે સર્જરી ટેકનિક છે એમાં recurrence rate has come down drastically. Even if you ask recurrence has come down to less than 1%. પણ તમે 6 મહિના 9 મહિના 2 વર્ષ 3 વર્ષ આપણે ડાયગ્નોસિસ ખવડાવીએ પછી બંધ કરશો પાછા જ્યાં હતા તેને આવ્યું.
ના ધારો કે હા
સપોઝ કે આપણે સર્જરી નથી કરતા ડાયગ્નોસિસ કોઈ પણ અધર સપ્રેશન આપીએ પછી તમે મેરેજ થઈ જાય પછી 4-5 વર્ષ રહીને ઓપરેટ કરો તો ડાયગ્નોસિસ આપતી હોય ને ના આપતી હોય બંનેમાં ટિશ્યુમાં શું ફરક પડે છે?
ટિશ્યુમાં ઘણો ફરક છે. ટિશ્યુઝ એકદમ ફાઇબ્રોસ થઈ જાય છે પછી ઓપરેટ કરવું ને ઇટ ઇઝ વેરી ટફ. ફાઇબ્રોસ which will lead to more complication. એટલે પ્રાઇમરી જો ટ્રીટમેન્ટ અગર પણ પ્રાઇમરી
ડાયગ્નોસિસ નહીં આપવાનું બીજું આપ પોસિબલ સેમ
તમે લોંગ ટર્મ માટે કોઈ બી વસ્તુ પ્રોજેસ્ટ્રોન આપશો ને મને
पर मेरी बात सुनो, अगर मान लो कोई यंग गर्ल आती है आपके पास 16-17, तो व्हाट विल यू डू? यू विल एडवाइस हर फॉर सर्जरी?
But depends on endometrium and the symptoms. complaint symptoms are severe dysmenorrhea and if the endometrioma is more than 4-5 centimeter, तो remove करूँ पड़े. हाँ, 2 centimeter obviously
नहीं
nobody
नहीं,
will remove. 2
it
centimeter
doesn't
is
depend upon
centimeter.
the size of endometrioma whether it is symptomatic or not. Even a 2 centimeter endometrioma can be more symptomatic than 5 centimeter endometrioma.
Agree. Depends on the tissue and the tissue and the adhesions inside, definitely. But for
અને
2
તમે
centimeter patient might not be ready, you can give. But what we have seen, I don't know, but what we have seen, even when we now what engine classification has come down for endometriosis and everything, they say that if there are symptoms, severe symptoms are there, then surgery will give you up, will improve, or almost 90 to 96% of symptoms will come down. And almost whoever is practicing endometriosis, definitely laparoscopically, if you do proper clearance, હું ખાલી cyst removal નથી કહેતા. I'm not talking about cyst removal or radical total if you remove the whole tissue, right, bilateral peritoneectomy થી લઈને, then definitely the chances of recurrence will be less than 0.1%. Since 5 years at our center, we have seen not a single recurrence in endometriosis. Or even if you ask Deven sir also will be the same opinion, because approach of surgery has different. Initially bilateral peritoneectomy was nobody was doing up 15 years back or 10 years back. So that in that scenario I'm saying કે surgeon no approach same સગ્યા થયું હોય, center જોવાનું and the quality of the surgery, then if you compare the study, I think that will give a better result.
One question. Okay, what is the cause of endometriosis?
Definitely.
This patient
Cause-
presented with endometriosis. I'm not against surgery, I'm a laparoscopy, I'm also doing endometriosis surgeries also. But the problem is, okay, what is the cause of endometriosis? So initially, when the patient was virgin, the pelvis was virgin, then also she had endometriosis. कुछ भी कारण से उसको endometriosis हुआ, ठीक है, आपने surgically you removed everything, I agree. आपने जो भी था you cleared it everything. But she has an inherited tendency of this ectopic endometrium to go again. So there are chances that you get a recurrence.
Will be there.
And the enzyme classification, what we are talking about enzyme classification basically is a mix of diagnostic and surgical thing. It is not before diagnosis you are going for an enzyme classification. It is basically what you did, you mentioned in a particular format, that is enzyme classification. Enzyme classification is not something that before surgery you are putting it, this enzyme classification patient is coming and I am going to operate according to this. This is basically a mix of diagnostic and operative thing.
Yes. But
So-
again, my concern only is that when you give all this dinogestrone and all progesterone, but usually what we have seen, once they stop, the recurrence of symptoms comes back in 2 or 3 months, and then again we are at the square one. And
I agree.
probably
Once you
after
stop,
doing surgery, after that, it is more tedious and more challenging.
I
for
agree,
health
I agree, 100% agree. But if a young girl comes to you, she is in pain, she is having endometrioma, at the age of 16 you cannot offer her surgery. Then maybe 3-4, अब वापस होगा तो क्या करेंगे? 5 साल का डेटा है आपके
but
पास.
surgery will improve the quality of. Again, endometriosis is a debatable topic. I'll tell because.
Let's discuss this later on. It is a never-ending topic. You
But
what to do and when to do. But
that's-
5 years, you have the data of 5 years. But she is 16 only. At the age of 21, 23, she again has the same problem. Then what will you do? Because your surgery is excellent. I agree. Because of surgery, there is no recurrence. But she already has the tendency of this ectopic endometrium to go inside. Then what will you do about that? So again, she lands up in a surgery. So best thing is till she is not conceiving, till then you can just pull on. You can put a LNG iodine unmarried also.
Yes, we can.
You can put
જ્યારે
બચ્ચા કરવાનો ત્યારે જ ઓફર કરવાનો and you have to tell her that this might reduce the chances this your ovarian reserve. In fact, endometriomas per se can reduce the ovarian reserve.
But then the surgery will be challenging once you give this, because we have seen patients.
In the experts and nothing is challenging.
That is
After such an insightful talk, now we move forward. We have now Dr. Hirani sir.
Need a break.
I invite Dr. Hirani sir for next talk. He is most senior gynecologist of Kutch. He has been serving people of Kutch since 35 years. He has pursued MBBS and MD from MP Shah Medical College Pioneer in Kutch to provide advanced services like USG, laparoscopy, and ART procedures. He's professor in Dani Medical College, Bhuj. He's founder secretary of Bhuj Obs and Gynec Society since 1995. Chairperson for SOGO 2004 and 2021. President SOGO 2021 to 22. Over to you, sir. Sir will be speaking on hematological investigations during various trimesters of pregnancy, which are must or which are suggested.
Hematological investigation. Hematological investigation during the pregnancy. So, during pregnancy in the different trimester, so routinely any patients comes to us. So, laboratory investigations, basic investigations. So, what investigations usually we must do it and it should be suggested. Uh, First of all, any patient comes to us for the pregnancy diagnosis. The patient says that my LNP was this. Usually, I got period before 4 days, so already 1 month and like 10 days, 12 days, like that. I done twice urinary pregnancy test at my home, and it is positive. Usually, the pregnancy test comes positive. We know that it is 30 to 50 international unit is positive. And you will suppose a patient comes to you and you will do the sonography and you didn't find any gestational sac, then what to do? So better to search for any other locations. And for confirmation, the patient many times ask that you whether I would like to travel, what to do, what precaution I should take. So better to even confirmations. So then the beta ECG is the must. So any beta ECG base level will guide a lot. If do beta ECG in first and you are not finding, suppose a patient has 6 weeks calculated gestational weeks on sonography, 6 to 7 weeks, still you didn't find anything. But beta ECG is 670 or 700. Then call for after 2 days whether this will develop or not. If it will not develop, then think for ectopic. So there are so many patients that come with ectopic like that. So ectopic, before diagnosis ectopic, the beta ECG is must. And usually we find gestational sac when beta ECG is more than 1500. Then next investigation comes to us is complete blood count. In complete blood count, mainly usually we see hemoglobin. Normally, hemoglobin, if we consider each laboratory have different criteria, 12 to 16, somebody says this is 100% is like that. So each red blood, any cell counter have different adjustments. But commonly, if you consider the 12 to 16s, it is a normal count. Usually in the first trimester, the count due to the hemodilution like that, the 0.5 milligram, in second trimester, 1.5 milligram, and third trimester, again 0.5. So as the pregnancy advances, that there are the chances of low hemoglobin. Simultaneously, when hemoglobin count is low, I mean, we should see for the hematocrits or RBC in the particular blood. So RBC count is simultaneously helpful. And also we should look for PCV, MCV, MCH, MCSC and RDW. Because these all parameters are helpful to us. Suppose hemoglobin is low, then it is either thalassemia or either some another reason. So this is the basic, gives hints to us what next investigation would go for that. And regarding the platelets also, the platelet usually little bit thrombocytopenia, little bit is there. And when normal count we consider as a 1,50,000, and if more than 6 lakhs, then we should ask for some hematologist help. So basic subhemoglobin level is around less than 10, we can say mild, between 10 to 7, moderate, or less than 7, we can say severe. And peripheral blood in iron deficiency, it is a MCV and hyperchromia and microcytic, and the shape is little bit different. To identify iron deficiency anemia and confirmations, the reticular count is very important, because reticulocyte count comes first from the bone marrow within 2 days, while RBC lifespan is 120 days. So to get some MCV or MCSC or MCH, the reticular count is very important. In reticular count nowadays, now Sysmex machine and some new machines are there to identify earlier, like reticulocyte hemoglobin equivalent. So RETHE is the fastest way to detect changes in the iron status. It measures the hemoglobin content of the reticulocyte and considered to be the more sensitive and early as well as early marker of the iron deficiency. Normally, it should be less than more than 28 RET. If less than that, then we can say iron deficient. Another confirmation test, suppose iron is the ferritin. But in ferritin, we should keep in mind, suppose if any inflammation, acute or chronic, then this ferritin will rise. So it will not conclusive. So red hemoglobin is the more confirmation, and this test is now available in all pathologists, and cost is nothing, only 250 rupees, like peripheral smear with RET. So it is a more confirmatory test nowadays. In reticulocyte indices, what happens that absolute reticulocyte and reticulocyte count, absolute reticulous production, it all suggests the quantity about the circulating reticulocyte. But RETH measures the amount of hemoglobin in each reticulocyte, reflected in quality of the newly produced reticulocytes. So this is more helpful in the monitoring of the iron therapy or erythropoietin or any other therapy. So this is very helpful to the response of the drugs also. So another in iron deficiency anemia, the MCH, MCHC, and MCV is reduced, while in thalassemia, MCHC doesn't differ. So here gives us hints whether you go for the thalassemia or not. Another most important thing, red cell distribution with RDW. In iron deficiency anemia, it is always, usually this is the consistent. RDW in old trimester, it is consistent around 14. If it is more than 14, you think over iron deficiency, because whatever iron will be available, according to the red cells, will try to get it more, and the width is different. While in thalassemia, always RDW is less than 14. So this is also gives us the hints whether to go for the iron deficiency or with thalassemia. Other ferritin level, just I told you that in chronic diseases, only inflammation may arise with the ferritin level. Otherwise, for confirmation, iron deficiency, serum ferritin is very good drug. Other transferrin, serum hepcidin, all are just for as a theoretical purpose, not practically help. About megaloblastic anemia. Here, MCV will be more than 96, and MCV is more than 33 picograms. And here, the maybe hypersegmentation of the neutrophils, and the LDH level, we will find megaloblastic anemia rise. About platelet, just we discuss is that if platelet is much more, but commonly in ITP patient, many a time in pregnancy are found out. At that time, the smear will show us there are large in size and tiny platelet fragments. And this is the difference between the iron deficiency and thalassemia. You will see that MCV, MCH they are reduced in the iron, but thalassemia also are less. But MCSC remain consistent, and while in thalassemia we will find hemoglobin A2 and F. So in thalassemia, as we know, that is due to it is an autosomal recessive disorder characterized by decreased synthesis of either alpha and beta globin chain of hemoglobin A. So here MCV, MCH reduced, MCH remains normal, and red cell distribution less than 14. In alpha thalassemia, when the fourth gene deletion, then we find the non-immune eye drops during the sonography. While other patients have carrier and severe anemia. Severe anemia and carrier are there. About beta thalassemia, major, minor, and intermediate. So this is a normal electrophoresis. Here we'll find the HbE2 usually remains around 2.8 or like less than 10. While this is if suggestive minor trait is there, then it is more than 3, so 5.4. So it suggests. And while major, so here we will find HbF is more, A2 level low. So here the thalassemia in this is helpful. About blood group, Rh negative, Rh positive. So in Rh negative, mother and her husband both are negative. There is no any issues. Blood group whenever Rh negative is there, the husband should be positive or can test for indirect Coombs test or past history of some abortion or any mishaps like that. So we can repeat ICT at 28 to 34 weeks, and can some people at present give NTD for that, but it is different individual choice whether to give it or not. So in indirect Coombs test, suppose this comes to the positive, then we go for the antibody titer. So titer is a critical 1 into 116. So if it is more, then you should be alert. And then titer, when it is more than 116, then it is a pakka Rh incompatibility is there. So no repetition requires. We have to manage the patient how it can be survived in vitro. So here, if negative is there, like that, we should give prophylaxis and after delivery prophylaxis. And if 1 into 16 is positive, then we should search for fetal weaning by measuring sonographically MCA, peak systolic value, and according to whether to deliver earlier or not, as the fetus is got viability. So if yes, then better to have 34 weeks, we go for delivery, or in less than that, then we think for intrauterine transmissions. About aneuploidy screening. So just we previously discussed with such about double marker, quadruple marker, NIPT like that. Here, alpha fetoprotein is not usually included in these markers. So for that, open needle tubule defect or gastrochiasis or anything, any body fluids come into the amniotic fluid, then this test is essential for alpha fetoprotein. But the sensitivity of the test is around 82%. While NIPT, the test is little bit more and more promising. So now fetal medicine experts usually recommends NIPT in the old patients when the age is high or high risk is there, or when you are more past history of such patient is there. So NIPT by that way is more, or you can detect earlier, around more than 10 weeks, you can able to, because it's on DNA, the plasma cell DNA. So around 12 weeks, we can have some conclusion, while other tests are little bit later on. So patient risk is only in age, family history or personal history, or we should counsel regarding the multifetal gestation and patient weight. While role of alpha fetoprotein is not in aneuploidy but in open tube defects. So NIPT is more promising for the testing. about viral markers. So HIV patients, each and every patient come on the first visit, we should go for HIV testing, and particularly it is advisable in third trimester because we want to prevent transmissions, mother fetal transmissions. So HIV test is very important. And diagnosis by the CD4 cell count, ELISA, rapid test like that, routinely we do it, but confirmation test is usually Western blot methods. And each and every patients who are positive or after 22 4 weeks, such HIV patient must be treated with tenofovir, lamivudine and ifavirenz regarding any count or this is the first line, and usually so we patient refer to the ART center, but this is the line of treatment. Infant usually should give syrup nevirapine and quote-trimexol prophylaxis to avoid other secondary infections. Suppose HIV is associated with there. This is the dose schedule regarding the drugs. And infant, this is usually 10 milligram per ml. Accordingly, we can titrate the dose to the baby. But this should be given to the baby 6 weeks to 12 weeks. Hepatitis B. So hepatitis B usually it is every patient should be investigated, and if positive, then confirmation with DNA quantifications. And any infected patients of hepatitis B, the chances of transmission to the baby are much more. So such patients should be advised with hepatitis. Vaccination should be also advised, like state dose after 1 month and 6 months. Hepatitis B immunoglobulin can be given to the baby and vaccination also. So when any patient DNA viral load is more than 2 lakh international unit per ml, should give tenofovir prophylaxis. Where DNA testing is not available, such patient also should be tenofovir prophylaxis must be started, because the earlier you start it, chances of transmissions are very less. So tenofovir tablet 300 milligram daily from 24 onwards, it is advisable. Hepatitis C. Usually hepatitis C routinely on the first visit you should recommended, and in hepatitis C usually found in the drug abusers, hemophilic, when a repeated transfusion, which have high risk of sexual behaviors and or such patients. Ideally, there is no such prophylaxis available during pregnancy, because all drugs, if you use for hepatitis C, all have very side effects to the baby, and even also routinely not advisable during the pregnancy. And particularly here, SGPT usually, if you will find, is very high. So here, when any patient comes to the counseling to you, so if you advise for hepatitis C and found positive, then advise for ribavirin and interferon, and advise at least for 6 months you should not have pregnancy. Because if you advise is contraindicated, if hepatitis C is there, the baby mother is breastfeeding. If she had cracked nipple or bleeding nipple or any co-infection, then also simultaneously alert to her and not to do like that. So other thing is rubella. About rubella titer, routinely you can you may ask for that, or you can ask for it. Usually any infection is there, the rubella IgM comes to the positive as early as within 4 days. So the recent infection, IgM is indicated, and IgG, if it's positive, usually it is maybe a past infection, maybe past immunizations. So if it comes positive in this pregnancy, then not necessary to give any treatment to the pregnant lady, because she is already immune for rubella. So according to titer, so when you more than 10 is greater, we can consider is a IgG positive rubella. While IgM, it is 25 is detected, then it's positive. So look out bacterial marker, VDRL. The VDRL, we know that is by the bacteria, and the confirmation test is trypanosoma pallidum particle evolution test. And in the all syphilis patients, the drug of choice is penicillin G, either for mother or the baby also. Gestation diabetes mellitus. So nowadays, the diabetes patients comes much more. So any first visit, patients comes to you, then ask for random blood sugar and HbA1c. Suppose if more than 140 RBS or 180, more than 140, or HbA1c is more than 6.5. So this considered is overt diabetes. So if result is between 140 to 80, 180, then such patient require GTT up to 24 weeks because it is a gestational diabetes, chances are much more. And the high risk patients, suppose patient is obese, positive family history of diabetes, previous history of stillbirth, history of delivery of large infant, glycosuria, unexplained neonatal death, congenital anomaly, preeclampsia, multipella, polyhydramnios, traumatic delivery, recurrent urinary infection, candidiasis. 3 spontaneous abortion, history of diabetes in previous pregnancy, and age is more than 30 years. These all are high risk. So previously there was the one-step approach was the glucose challenge test. When you give 50 gram glucose and you test for more than 140 these things. But at present the DIPSI is recommended. It is advisable for glucose tolerance, and such high-risk patients should be advised after 24 weeks. Before giving 75 gram of glucose, first 0 at the time it should be, if it more than 92, after 1 hour, it is if the more than 180, and after 2 hours is more than 150, then these are stamped as a diabetes. So gestational diabetes, you should treat it. And nowadays, there are more patients comes to us with gestational diabetes. Regarding thyroid profile, so any patients comes to you in the first visit, the TSH, T4, and TPO may require if found to be more. So if TSH usually around should not be more than 5, or when more than 10 TSH is there, then it is over hypothyroidism. And free T4, it is more advisable because laboratory people says that T3 have a very labile, so you will not find exact level of the T3. So T4 it is more advisable, and when hypothyroid is there, you go for anti-TPO. Thyroid peroxidase antibodies should be treated, and it should be less than 5.6. So overt hypothyroidism we can consider more than 10. Subclinical hypothyroidism is more common in pregnancy. So between 2.5 to 10 it is error. And anti-TPO titer more than 5.6 should be watched for in the third trimester. So, and such patients should be treated. And each and every patient who are on hypothyroid treatment, L-troxin, should be after 1.5 to 2 months, better to go on empty stomach in the early morning for the free T4 and TSH test. About hyperthyroidism, if the value is TSH is less than 0.1 microgram and free T4, T3 and T4 are less, then such patient also treated with propyl thiouracil and methimazole in the second or third trimester. So such patient also should be thyroid people, should be thyroid investigation is also the essentials. So this is a routine test. Other test, if you suggest anything or if you know, let me discuss. Whatever routinely we do in our day-to-day practice, just I narrated to you.
Sir, OGTT, should we do it regularly to all the patients?
No, when high risk is there, when high risk, better to have high risk. So in randomly, if you want, yes.
जो पेशेंट्स आते हैं वहाँ से एयरफोर्स वाले ना दे all the patients are doing in all their patients I think they are doing their OGTT at 25
Due to the awareness, awareness is due to the awareness, the people are also demanding for that. But nowadays, you see, when previously and my present practice, I really see more patients of gestational diabetes. So many patients,
So we should make
routinely. So better give for GTT. Better to go for our separate side. Better to go for some educated patient. He says go for GTT.
And what the gestation age is like 25, 24?
More than 24, 24 to 26 weeks.
24 weeks.
Each patient should be advised for gestation. HbA1c, if initially is more helpful, afterwards HbA1c doesn't, is very misguiding. I was using HbA1c, but I had found that last time random blood sugar is around 230, 300 like that. So actually gestational diabetes we can say after 24 weeks of 26 weeks of pregnancy. And the GTT 0, 1, 2. This is more, and I also asked with our endocrinologist, Kunal Thakur. He told that this is now DIPSI is recommended to all. No any American guidelines like that. So they also prefer that you go for like that.
GTT in all the patients after 25.
High risk.
High risk patients.
High risk.
So all our patients are high risk. Divya, all our Indian patients are considered to be high risk. So we do GTT in all the patients after 25.
Now they have recommended that OGTT should be done for everyone
All
at least
patients.
at 24 weeks and I think 1 month later. Probably if it
Twice
around-
we should do.
Yeah, they do, but once it comes negative, then I think at 28 weeks they have to repeat it. Probably I think residents will tell better. What is the 24 weeks they tell, right? First 28 weeks. Right? 2 tests are supposed to be done.
We are doing it twice or
Once 24.
Anywhere between 24.
But if it is on the higher border, then you have to repeat after 32 weeks.
NTTPO positive medicine of it,
No. Medicine remains same. But if NTTPO positive means the androxin is required must. You suppose if comes you lower down or TSL, but you should not decrease or you should not stop the medicine. Only thing is that during pregnancy, many a time the transient hypothyroidism patients are getting very low. So after many a time after when they delivered, they may require some less amount or may not have any hypothyroidism.
So if I'm not wrong, if sometimes it happens that TSH is normal, but anti-TPO is high. So in
Yes.
that case, I think we should add
Electroxin, yes.
Yes.
Amatu slide.
So that is the, I think, role of anti-TPO.
Yeah,
Given
yeah.
the TSH is normal, but anti-TPO is high, then
and
you
also
have
said that if NTTPO is positive, you should keep little bit higher side. Stop तो नहीं करो, decrease भी नहीं करो. Little bit higher side. NTTPO positive है, तो requirement always basis. Will never decrease. NTTPO will just on the higher side.
So if the TSH is like more like 6 or 7, so in that case, anti-TPO is also possible. So is there any dose change in this patient?
Never decrease the dose if NTTPO is positive.
Suppose the patient was euthyroid before pregnancy.
You can add, but you cannot decrease. Suppose 7, 8 comes, you can add 25, 50 microjoule like that, and you again repeat after 1.5 months. But you should not never decrease the dose.
कुणाल भाई बता सके NTTPO positive हो सकता है, पर ये requirement क्या है decrease तो नहीं
नहीं pregnancy better to treat. Never, should be never. No.
Okay, thank you.
Thank you, Dr. Hirani sir. Now, the hot topic of the day.
Slide पर point
क्या है? अच्छा, मॉनिटर है? कैसे कर?
slide आगे पीछे कर।
तो इससे होगा आगे होता है?
Technology.
नहीं होता।
Connection
अच्छा आगे अच्छा ऐसे।
Now the hottest topic of the day, PPH. PPH is the nightmare in obstetrician's life. It can occur with any high risk case and even normal pregnant patient. And it can occur with anyone, everyone and anywhere. So to deal with these nightmares and catastrophic situation in an obstetrician life, I like to invite our Malik, boss of Mandvi, Dr. Puneet Khatri.
हेलो, थैंक यू मैम Good afternoon, everyone. In most of the conferences, we are being taught medical management and surgical management of PPH, step-wise devascularization, internally aggregation, obstetric hysterectomy, everything destructive. Alta, jalta, PPH, chaos થઈ ગયો છે PPH. Now, today we are going to discuss prevention of PPH. So, PPH is also known as nightmare of an obstetrician. The commonly used definition is blood loss exceeding 500 ml following vaginal delivery or 1000 ml following cesarean delivery. And the new definition is cumulative blood loss exceeding 1 liter with hypovolemia within 24 hours of birth regardless of the route of the delivery. According to ACOG definition, excessive bleeding exceeding 1 liter in first 24 hours of birth but can occur up to 12 weeks postpartum. According to RCOG definition, heavy bleeding after birth, it could be primary within 24 hours or could be secondary or late if occurs after 24 hours of delivery. These are the 4 main causes of PPH in majority of the cases. Torn tissue, trauma and thrombin. Torn means the causes related to atonicity of the uterus. Tissue means the causes related to retained placenta or the retained products of pregnancy. Trauma means the causes related to lacerations of vagina, cervix or uterus. Thrombin means the causes related to coagulopathy or coagulation disorder, which could be either congenital or acquired. So let's come to the first cause, that is torn. In a majority of the cases, the reason of the uterine atone is sudden uterine decompression, and the major predisposing factors are big baby, multiple pregnancies, and polyhydramnios. Prolonged second stage of labor, pregnancy-induced hypertension, increase the use of tocolytics because of increasing cases of infertility and rhesus pregnancies, and over-enthusiastic use or abuse of oxytocic agents. So, the management of third stage of labor is very crucial in prevention of uterine atonicity. It is written in the book of Practical Obstetrics by Ian Donald that we should never apply fundal pressure or fundal massage before the delivery of placenta in case of full-term delivery, because once the blood finds its tract between the uterine wall and the membrane before delivery of placenta, then it would be very difficult to control the hemorrhage. To hasten the delivery of placenta, this is the most reliable method, and that is the modified Brent-Andrews technique, where we apply continuous cold traction in downward direction and suprapubic counter traction in opposite direction. The 1/4 of all maternal deaths occur due to PPH. According to WHO guidelines, these can be prevented by prophylactic use of uterotonic agents in third stage of labor. A Cochrane systemic review and network meta-analysis compared all uterotonic options and placebo or no treatment, and 196 trials have been conducted across 53 countries over 135,000 women, and concluded the use of an effective uterotonic for prevention of PPH during third stage of labor should be recommended for all deliveries. For one of the following uterotonic agents can be used: oxytocin, carbetocin, misoprostol, ergometrin or methyl ergometrin, oxytocin, ergometrin fixed dose combination, oxytocin intramuscular or intravenous, carbetocin 100 microgram IM or IV. It is the first long-acting synthetic analog of oxytocin, and that is having half-life of 40 minutes. It is 4 to 10 times more potent than oxytocin. Misoprostol 400 to 600 microgram orally or per rectal. Ergometrin or methyl ergometrin 0.2 milligram IM or IV. Oxytocin ergometrin fixed dose combination. An injectable prostaglandin, carboprost or subprostone. The routine use of injectable prostaglandin is not recommended for prevention of PPH. So, despite of practicing active management of third stage of labor and prophylactic uterotonic agents, the incidence of PPH is rising instead of declining day by day. So, this is the real need to look into the reality of the trends of the modern obstetrics practice. the reliable, authentic data of changing trends in PPH in India are not available. But according to a study conducted by International PPH Study Group in high resource countries, it was found that the incidence of PPH has increased over a decade, but the rate of blood transfusion, surgical interventions, or obstetric hysterectomies has reduced in the UK, France, the USA, and the Netherlands. So, as we all know, medicine is not a perfect science. What we have been learned or what we are practicing today might change after 2, 3, 4, or 5 decades, and we might come to know that the particular trend of practice or use of a drug is no longer recommended. For rising rate of atonic PPH, we need to understand the oxytocin receptors. Oxytocin receptor is a G protein receptor with the intracellular pathways activated in response to binding oxytocin and similar vasopressin. Now, estrogen stimulates the process of parturition by increasing expression of the genes responsible for myometrial contractility and excitability, and increases the uterine sensitivity to oxytocin during the course of pregnancy. And the expression of oxytocin receptors are highly regulated throughout the course of pregnancy. It reaches peak level at the onset of labor, and it's almost 200-fold more than a non-pregnant level. And it falls sharply in advanced labor and in the postpartum period. And that time the uterus becomes refractory to endogenous as well as exogenous oxytocin. So endogenous oxytocin travels to the uterus and stimulates the contractions, which in turn causes pituitary gland to release more oxytocin, which increases duration and intensity of contractions. So this is very important mechanism to understand. So prior use of oxytocin downregulates the number of prostaglandin receptors. And vice versa, prior prophylactic high dose of misoprostol or any prostaglandin downregulates the number of oxytocin receptors. So whenever oxytocin has been used previously for induction or augmentation of labor, after that the uterus will become less responsive to oxytocin as well as prostaglandins. And we have seen many obstetricians recommending the prophylactic use of misoprostol, per rectal insertion of misoprostol, even in case of cesarean. So this practice will downregulate the number of oxytocin receptors, and ultimately uterus will become less responsive to prostaglandin as well as oxytocin. So this routine use of prophylactic misoprostol or overuse of oxytocin for augmentation of labor should not practice routinely. So oxytocin is also known as love hormone or cuddle hormone. After birth, endogenous oxytocin releases more milk from the mother's nipples by let-down reflex and fosters a bond between mother and baby. Moreover, our baby produces oxytocin when we fall in love, stimulated by our sexual partner and at the time of cuddling. So we all know genes, hormones and receptors. These three are responsible for evolution, underevolution, atrophy and hypertrophy of all our living being or any part of the living being. So this is the law of the genetics, that the lifestyle runs in the generations. The lifestyle which continued for 2, 3, 4 decades, it enters into the genes. And this physiology of labor and role of endogenous oxytocin is a truly phenomenal. So stick to the nature, allow nature to do its work by the phenomena, and let the endogenous oxytocin work over the receptors. We might have seen in many of our ART cycles, when we stimulate the patient, at the time of monitoring, we see the endometrium, beautiful triple line endometrium, responding to endogenous estrogen. But in frozen transfer, in FET cycle, frozen transfer, when we give estrogen from outside, then many patients will not respond to exogenous estrogen. So this is the mechanism of endogenous hormones, which receptors respond to endogenous hormones. So આપણે ક્યારે નથી સાંભળ્યું કે ભાઈ કૂતરા બિલાડીની ડિલિવરી થઈ અને પીપીએસ થયું. કોઈ કૂતરી વિયાણી કે બિલાડી વિયાણી કે ભાઈ કોઈ એનિમલની ડિલિવરી થઈ એ લોકોને પીપીએસ. મોટા એનિમલ્સમાં માલ પ્રેઝન્ટેશન સિઝેરિયન હોય છે, પણ એનિમલ્સમાં વી હેવ નેવર હર્ડ ઓર નેવર સીન કે ભાઈ આ લોકોને બીપીએસ કે બ્લીડિંગ થયું. હવે લેટ્સ હેવ અ લુક to the varieties of emotional expressions over the dogs' faces, different kind of dogs, different kind of emotional expressions of these dogs. This dog looks curious but having mixed emotions. This dog looks anxious. This one looks very sad. And this dog is happily smiling. So why I am showing this all to all of you? Because the domesticization of dogs with the humans has more than history has more than 3,005 years old history, and by living with the humans and seeing a human's facial expressions, dogs started their facial emotional reactions by evolution of extraocular muscles as well as other facial muscles. So there is only one species of dogs in the world, and that is Siberian Husky. Siberian Husky has no evolution or development of extraocular muscles or no emotions. So this is Siberian Husky, the face with no emotions, no evolution or development of extraocular muscles. So with the evolution of humans, with the evolution of Homo sapiens sapiens evolved from quadrupedalism to bipedalism. So tail vanished due to disuse of the tail. And tail became no longer a tail and it became appendix. તો જે હજારો વર્ષ પહેલાં હતું એ હમણાં નથી, અથવા હજારો વર્ષ પહેલાં જે નહોતું એ અત્યારે છે, અત્યારે જે છે એ કદાચ 100, 200, 500 વર્ષ પછી નહીં પણ હોય. તો જ્યારે એક ટાઈમ કદાચ એવો બી આવે કે ભાઈ આપણું બોડી કે રિસેપ્ટર્સમાં એટલા જેનેટિક ચેન્જીસ આવી ગયા કે ઇટ વિલ નોટ રિસ્પોન્ડ એની ટાઈપ ઓફ એક્ઝોજનસ હોર્મોન્સ. અને મે બી આર્ટિફિશિયલ લેટ્સ હોપ કે આર્ટિફિશિયલ ઇન્ટેલિજન્સ આવશે જ્યારે આપણું બ્રેઇન બી એટ્રોફી ના થઈ જાય. So use, disuse, evolution, underevolution and atrophy is phenomenally governed by the nature at genetic, molecular, hormonal and receptor levels. So avoid induction and augmentation of labor as far as possible, and never use vaginal prostaglandins for the induction of labor in full-term pregnancy. It is never used in the developed world. Disasters happen only when we destroy the nature. આપણે હમણાં રિસેન્ટલી ઘણું સાંભળ્યું હશે છેલ્લા 2-3 દાયકામાં કેન્સરના કેસીસ, યંગ કાર્ડિયાક ડેથ આ બધું વધી રહ્યું છે, એન્વાયરમેન્ટ ખરાબ થઈ રહ્યું છે. ફ્રી રેડિકલ્સ, બીકોઝ ઓફ ધીસ ફ્રી રેડિકલ્સ પ્રોડ્યુસ ફ્રોમ ધ પેસ્ટિસાઇડ્સ, chemical fertilizers, plastic, excess use of plastic, pollution, carbon products, industrial waste. So these free radicals bind with our DNA genetic material. They produce a change in our DNA and they suppress the tumor suppressor genes, and that give rise to the different types of diseases and tumors and cancers. So those people are suffering from cancer. Those do not have hereditary history of cancer. So those people are dying because of oral cancer. તમાકુ ક્યારે ખાધી નથી, સિગરેટ પીધી નથી તો લંગ કેન્સર થાય છે, liver cancer થાય છે. All this because of genetic change. The change in genes, genetic change and behavior of a human or any living being is the biologist's rule of the biology. So let's come to the cause number 2, that is tissue. The causes related to retained placenta. The morbidly adherent placenta can be placenta accreta, increta or percreta. Because of increasing cases of infertility, adenomyosis, fibroids, and increasing surgeries over myometrium and endometrium. So recently, a study has been shown that there are evidences that frozen embryo transfer in HRT cycles is more associated with morbidly adherent placenta, fetal macrosomia, and preeclampsia. So now gradually people have started shifting to fresh embryo transfer instead of frozen ET by minimum stimulation with relatively lower levels of E2, followed by fresh embryo transfer or frozen transfer in natural or modified natural cycle. So early anticipation of adherent placenta by good ultrasound is possible, and that is the anechoic line which can see the subplacental sonolucent space, that is the cleavage plane between placenta and the myometrium. Absence of such plane gives a clue to placenta accreta, and according to the invasion of placental tissue seen on ultrasound, invasion into the myometrium, we can also make out the increta or percreta. This is the ultrasound image showing subplacental sonolucent space, and this rules out the adherent placenta. This is also showing anechoic line between myometrium and placenta. So this picture is showing a placenta accreta where we can see the thinned out lower uterine segment And there is no anechoic plane of cleavage between placenta and the myometrium. Abnormal placental implantation over myometrial scar, the extrusion of the placental tissue beyond the usual confines of the uterine cavity, fibrinoid deposition and neovascularization. Placenta accreta spectrum is graded according to the placental involvement, ranging from abnormal adherence to myometrium, that is accreta, to deep myometrial infiltration, that is increta, to percreta, where the placenta breaches the serosal surface and may involve the surrounding structures. So manual removal of placenta can lead to torrential hemorrhage or uterine rupture if we attempt MRP in placenta increta or percreta. So always put an ultrasound probe before attempting MRP if we have not seen the patient in antenatal period by good ultrasound. If it's accreta or percreta, do not proceed for the removal, just control the bleeding by good uterine contraction and weight. In placenta accreta spectrum, placenta, we can see the placental lacunae within the by on ultrasound. And those are multiple anechoic areas noted within the placenta. The placental invasion beyond the limit into the myometrium passes the spiral arteries, leads to excess dilatation of these high velocity arteries, and increases the flow into the intervillous spaces, which gives the placenta this most eaten appearance. Whenever in doubt by ultrasound to rule out adherent placenta, the MRI is very good diagnostic tool. And this is the MRI picture of the true placenta accreta at 27, which is in sagittal section. Here we can see low signal intensity band within the placenta. So early diagnosis always saves the life, and good anticipation. Decide the level of the center where delivery or LSCS needs to be planned, depending on the type of adherent placenta, availability of blood transfusion, etc. Secure the IV line and keep a cross-match sample blood ready in each and every normal obstetric patient. That is the key to the safety. Let's come to the number 3, that is cause number 3. Trauma means the causes related to lacerations. So cervical lacerations occur in precipitate labor, difficult forceps delivery, big baby, vaginal mesoprostol. And uterine rupture in grand multipara, prolonged trial, previous LSCS. An extension of perineal tear or episiotomy occur usually in difficult forceps deliveries, breech delivery, big baby. An extension of uterine incision in case of malpresentation, deeply engaged head, placenta previa. And iatrogenic, where full thickness of uterine wall is not sutured in efforts to exclude the deciduum. So all these causes are preventable and can be anticipated, except in cervical laceration in case of iatrogenic cervical laceration in precipitate labor, where we cannot prevent the laceration. But in case of difficult forceps delivery, big baby, we should be vigilant for the cervical laceration, whether it has occurred or not. Uterine rupture is very rare nowadays because of different government programs run by the health ministry. And extension of perineal tear can be, or episiotomy can be prevented by giving a liberal episiotomy in case of difficult deliveries, breech delivery, difficult forceps delivery, etc. And uterine incision, extension of uterine incision also can be prevented whenever we anticipate that the big uterine incision would require in case of deeply engaged dead, malpresentation, placenta previa, where the lower segment is not formed in premature, preterm LSCS, etc. Let's come to cause number 4, that is thrombus. The cause is related to coagulopathy. It comprises of 3% of all BPH cases and mostly related to placental abruption and amniotic fluid embolism, leading to early onset coagulopathy, DIC and hyperfibrinolysis. So congenital coagulation disorders like hemophilia A and B, factor 11 deficiency, von Willebrand disease, prothrombin G20210A mutation, factor 5 latent mutation, antithrombin deficiency, MTHFR, methylene tetrahydrofolate reductase deficiency, protein S deficiency, protein C deficiency. And unfortunately, some women do not know that they are the carriers of the condition and may not represent themselves until they become pregnant. The coagulopathy is never missed when we thoroughly investigate the patient and by regular antenatal care, including all investigation, complete blood count, platelet count, BTC, TPT, INR, coagulation profile, and if detected, can be treated without motility or the least morbidity by factor replacement or PRP or FFP transfusions. આપણે આઈવીએફમાં સારા રિઝલ્ટ મળે, એન્ડોસ્કોપીમાં રિઝલ્ટ મળે, ડિફિકલ્ટ કેસીસમાં રિઝલ્ટ મળે ત્યારે આપણે એક અદ્ભુત આનંદની અનુભૂતિ થાય. પણ જે અલૌકિક આનંદ નોર્મલ ડિલિવરી કરાવ્યા પછી આવે છે આઈવીએફ એન્ડોસ્કોપીમાં નથી આવતો. થેન્ક યુ વેરી મચ.
Any questions?
I have reading one of the oxygen that you don't claim the uterine means maternal end of the umbilical cord. Only you claim the fetal end of the umbilical cord. Let the blood goes down, and BPH chances are very good.
You are asking about delayed cord cutting or
Not delayed.
okay.
You don't bear petrol on the maternal side of the cord.
પ્લાસેન્ટાનો બ્લડ નીકળી જાય તો પ્લાસેન્ટા શ્રિંક થઈ જાય.
Shrink થઈ જાય. Okay, okay.
This I read in one of the
Okay, no, I am not aware of that.
I have read in our journal
Okay,
oxygen.
This
And I'm
curiosity.
practicing since many years.
Okay.
It's really helpful.
Okay.
BPH chances are very good.
This curiosity came in my mind when I was in PG and I asked my teachers કે ભાઈ આ તો ઠીક છે કટ કરી, આ શું કામ કટ કરી? So they told કે ભાઈ જો એ ના કરો તો બધું મેસી થઈ જાય એટલે આપણે કટ કરીએ.
And let blood
we
goes
can
out,
allow
let out
that.
the blood. Uterus decreases in size, placenta comes very easily.
એટલે કોડ ક્લેમ પણ નહીં કરવાની એમ કહો છો?
Maternal side, on the maternal side you don't claim. Only on the fetal side is claim.
એક આંટી લગાવીને જ કટ કરતા ઓલી ભલે નહીં પ્લાસેન્ટા વાળી ભલે.
અચ્છા, ઓકે ઓકે. થેન્ક યુ. હા બોલો બોલો.
I'd just like to add one thing. In spite of all the 4 Ds, in spite of you do everything you like, everything for prevention of BPS, but sometimes when your time is bad and sometimes the patient's faith is bad, first thing you call your colleagues. Always call for help. Don't be a hero to deal everything, because when your colleagues come, then it's a moral support, and in today's scenario, and it is very important if 4 to 5 people are there. So it's my sincere request, and my sincere request to each and everyone also. So please help your colleagues when they are in things.
Madam is helping for the intermediate ligation.
Madam is expert in internet language.
Not for me, it's for each and everyone. Always call for help. That's the moral of the story to deal with PH.
Moral of the story is also do not use vaginal misoprostol, prostaglandin, and never do induction augmentation. Whenever service become favorable, I start oral misoprostol. That 2 in 25 to 50 microgram, 3 to 4 hours. I have never encountered cervical tear, very rarely. Once, hardly in 5 to 10 years, one cervical tear I encountered. હમણાં વચ્ચે એક પેશન્ટ મારે હતું સર્વાઇકલ ટેર, સ્પોન્ટેનિયસ ડિલિવરી કાંઈ નહીં, અને મેડિકલ ઓફિસરનો ફોન આવે, બ્લીડિંગ બહુ થાય, ટોરન્શિયલ હેમરેજ. હું ઊભો થઈને ભાગ્યો સીધો, શૂઝ નથી પહેર્યા, ઘરનું બારણું પણ નથી કર્યું, સીધો ભાગ્યો, પહોંચ્યો, રસ્તામાં ફોન કર્યો, આઈવી લાઈન તો લીધેલી જ હોય, હિમાસિલ ચાલુ કરો, 2-3 બીટી મંગાવી લો, ઇન્સ્ટન્ટ રિફ્લેક્સ છે, આવું થયું છે તો આ હશે કંઈક જ. અને પેશન્ટ ઓટીમાં શિફ્ટ કરવાનો ઓર્ડર બી આપી દીધો અને બીટી મંગાવી લીધું, હિમાસિલ ચાલુ હતું. હું ગયો ને ત્યારે પેશન્ટ વોઝ એક્ઝેન્ક્વિનેટેડ, પલ્સલેસ બીપીલેસ. હવે જે બીટી આવ્યા ને એમાં છોકરાઓએ 20 સિરિંજમાં બ્લડ ભરીને પુશ કર્યા લીટર, અને જીએ આપીને સ્ટેજ કરી રિપેર કરી અને પેશન્ટ સર્વાઈવ. 5 કે 6 બીટી આપ્યા. એનું બીજા કે ત્રીજા દિવસે યુરિયા ક્રિએટ છે ને, ક્રિએટ 3.5 પહોંચી ગયું, 3.5-4 પહોંચ્યું હતું. રિકવર થઈ ગયું, સર્વાઈવ થઈ ગયું. પણ ધીસ ઇઝ ધ રિફ્લેક્સ એન્ડ એન્ટિસિપેશન. કંઈ નહીં થાય એવું નથી, પણ એઝ ફાર એઝ એટોનિક બીપીએસ ઇઝ કન્સર્ન, આપણે કંઈ નથી કરતા તો એટોનિક તો નથી થતું. ધીસ ઇઝ માય એક્સપિરિયન્સ ઇન ધીસ મેની યર્સ ઓફ. મારાથી ઘણા સિનિયર મોટા લોકો છે, પણ હું મારો એક્સપિરિયન્સ શેર કરી રહ્યો છું.
Now for the last lecture of this session, I like to call the star performer of BOGS. He is every president's favorite, great planner or great organizer skills, and he has been awarded as the National President Appreciation Award for 2022. He has shown his skills as the organizing secretary for SOGOG 2021. None other than Avik Khatri.
થેન્ક યુ વેરી મચ દોસ્તો. ડિલેડ કોર્ડ કટિંગની વાત કરીને તો મને ધ્યાન આવ્યું કે છેલ્લા 5-6 વર્ષથી વી પર્ટિક્યુલરલી ઇન અવર હોસ્પિટલ ડિલિવર ઇન અ ડિફરન્ટ વે that we always do the delayed cord cutting. Sometimes in vaginal deliveries we delay the cord cutting up to 55 minutes. You won't believe this, but in one particular patient, I delayed the cord clamping for 55 minutes. The reason I will tell in the lunch area, and in one particular cesarean section, I delayed the cord cutting for 40 minutes, 40 minutes. Again, the reason I will tell in the lunch area. So, let us see one particular slide that is there. આ મારી ઓપીડીની ફાઇલ છે. ડાબી બાજુ એક ફાઇલનો ફોટો છે, જમણી બાજુ એક ફાઇલનો ફોટો છે. જુલાઈમાં એક પેશન્ટ આવ્યું હશે 74.2 કિલો સાથે, અને પછી મારે ત્યાં એ ટ્રીટમેન્ટ લેતું હશે, અને શી કેમ ડાઉન. આ 4 ફેબ્રુઆરીની વાત છે, એટલે કે આ હમણાંનો જ ફોટો છે. 4 ફેબ્રુઆરી 2024ના 65.1 65.5 સુધી આવી ગયું. બાજુમાં એક ફોટો છે 8 ઓગસ્ટના 94.7 વેઇટ સાથે આવ્યું, અને બીપી હતું 135/113. બહુ ખરાબ કહેવાય બધું. પછી ધીમે ધીમે આગળ ટ્રીટમેન્ટ ચાલી 30 જાન્યુઆરી, એટલે આ હમણાં 10 દિવસ પહેલાંની વાત છે, ત્યારે એનો બીપી 98.3. લેફ્ટ સાઈડનો જે ફોટો છે ને 74 થી 65 વાળો સફર, એ પ્રીનેટલ લાઇફસ્ટાઇલ મોડિફિકેશનનો છે. Prenatal lifestyle modification. When a couple is planning for pregnancy, we allow them to settle down their weight, normalize their parameters, be physically and mentally more healthy, and then go for pregnancy. Right side જે ફોટો છે ને, એ ડ્યુરિંગ ધ કોર્સ ઓફ ધ પ્રેગ્નન્સી છે. એટલે કે ઓગસ્ટથી કરીને જાન્યુઆરી, હવે છે ને લગભગ આ જાન્યુઆરીમાં એનો 3rd ટ્રાઇમેસ્ટર ચાલુ છે પેશન્ટનો. તો ફર્સ્ટ ટ્રાઇમેસ્ટરથી કરીને 3rd ટ્રાઇમેસ્ટર સુધીમાં જે આપણે વેઇટ ગેન, નોર્મલ વેઇટ ગેન આપણે જોતા હોય ને 12 કિલો 15 કિલો, સમ ઓફ ધ પેશન્ટ્સ યુઝ ટુ ગેઇન 20 kg weight gain during the pregnancy. This particular patient, with the help of lifestyle modification, gained only 4 to 5 kg of the weight. અને આજ આપણે આજે શીખવાના છીએ કે પ્રેગ્નન્સીમાં ઓવરગ્રો ના થવાય, ડિલિવરી પછી ઓવરગ્રો ના થાય. લેડી સ્લિમ છે એનું બહુ ટેન્શન નથી, એ લાડુ પેડા ખાઈ લેશે, શીરો ખાઈ લેશે, તો બધી ફૂલી તો જશે. ન ફૂલે એના માટે શું કરવાનું છે એ આપણે આજે જોવાનું છે. મારી સીવી તો મેડમે મસ્ત વાંચી. લાસ્ટ લાઈન હું વાંચવા માંગીશ કે there is a transformation journey of 26 kg with myself. I used to be 108 kg once upon a time. Today I'm 84. A baby is something you carry inside you for 9 months, in your arms for 3 years, and in your heart forever. The feeling of carrying a soul within you is the most awaited time in a woman's life. કહેવાય છે કે એક લેડી હોય ને, એને માતા બનવું હોય એટલે બિચારી લગ્નનો જે કંઈ પણ સ્ટ્રેસ છે ને, એ એક જ ફિલિંગ માટે ફેસ કરવા માટે તૈયાર છે કે ભાઈ એને માતા બનવા મળશે. બાકી એને આ બધી ઝંઝટ, મેરિડ લાઈફ, સોશિયલ લાઈફ અને એના સ્ટ્રેસ, સાસરિયાના સ્ટ્રેસમાં એને કોઈ ઇન્ટરેસ્ટ નથી. એને છે કે ચલો મા બનવા પડશે ને, દેટ્સ ઇટ. ઇટ ઇઝ ઇમ્પોર્ટન્ટ ટુ ઈટ રાઇટ, ટુ ગીવ ધ રાઇટ અમાઉન્ટ એન્ડ ટાઈપ ઓફ ન્યુટ્રિશન ટુ ધ લિટલ વન એન્ડ ધ મધર. બચ્ચા માટે સારું ખાવું જરૂરી છે, અને માતાએ પોતે સારું પોતા માટે બી ખાવું પડે, અને માપનું ખાવું પડે. બધી સાસુ બિચારી ખવડાયા કરે કે હવે તારે કેટલા લોકોનું ખાવાનું છે? 2 લોકોનું. ટ્વિન્સ હોય તો, અને નરેશ સાહેબ ટ્રિપલેટ હોય તો ક્વોડ્રુપ્લેટ. લ્યો સાંભળો. ઓહ માય ગોડ. જી જી બિલકુલ.
ક્વોડ્રુપ્લેટ ડાયગ્નોસ, નોર્મલ વજાઇનલ ડિલિવરી, 4 બચ્ચા બચી ગયા. એક બચ્ચું 6 મહિનાનું થઈને ઇન્ટેસ્ટાઇનલ ઇન્ફેક્શનમાં મરી ગયું. હવે 3 અત્યારે જીવે છે, ફોટો પડાવવાના.
લવલી. સો
સીએસ કરે છે, કારણ કે આઈડીએફ હતા એટલે માટે 4 જીવે છે, 7 વર્ષના છે, ગાંધામાં છે ને, અમારો બ્રાન્ડ એમ્બેસેડર છે અત્યારે.
ઓહો, શું વાત છે. હા, પણ પેટમાં 4 બચ્ચા હોય તો 5 લોકોનું નહીં ખાવાનું એમ. વોટ આઈ વોન્ટ ટુ સે ઇઝ, so eating less in order to avoid weight gain during pregnancy is the worst idea of all times. કેમ કે પ્રેગ્નન્સીમાં if you don't monitor your calorie, hydration, nutrition, you will suffer a lot. આમે પોસ્ચરલ હાઇપોટેન્શન બહુ થતા હોય, ચક્કર ખાઈને પડી જાય લેડી. એમાં જો ફાસ્ટિંગ બહુ કરે તો લોચા થાય. So we should have some of the idea કે ભાઈ પ્રેગ્નન્સીમાં ખાવું કેવી રીતે જોઈએ. BMI is a measure of your weight relation to your height. Attempting to lose weight during pregnancy is not that much advisable, but limiting the weight gain during the pregnancy should be the ideal. First trimester, the body begins to nurture the fetus, accompanied by fatigue and morning sickness. Second trimester, the baby bump grows. This period often entails a surge in energy levels and increase in the appetite. પહેલા 3-4 મહિના તો 3-3.5 મહિના તો કેવું હોય કે ખાધું જ ના ભાવતું હોય, એટલે વેઇટ ગેઇનની બહુ ચિંતા ના હોય. ઉલટું પેશન્ટ આવે કે ભાઈ 4 મહિના થઈ ગયા, વેઇટ ગેઇન તો થયું જ નથી, સ્ટેબલ જ છે. વી હેવ ટુ કાઉન્સલ કે બેટા વેઇટ ગેઇન તો તારું હવે થશે. સેકન્ડ ટ્રાઇમેસ્ટરમાં છે ને ક્રેવિંગ્સ ચાલુ થઈ જાય. સો ધીસ ઇઝ ધ ટાઈમ વેન વી શુડ એડ્રેસ ધેમ પ્રોપરલી, હાઉ ટુ ટેકલ ધેર ક્રેવિંગ્સ. And third trimester, as the due date approaches, the body prepares for childbirth. Expanding uterus can cause a shortness of breath, frequent of urination, and the body tries to accumulate energy for the labor. This is the FIGO guideline. They have given some of the checklist which are available online. I would tell in brief that there are 4 portions of this FIGO guideline, section 1, 2, 3, 4. One is to study whether the patient is vegetarian or non-vegetarian. 2 is to study her BMI depending on the weight and the height. Section 3 deals with the quality of the diet, eating minimum amount per week, કેટલું ખાય છે. અને section 4 is to deal with micronutrients. એટલે કે જે ખાય છે એમાં micronutrients બરાબર છે કે નહીં, અને આના questionnaires ઉપરથી then we should advise them કે એણે શું ખાવું જોઈએ. Weight gain is a normal part of the pregnancy. Depending on the BMI, we should advise and be watchful whether the patient gains weight in the given format. Say, for example, if a patient is very lean and thin in the range of BMI 18 or less than 24, I would say, she is allowed to gain weight till 11 or 15 kg, which is the normal expected weight gain. But for pre-obese cases, we should restrict the weight gain till 7 to 11 kg, but in obese cases, frank obese, we should restrict the weight gain in the range of 5 to 7 kg only. So now you remember the first slide, કે જેમાં આપણો પેશન્ટ ખાલી 5 જ કિલો weight gain સાથે આગળ વધતું. We have to be watchful regarding the weight gain of the pregnancy. Along with that, we should be watchful for all the nutrients that she should be having. Folic acid, calcium, vitamin D, vitamin A, everything should be well balanced in the diet. We should explain all the dietary resources કે ભાઈ તને ફોલિક એસિડ, વિટામિન ડી, વિટામિન એ વગેરે શેમાંથી મળશે. I will not go in the detail કે કઈ વસ્તુનો સોર્સ કયો છે, but we have to counsel them that these are the sources of vitamins and you should take care of these things at least in your diet. If you receive Yes, again the same thing. Okay, do I need to eat for 2? So no, energy requirements do not increase until the 3rd trimester of pregnancy. As we all know, okay, pregnancy ma calorie requirement of particular lady increases to the range of 300 to 600 calories daily. એટલું એને રોજ એક્સ્ટ્રા ખાવું પડે. અને ડિલિવરી પછી lactation period માં બી the demand increases to around 600 to 700 calories. But the thing is that because of the cravings and all, when lady does not know what to eat, she starts eating high calorie food, and ultimately the calorie balance is always towards the plus side, and which results in excessive weight gain. So we should counsel them how to cut short the calorie. Starchy food is always a good source of energy, but it increases the calorie that is going inside the body very swiftly, and we should be focusing on that thing, and we should ask them to restrict starchy food. So that is maida, bread, rice, potato. What I always used to advise to my patients, how many of you, with the grace of God, there are very less gynecologists from Anjar and Gandhidham now, but still I would like to ask, how many of you have received my file in your particular OPD? Nobody? Oh wow, Shailibin પાસે પહોંચી ગયો પેશન્ટ. So I used to write down all the things that she has to do regarding the nutrition. અને જેમાં obesity અને diabetes mellitus આવે, then in all those cases I always used to ask them to restrict high glycemic index food, starchy food, and we advise like bhat, bateta, khand, chocolate, ice cream, sharbat, cold drink. We specifically write everything that she has to restrict. And then she will understand that yes, she does not need to go for those things. She need to focus more on fruits. And again, the same thing that she should restrict very sweet fruits in larger amount. I'm not against eating banana, mangoes and other things during pregnancy, but she has to restrict sweet fruits during the course of pregnancy. Milk and dairy foods, if not added with sugar, not added with sweet sharbats and all, flavored syrups that we are having in the markets, the milk beverages will be very healthy. But if you add lots and lots amount of sugar in that, it will be very difficult to manage weight then. For non-veg sources, they should avoid the non-veg sources which are very fatty and processed meat. The examples given here are sausages and pies and all. The lady should focus on the sources of iron and vitamin C as well. Regarding foods and drink habits, she should restrict sugar in their tea and coffee as well as in the milk. She should definitely avoid syrups, sharbats and the so-called cold drinks. As we all know that the cold drink is the having highest amount of sugar in it. પેલા 3-4 મહિનામાં જે ખાધું ના ભાવે તો લેડી શું ખાય? શું ખાય મેડમ? Ice cream. Look at this. So again the same thing, they don't know how to solve their craving. અને એમાંય પાછી પેલી પ્રીતિ ઝિંટા સલામ નમસ્તે એમાં ખબર નહીં શું શીખવાડી ગઈ કે રાતે 2 વાગે 3 વાગે ઉઠીને આઈસ્ક્રીમ ખાવાનું. Now if Bollywood starts teaching like this, that lady will think like કે જો મને આવું નહીં થાય તો મારી પ્રેગ્નન્સી વેલિડ જ નહીં ગણે. And she will also start behaving like this. The same is true કે if Bollywood is showing કે ડિલિવરીમાં તો રાડો નાખીને જ ડિલિવરી થાય. હા, એન્જિનિયર લોકો વેક્યુમ લગાડી નાખે. તો now look at the confidence of mechanical engineer husband who is coming into the labor room. So we should be realistic that if at all the craving happens, you should not focus on this ice cream and all. Whatever you are eating should be palatable but not too spicy, because too spicy things will alter the metabolism and will ultimately increase the weight gain. The food area which she is using, she should wash all the fruits and vegetables. She should use unpasteurized cheese, and she should limit her caffeine level as well. So again, one more crux I would like to add. One thing already I have added is, number 1, she should be eating the food that is with low glycemic index. What to avoid you should know. The rest of the things you can make a list in your prescription. These are the things with low glycemic index, and you can start having this instead of that. Number 2 thing is, one question that Shakti she asked in between was that how you changed this weight, 26 kg weight loss, how it happened. So I used to observe my diet during the course of noting it down. I used to write everything that I used to eat in my mobile phone, that so many applications are available. અને સવારથી જે હું ખાતો આવ્યો ને એકદમ દિલથી મતલબ શું કે ઓનેસ્ટલી આપણે લખતા જતા કે સવારે આ ખાધું તે ખાધું, બપોર સાંજ સુધી આવતા આવતા છે ને મારી કેલરી લગભગ 1900 સુધી પહોંચી જતી. અને મારી સેડેન્ટરી લાઈફસ્ટાઈલના લીધે મને ખબર પડી કે મારી કેલરી તો 1800ની આજુબાજુ હોવી જોઈતી હતી. ઓલરેડી સાંજ સુધી 1900 ખાઈ ચૂક્યો છું. ત્યારે મને સમજાણું કે હવે તો હું રાતે જે ખાઈશ એ ગેઇનમાં જ જશે. So this thought came in my mind, and then I started watching my food habits. I started cutting down high carbs thing. Then I realized that I should cut down the dinner value as well. So I restricted my dinner. And this is again a crux that we should ask our patient that at least in the dinner, they should not be having high glycemic index things કે રાતે ઘઉંની રોટલી ના ખાઓ, રાતે ભાત ના ખાઓ, એની બદલે બાફેલી દાળ શાક કઠોળ કે જે ઓછી કેલરીવાળા ફ્રૂટ્સ હોય એ તમે ખાઈ લો, દૂધ પી લો. અને જ્યારે એને ક્રેવિંગ્સ થાય ત્યારે પણ આપણે એને એડવાઇસ આપીએ કે તમને ક્રેવિંગ્સ થાય ત્યારે દાળિયા ખાજો, બદામ ખાજો, પણ આઈસ્ક્રીમ ને કાજુ ન ખાઈ જતા. So these are the small advices that we can give her and she will be helped a lot. The body transformation is 70 to 80% about diet and only 20 to 30% about surbibin. Oh sorry, matlab about exercise. But exercise is also a very important aspect to maintain their overall health if they want to sustain for the rest of their lives. There are guidelines for walking as well, that in pregnancy, a lady can do 30 to 40 minutes of walk in a divided form. So we can advise them કે આખા દિવસમાં 10 થી 15 મિનિટ દિવસમાં 2 થી 3 વખત તમે ચાલી શકો છો. So this additional walking will help her cutting the calories. There are so many exercises apart from that also. The walking has got tremendous benefits. I will not go in detail, but walking helps a lot to maintain posture and all. બેકએકમાં પણ છે ને વોકિંગમાં ખાલી આપણે એક નાની એડવાઇસ આપી દઈએ ને કે ભાઈ ચાલતી વખતે છે ને કમર થોડી સીધી રાખજો. ફ્યુ ઓફ ધ લેડી યુઝ ટુ હેવ મિથ કે પ્રેગ્નન્સીમાં તો આમ જ હાલવું પડે. ચોથા પાંચમા મહિનાથી આઈ હેવ સીન લેડી વોકિંગ લાઈક ધીસ જસ્ટ ટુ ફીલ દેટ યસ દે આર પ્રેગ્નન્ટ. We should ask them to correct their posture because otherwise they will end up in severe backache postpartum. પછી માથું આપણું જ ખાશે કે ડિલિવરી થઈ ગઈ, પેટ બહાર રહી ગયું ને કમરનો દુખાવો તો જાતો જ નથી. હા પછી જો સાંભળો વાતો વાંક આવ્યો એનેસ્થેટિસ તો હા પેટ નથી દેખાતું. સર 5મા મહિનો આવી ગયો, પેટ તો હજી દેખાતું નથી. તમારે બીજાને બતાવીને શું કરવું છે? So we should know the guidelines of walking. There are so many other exercises as well. So those are swimming and some other yoga exercises, posture and breathing exercise. And then that also we should offer them that yes, you can do this and that. Okay, so these are some information, more information available, but I would like to end up here. Thank you very much for your patient hearing.
Now I'd like to invite on stage Dr. Bhanushali Badraka sir and Shaili ma'am to please facilitate our speakers. All the speakers on the
Dr. Hirani sir. Dr. Puneet Khatri sir.
કચ્છમાં શું હાલે છે? કચ્છમાં કે આજે અને
please come for the group photo.
Group photo, sir.
સર થોડાક આગળ આવજો ને, થોડા આગળ આવજો. યસ Yes, sir. Look here, yep. Wait a minute. Yes. Again, yep. Okay.
Now we'll proceed for lunch, and the last session, the heating discussion will be after lunch.
The lunch is open for all, and now you all know what to eat, what not to eat. The panel discussion is yet to be there after this lunch, so please be with us and bear with us.
National international conference.
Khatri. Over to you, Divya.
यहाँ करूँ, यहाँ करूँ? एक मिनट. ये ना?
So we'll start with the last session of this event, panel discussion, and not wasting much time, we directly come to the case number 1.
Panelist invite करें.
Madam, no panelist.
Open forum से.
બધા panelist જ છે હવે તો.
So let us start with the fill in the blanks. એટલે કે આગળ જે ખાલી જગ્યાઓ છે પૂરી કરો.
So we'll start. Mrs. ABC, 23 years, primary, marital life 1 year. Her EDD was 11th of March 2024. She was referred at 36 weeks with recently detected hypertension, not on any antihypertensives. On receiving, patient was conscious but icteric. BP was 140/90. Her abdomen uterus was 36 weeks, vertex presentation, FHS was normal, NT, target scan and growth scans was normal. So with this history, what is the provisional diagnosis you come to?
You can shout in crowd from behind, yes.
Any one of the PGs from this history part, what I have told, anything comes to your mind?
શેનું પેશન્ટ છે? પ્રાઇમી 36 weeks. પછી? આ બસ. આ બસ એવી રીતે.
So what all investigations you will order? We gave the investigations and investigations were like hemoglobin was 10, platelet count was 1 lakh, creatinine was 1.5, urea was 46, bilirubin was 6.8. Okay. SGOT, SGPT were raised, alkaline phosphatase was raised, protein was 5.3, RBS was 70, urine albumin was traced, and protein creatinine ratio was again raised. And coming to the fetal side, USG was normal, color Doppler was normal. So after this investigations, how will you improvise upon your provisional diagnosis? You had told that it looks like PIH. So now how will you improvise on your diagnosis with after this investigation part?
Exactly. Biochemical investigations are going that platelets have reduced, the LFTs has increased. So probably we are dealing with HELP.
So in this case, we will have a differential diagnosis. One of those is HELP syndrome. Okay. One more, what comes to our mind is hepatic disorders in pregnancy. So it might be hepatic disorders in pregnancy. In that it comes acute fatty liver of pregnancy. Then it comes cholestasis of pregnancy. And viral markers also we should get it done, whether it is component of hepatitis is there or not. So how will differentiate whether component of hepatitis is dominant, she's suffering from hepatitis or not. We'll get the viral markers done, and in that the LFTs will be grossly deranged. It will not be like 6.8, it will be very high, and all the other markers SGOT, SGPT will be also very high. And how will we rule out cholestasis in these cases? Bile acid will be raised, and again problem of itching will be there, but in this case itching was not there. Okay, so we got the viral markers done. Viral markers were negative, and one more investigation which was missing was coagulation profile. So we get the coagulation profile, and coagulation profile was deranged. PT was 27, INR was 2.24, APTT was 45, and fibrinogen was 105. So now again we improvise on our diagnosis. So what we add on to our diagnosis is acute fatty liver, mostly acute fatty liver of pregnancy with coagulopathy. Okay. So now what is the treatment part? How will you manage this case? She is 36 weeks, baby is fully mature, coagulation profile is getting deranged, LFTs are deranged. So what is our next step? How will you manage this case? Termination of the pregnancy is the only and the immediate
that we have to do immediately. We cannot wait for long, because as much as we wait, that fetus is getting affected, mother is getting affected, coagulation profile is worsening. So we will have to do an immediate termination. Now for termination, again we have choices. So in this case, we did an examination. Cervix was uneffaced and vertex was at -3. So now what is your probable way of termination? How will you opt for termination in this case?
How many of you want to go for induction of labor? No one. Lovely.
Because again, if we induce in this case, we have to wait for 24 to 36 hours. That will cause worsening of the case. Her Bishop score, if we calculate, Bishop score comes to less than 4. And in this case, if Bishop score is less than 4, induction is not recommended. So
Just to twist the case, I would like to do one thing, that in routine examination, this was found to be a case of IUFT. Now how to proceed? બધું સેમ ટુ સેમ, ખાલી IUFT.
These findings or without this?
With these only findings, आज બધું same to same, ખાલી IUFT. Yes, now the question, how many of you want to go for induction of labor? આપણે કરી દઈએ ચાલો.
no, in acute fatty liver
RFT
pregnancy,
normal છે,
immediate
RFT
delivery
normal.
is the only answer.
Create વધારે છે. Hi Ram.
So you don't have time
Oh
to
my
wait for 12 to 24 hours. So immediate delivery is the only option.
So we want mother to be safe.
So in these cases, what is the anesthesia of choice? Because if we go for spinal, chances of hematoma formation are there, bleeding from the spinal site are there, chances of infection are there. So GA is whenever coagulopathy is there, GA is the better option. Again, we have to involve all the disciplines. Gastroenterologist has to be involved, and senior anesthetist is required. If we get one more gynecologist, our colleague, we get along with this cesarean, in this cesarean, that is better. And we have to arrange for blood components, because it is never predictable how much the patient will bleed intra-op. So FFPs, packed cells have to be arranged. Proper counseling has to be done. Patient has to be counseled properly कि આ બધું થઈ શકે ઓટીના વખતે આ બધું આપણે તૈયારી રાખવી પડે. તમારે જણ સગા ન હોય તો આ બધું ભૂલાઈ રાખજો, તો દોડભાગ કરવામાં એ લોકોને સહેલું થાય. બરાબર. What is the incision we recommend for this? Phalansteal, but some books say we should go for vertical incision, because in that if we have to go for stepwise devascularization, again internal iliac vagara, then vertical incision is easier. Liberal.
No, it doesn't. We require a hematectomy.
No. Skin incision, I'm asking. Skin incision.
Skin incision to financial
So we went along with the cesarean. On table, uterus was flabby. So that time your counseling comes to role. We had already predicted this could happen. So attenders are prepared and we will not be in a mess. So uterus was flabby. Now how to proceed? What all things we can do? All the oxytocins we can give, blood components we can give, and stepwise devascularization we can do. And sutures we can put, Heman sutures and all. So
Anything
that uterus is
to
contracted.
be done for prevention of catastrophe before surgery?
And modified peeling suture is form of MG.
બરાબર. Vitamin K, number 1.
Tranixa.
Tranixa point. And some of the measures to prevent? FFP. She already told કે 2 FFP ને 2 PCV ને 6 FFP તો મંગાવી જ દેવાના. પૂછે કરી દેવાના. નો. એટલે એકવાર કેવું છે કે PPH તમારું બંધ થાય ને પછી તમે નવો સપ્લાય આપો તો it is more beneficial for the patient. If you
So pre-op, if you start FFP giving pre-op with this coagulation, deranged coagulation profile, it is always better. If you, before taking only, you start FFPs. So when you take that time, 5-10 minutes, it's hardly a matter of 5 minutes. So anybody who would like to put drain, if generalized oozing is there, then drain we should put.
Always put a drain. Whenever you do a complicated case, always put a drain so that you can sleep at night.
BT or PCV?
PCV with blood
Blood
There's nothing like fresh blood.
Fresh blood.
The scenario of Amar Akbar Anthony is gone now. The scene of Amar Akbar Anthony is gone now. Amar Akbar Anthony.
इधर से उधर लगाएगा तो फिर वहाँ जाग जाएगी.
PCV and blood components are removed. That is my
Because that will help in coagulation.
rather than
PCV
the
was PTL.
No. The platelets and FFP will help in
PCV with blood components is blood function.
So post-op orders, we have to give higher antibiotics in this case. Oxytocins have to be continued for a longer time, and repeat investigations. We'll repeat all the investigations after how much time? 24 hours. We'll repeat all the investigations to see whether her coagulation profile has improved or not.
If everything goes well.
So, coming to the short description of acute fatty liver pregnancy, this was first described by Sheehan. It is also called as acute liver atrophy or acute fatty metamorphosis. It is rare but life-threatening complication. Third trimester or immediate postpartum period is the time when it emerges. Risk factors for it are maternal age, multiparity, male fetus, multiple pregnancies, underweight patient, or preeclampsia. This can lead to fulminant hepatic failure, so it is an obstetric emergency. Recurrence in subsequent pregnancy is not known. Signs and symptoms will be like of hepatitis. We already discussed. Itching will not be there. Other than that, all hepatic symptoms can be there. Role of hepatic imaging or hepatic biopsy has no role in this. So it is associated with complications like acute renal failure, hepatic encephalopathy, pulmonary embolism, and mortality is in there 10%. But the good part is there is complete recovery if we give symptomatic treatment and supportive therapy. So all the renal and kidney functions will recover after some time. So as soon as you early diagnose, early give supportive treatment and prompt delivery, so the patient will recover very fast.
So what is the diagnostic finding in AFP?
Once you rule out everything, if nothing comes, then it is acute fatty liver of pregnancy. If it is not cholestasis also, then it is acute fatty.
But it was helpful, na? देखो low platelet count, elevated liver enzymes.
For LDH, we should, if we have to see help, then we have to get LDH done. LDH was not there. LDH was not there in this case. If we want to rule out help, then we should get LDH also done.
To MCQ, I would like to raise here, which is the most common cause of hepatitis in pregnancy. Most common hepatitis in pregnancy. Most common hepatitis during pregnancy. Viral. That is A. Hepatitis A. And which is the most fulminant one?
E.
Yes. So we should keep this in mind, and wherever viral markers showing hepatitis E, you should be alert enough that it should not be managed at any of the periphery center. It has to be managed in higher setups. Let us move towards case 2. There is a small girl with us, Miss ABC, who is only 13 years old, and she has started menstruating since a few months. There is excessive menstrual blood loss, which has led to severe anemia to her. How would you like to investigate here?
History first. Any family history.
Okay, number 1 is family history કે બીજી કોઈ બેનને આવી તકલીફ થઈ છે, મમ્મીને થઈ છે, માસીને થઈ.
Coagulation, blood investigation.
Okay, so okay, so you want to jump now towards investigations. Okay. Age of menarche. Here it was not mentioned, but she has started menstruating since last 6 months. So there is coagulation profile and CBC and thyroid function test, 3 tests. Anything else? Ferritin. Acha. Exactly. Ultrasound. थोड़ा सा sonography करना. UST pelvis. But we would like to say something. Amagat can also. Sir, Punit sir, especially to you, if such girl comes to you, how would you like to proceed further? You have done the ultrasound, the uterus was found to be normal in size, endometrium was thin, ovaries were normal, HB were 4 gram, electrophoresis test was done, it was found to be normal, no thalassemia or something was done. TSH was, thyroid profile was done, TSH was 4.0, rest of the parameters were normal. Coagulation profile was deranged here. Deranged.
Platelet, thrombocytopenia.
Platelet was 1.2 lakh.
Find out the cause, like
Yes. So whenever you don't find specific reasons, you have to search of the some of the rare causes of coagulation disorders that Sir Hirani sir already described in his list was factor 5 latent deficiency, von Willebrand factor deficiency, this and that, and ultimately you have to come to one conclusion, and accordingly you can treat with artificial infusion of the factors along with anemia management and menorrhagia management.
And in this case, if the coagulation profile was normal, all investigations come normal, then how will you manage this case? And what will be the diagnosis? Puberty menorrhagia, abnormal uterine bleeding, and how will you manage this case?
Correction of anemia, 4 grams of BT.
Yes, depending on the endometrium. If there is thin endometrium, as I already told, she can be put on COCs, that is combined ossipils. Usually it will help, and give progesterone in such a manner that androgenism and other side effects are very less in this particular age group.
But recently what the age is less than 16 years, and estrogen will enhance the fusion of activities than Western growth of the long bone will be hampered if we have estrogen before age of 16. So
But sir, in this short duration we can give, no, for this short duration we can give, then put on progesterone therapy.
The short duration is for 20 days.
We can initially start the treatment with progesterone
I'm
only.
really
If she is
not
not responding to progesterone therapy, maybe Premiol or estrogen you can start for a few days and then put on for continued progesterone therapy. Prime and then for short duration.
Progesterone both are theoretical, but doesn't work. According I want to say, and no doubt, everybody says that there is a progesterone, progesterone. No. Practically,
no, but ultrasound findings show the type of AUB with the PCO type deficiency is
ultrasound is very important. Formulation of PCO, formulation of PCO. Puberty menorrhagia.
So, because the endometrium was thin, we started giving PCVs to this patient because her HB was only 4 gram. We builded her till say 8.5 and then planned that in further progress we will shift her to injectable iron and we will allow her to normalize the hemoglobin. Eventually, we started ossipils as per the guidelines, and after 4 days, again she was brought with her mother that the menorrhagia is not improving. With ossipils.
Double the dose.
Okay, so now previously we were not allowing estrogen.
Combined therapy you can give.
Once we have to stop the bleeding.
Yes, we have to stop the bleeding.
Acute you can give. Short term therapy you can give.
Yes. So we can increase the dose as per requirement. You can add hemostatic agents. You can increase the dose of hemostatic agents as well. And
or repeat the ultrasound in case if the endometrial polyp or some pathology is missed, if not by ultrasound, then go for MRI.
yes, go for expert ultrasound or needed MRI. And in rarest of the rare cases, I have not used, however, the conjugated estrogen which is being there can be given parenterally, does dramatic improvement in such cases. However, એવું બધું જરૂર નથી પડતી.
Anybody has experience of giving Aquarion testosterone injection?
કયું આપી શું આપવું છે પ્રોજેસ્ટ્રોન
Okay, so we'll proceed to the next case. We have now case number 3. She is third gravida, para 2, living 2, previous to LSCS. She is 37 weeks period of gestation, unbooked patient. She came to your hospital with scar tenderness. So she is previous to LSCS, 37 weeks, scar tenderness is there. So you decide to take up for cesarean. On your sonography labor room, you saw liquor was less and it was placenta previa. So what alarms will ring in your head? Placenta is anterior.
To threatenize you, it is anterior.
So immediately, if it is previous to LSCS, placenta is anterior, so immediately chances of placenta accreta percreta should come to your mind. In that, what clinical findings will be there to support your provisional thing, what is coming to your head? If head is floating, if head is high floating, there might be high chances that placenta is sitting down. So you open the case and this is the case. Placenta was as per your suspicion. Placenta is low-lying accreta. That we have discussed. What investigation antenatal, if supposingly this was your patient, she was having previous to LSCS and she is coming for you, follow-up to you from 6-7 months. How will you antenatally do diagnostic part to confirm whether it is accreta or percreta? What are the investigations you will order? And if ultrasound is slightly, inconclusive, then MRI we can get it done. So if you diagnose it antenatally, how will you plan the delivery? How will you do the counseling? What all consent you have to take? How will you make the attenders and family prepared for it? And make yourself prepared for it. Whether you will take it in your setup or higher center is required.
You have to explain to the patient the position of the placenta, the complications and consequences associated with the readiness for blood transfusion to be ready, and well informed and well.
So number 1 is it is a high risk case.
Second,
Number 2.
when you are taking such a case for cesarean, you post it at that time only, morning time.
So
that
senior
you get
senior anesthetist has to be there. Blood support should be ready. Colleagues should be there. It should be done in a tertiary center, not at a proper nursing home.
Where interventionalist, ICU and everything is available.
So, and for your preparation, all the preparation of PPH should be there. All the mobs, instruments, whatever you require, that should be ready. Hematinics should be ready. So what incision? What is the incision you prefer for this? And one more thing, we should always explain the patient for consent of obstetric hysterectomy. If there is a problem, we might have to proceed for obstetric hysterectomy. So again, in this few literature recommend vertical skin incision also. So that obstetric hysterectomy, if you proceed for artery ligation, you proceed that incision. Vertical, if it is there, it is easier to go about these things. Prophylactic internal iliac ligation, anybody goes for it before taking out the baby?
How it's possible?
No, if you take out the baby before taking out the placenta, if you will try for prophylactic internal iliac ligation.
બચ્ચું બહાર કાઢવાથી પહેલા યુટ્રાઇન કે ઇન્ટરનલ ઇલિયાક કોઈને લાઇગેટ કરવી છે? That is the question.
પોસિબલ નથી ને.
બચ્ચું આવી જાય પછી
જ છે. ના now currently there is different question. કે ડિલિવરીથી પહેલા કોઈને કરવું છે તો everybody agrees કે ના એવી રીતે નથી કરવું. Now the uterus.
જગ્યા જ નથી.
I am coming to the next point. Okay, now the baby has been taken out. The next thing, placenta કોને કાઢવી છે? At least try કરવા માટે. આ બધું લાવવાનો મતલબ જ છે. યસ સર.
અને પ્લેસેન્ટા પ્રેવિયા થીન આઉટ જે લોઅર સેગમેન્ટ સાવ થીન આઉટ એકદમ પતલું અને એક્રેટા છે આપણે ખબર જ
સાંભળો
उसको बोला था कि ये ब्लीडिंग तो जबरदस्त होगा ही ऐसे करके 4-5 मीटिंग रेडी रखा ओटी ऑन टेबल आपे પછી છે ને બેબી આઉટ થયું પ્લેસેન્ટા જેવી આવી એડહેરન્ટ આવી રીતે દોડતા થોડી વાર પછી પલ્સ બીટી મંગાવ્યું ઇમોશનલી સિક્યોર લોઅર સેગમેન્ટ એટલે આખું તમે જુઓ ને આ લોઅર સેગમેન્ટ એન્ટિરિયર પોસ્ટિરિયર વોલ ને આખું ધરવાઈ અંદર સુધી થ્રુ આઉટ એકદમ એટલું ભયંકર હતું બ્લીડિંગ ને એવું આ બધું ધીમે ધીમે ઇમોશનલી જે સ્પટર હતા બધા સિક્યોર કર્યા બાંધ્યા પછી અલ્ટિમેટલી ઇન્ટ્રાયુટ્રાઇન પેકિંગ કર્યું 3 દિવસ 2 દિવસ પેક રાખીને કાઢ્યું લગભગ કુલ 5 બ્લડ આવે અલ્ટિમેટલી પેશન્ટ સર્વાઈવ એકવાર પલ્સલેસ ડિક્લેર થઈ ગયું પછી આવી
So heroically, in cases when you know that you are dealing with placenta accreta syndrome, you should not touch the placenta. You should, no, તમારું નહીં. જી. હા. So you should not touch to the placenta. That is the key message we would like to give it here.
in spectrum the degree of spectrum just accreta only or
Percreta. So if the placenta is not separating, you can put a hand behind the plane in between the placenta and the uterus. If it is getting separated, well and good, but you should not forcibly separate it. Then that sinuses will open and bleeding will happen.
Yes. So prior diagnosis of whether this is
Accreta, percreta,
morbidly adherent placenta, increta, percreta, the degree of diagnosis should be in your mind. And if the placenta gets separated out from its own, then and then we should remove it. Otherwise, leave it as such and start for the hysterectomy.
So if in this case,
If there is, in cases of percreta, we should start with obstetric hysterectomy if the rest of the things, family and everything is completed. If the family is completed.
and you have counseled the patient properly. पर मैडम परक्रीटा से प्लेसेंटा सेपरेट नहीं था तो પછી
but you can leave the
How many of you will prefer giving injection methotrexate post-op? If placenta, then we have to give methotrexate. And in this case, if we leave back placenta, then we have to give higher antibiotics. Although support has to be taken care, so that again secondary infection is not there.
After case 2 and 3, again we have? Case 2 again. Yes, again we have case 2.
That is case 2 of Dr. Bhavik.
So, now we have one poor lady, Mrs. XYZ, 32 years old, active married life 8 years, primary infertility, uterus showing normal in size, but 2 subserosal fibroid, one in anterior wall, one in posterior wall of size 3 and 3.5 centimeter respectively. Bilateral ovaries were found to be PCOD. AMH level was 6.4, FSH-LH ratio was 6.2, LH was 9.4, TSH was 4.2, HB was 14 gram. And she is not concerned. Husband semen parameter was normal. How would you like to proceed here?
मोटा मोटा फाइब्रॉइड से
हिस्टोलैप्रोस्कोपी कर रहे हैं ड्रिलिंग कर रहे हैं ट्यूबल टेस्टिंग कर रहे हैं तो वी कैन जस्ट एडवाइस दैट कि गेट द फाइब्रोइड्स रिमूव्ड
Poor lady किधर है? Poor lady. Poor lady किधर है? मैं पैसा ना देगा. HSC કર્યો. HSC કર્યો.
લીવા પટેલ મોકલી દેવાનો
HSC કર્યો. HSC માં બંને બાજુની ટ્યુબ નોર્મલ આવી. અને ફંડલ ફાઇબ્રોઇડ્સ જે છે that is not affecting the cavity. Why you want to go for myomectomy? Yes, Madhav sir.
HSC will tell only what is tube. પણ અંદર શું થાય છે આમાં 100% તમને ગ્રેડ 1 ગ્રેડ 2 એન્ડોમેટ્રિયોસિસ મળશે 100% મળશે because it is 8 years
30 plus 8 ને એમાં 30 to 40% ladies will show you some degree of endometriosis.
Anybody who wants to do this tubal testing other way and advise her lifestyle modification for say a few months?
अभी टाइम पास करने में क्या मतलब है? 2 years 8
Just asking. करू નથી. Just asking.
હવે પેશન્ટને છે ને કુદરતને ભગવાન પર કેટલી શ્રદ્ધા છે હસબન્ડને પોતા પર કેટલો ભરોસો છે.
So, why? Yes.
એની 5-7 years infertility PCOD છે પછી એનું ટ્યુબલ ટેસ્ટિંગ હિસ્ટોલોજી બરાબર 2 ફોલિકલ પછી એને આઈવાય પેલી વાર કરવાનો ના આઈવાય સોરી આઈવાય નહોતું કરવાનું તો મેં કીધું હવે જો એસટીજી આપી ને રિલેશન રાખી દે તો આઈવાય જરૂર નથી મેં કીધું મને જાણો પૂરો ભરોસો છે
Wow, very good.
તમારો ભરોસો ડબલ થઈ ગયું.
So here, clear-cut case, long-standing infertility, PCOD, fibroid. You have 3 grounds. You should definitely go for diagnostic laparoscopy, laparoscopy, do PCOD correction, do myomectomy, see for the other things, and then advise them to continue with the pregnancy.
If patient is directly willing for IVF, then we go for
Poor
hysteroscopy only.
patient, poor patient.
મંદિરનું કેમ થાય છે? મંદિરમાં કેમ થાય છે?
મંદિરમાં કેમ? એ તો ઓપીડી જોશે પછી શું?
પછી અમે કરી આપીએ.
આઈવીએફ કરો? હા તો એડ્રેસ મોકલાવો.
લેવા પટેલને મંદિર બે કરાવી દે.
અચ્છા.
મંદિર પ્રાઇવેટમાં મંદિરમાં ફાયદો છે. લેવા પટેલ પછી લેવા પટેલ. પણ એક વન મોર ક્વેશ્ચન. આ તો 8 years of married life. What will be the cut off કે તમે હિસ્ટોરિક એડ્રેસ કરો? Like 3 years, 4 years.
So મારો ક્રાઇટેરિયા શું છે? 5 years plus married life. 30 near 30 plus apply go. એટલો ઇન્સ્ટોલ એવો કરાવવાની પેશન્ટને એમ નહીં કહેવાનું કે આ તમને આ નથી કરવું તો આપણે નીચો રહો ટ્યુબલ પેટર્નથી કરીને વેટ એટલે બીજું કોઈ અલ્ટ્રાસાઉન્ડ ફાઇન્ડિંગ ના હોય.
Whenever there are 2 or more reasons, go for laparoscopy.
ના ના માય ક્વેશ્ચન કટ ઓફ 2 વર્ષના થયા કે 4 વર્ષ 8 વર્ષથી તો તમે પેશન્ટ એડવાઇસ કરે.
You have to see the curiosity of the couple.
How much keen they are to conceive.
We have so many patients, they are not at all curious, just coming because the relatives have thrown them. कि जाओ दवा ले आओ. And the couple used to come.
થઈ ગયું આગળ એને ટ્રીટમેન્ટ કરી લીધી.
And then also let them decide. तभी वो ऐसे भगवान का अरे येसुस पढ़ने वाले बोलते हैं कि भगवान को इच्छा हो कि हो जाए.
हाँ. फिर जब वो कंसीव होते हैं तो हमें लगता है ये कौन से भगवान आ गए. So after case 2, now we have case 5.
So we come to the next case. She is 28-year-old female. She is 6 gravida, para 2. She is live birth 0 and previous 3 abortions. She presented in emergency room with 19-week period of gestation with pain in abdomen. Blood reports were normal. Anti-scan was done, that was normal. And today she is 19 weeks with IUD. Now coming to the obstetric history. Her first pregnancy was 10 weeks abortion. That time cardiac activity had come and she had gone for missed abortion. Second was 26 weeks IUD. Third was 8 weeks abortion. Fourth was 30 weeks IUD. That time she was severe PIH. Now fifth was 8 weeks again missed abortion. And sixth, this was present pregnancy, that was 19 weeks with IUD. There were no antenatal checkups in this patient pregnancy because she was from a remote village. Directly she reported to the emergency room with pain in abdomen, and that time we came to know that she is 19 weeks IUD. So what provisional diagnosis, what differential diagnosis comes to your mind? So this is mostly clear-cut case of Apla syndrome. So on examination, we saw that the patient had BP of 136/86, bilateral pedal edema was there. Now, again, this supports our diagnosis, Apla syndrome, because Apla syndrome is very connected with PIH also. Now, coming to the RPL. How will you define RPL? RPL is defined as more than 2 pregnancy losses by ESHRE, but RCOG and WHO define as more than 3 pregnancy losses. But again, we should start investigations after 2 pregnancy losses only, because each pregnancy is precious. We should not wait for the 3rd pregnancy loss and then we should start investigations. So what are the causes of recurrent pregnancy loss? So that is one cause, that is genetic. Second is hormonal. Genetic will be, as you suggested, that aneuploidies can be there, translocations can be there. Second, you told us hormonal thyroid problems can be there, prolactin, hyperprolactinemia can be there, diabetes can be there. So in those cases, hormonal causes are there. Third is anatomical causes. In this anatomical causes also, it can be what she is conceived, what she has got afterwards, that is acquired, or genetic. In genetic, like uterine anomalies will be there, didelphys uterus, unicornuate uterus. In this cases, pregnancy losses will be more.
And acquired causes, if she has got fibroid, polyps, in those cases pregnancy losses can be there. And fourth is immunological. Immunological again we subcategorize as acquired or congenital. In congenital we have got factor 5 mutation, factor C, factor S, and in acquired is Apla syndrome. So how will you, this is the different categorization what we have discussed just now. So how will you diagnose Apla syndrome? What titers we have to get? There is proper criteria for it. Beta 2 microglobulin. 3 things are there. And when we have to get it tested? In the pregnancy period, after the pregnancy period, how much duration should be there? This is what is the name of criteria? Especially PG students, question is there on this criteria only. Sapporo's criteria is there. So we have to get these 3 antibodies tested as sir told: lupus anticoagulant, antiphospholipid antibody, beta 2 microglobulin. And this is to be done after pregnancy. In the pregnancy you can not get it done. Like in this patient, once she gets terminated, after 6 weeks of pregnancy termination you can get it tested. And this titers then have to be assessed whether it comes out to be positive or not. So in this case, we got her admitted. She was induced. BP had shot. Mexalf was given, and after 6 weeks follow-up, we got it Apla tested. Okay. Thrombophilia screening. Again, we have discussed that thrombophilia, factor 5, factor C, and what are the treatment modalities? So if you get Apla positive also, then also treatment modality will be same. And if she comes out Apla negative, then also empirical treatment we can give. If patient is giving history like this, previous so many abortions are there, in those cases one entity is there, seronegative Apla syndrome. In this seronegative Apla syndrome, serology will be negative, but all the symptoms of Apla will be there. So in those cases, empirically we can start on low molecular weight heparin and ecosprin. So what is the dose of low molecular weight heparin you have to start? If she is more than 60 kg, then 0.6. And when you have to start on low molecular weight heparin? As soon as she is one day, as soon as she is UPT positive. And when you have to start with ecosprin, and what is the dose of ecosprin? Both you have to start. So what is the dose of ecosprin you have to start along with that? 150. So now there is no role of 75. Directly 150 you have to start, and low molecular weight heparin has to. Steroids, no?
Visolon can also be safely
if she is
given.
case of infertility, if she is not able to conceive, then it is shown. RPL also. OD once. Daily. There is no role of weekly, there is no role of bi-weekly. If you are giving, then it has to be given weekly. Otherwise, giving bi-weekly or weekly is like giving placebo only. It is no role.
Even hematologist tells that alternate aspirin and ecosprin and all that alternate.
No, alternate has no role, no.
But ecosprin,
one day ecosprin, one day heparin, like that.
Ecosprin should be 150 only. But LMW with 150 ecosprin,
This is
either you give 150 ecosprin only or give LMW only. If you want to ecosprin, then it should be 75.
So RPL की एशरे की गाइडलाइंस में लिखा हुआ है 150 with low molecular weight heparin. नहीं.
रिक्वेस्ट पड़ा तो થઈ જાય છે થઈ જાય છે એટલે આ લોકો નહીં થાય because already they are having coagulopathy मतलब hypercoagulation, thrombophilia, so they are less likely to bleed.
Any monitoring is required.
So you can keep a watch on INR.
Any monitoring is required if she is taking. So with LMWH, as madam told, no monitoring is required. Factor 10 in monitoring is also not required if you are giving LMWHA. So should anticoagulant should be continued postpartum if she delivered? Should it be continued postpartum? And if she is continuing throughout the pregnancy period, till what time in pregnancy you will continue LMWHA? How much time before delivery?
37 weeks.
Cesarean થી કેટલા કલાક
12
પહેલા?
hours before cesarean, 12 hours
Yes.
before, till that time you have to give. And once she is delivered, whether you will continue post delivery or not,
Warfarin? Warfarin.
now in this also two things are there. If she is obstetric thrombophilia or she is clinical thrombophilia. In obstetric thrombophilia, like only pregnancy losses are there, then no need of giving heparin post delivery. If she is having history of thromboembolism, clinical thromboembolism, other than this obstetric losses, then you have to start heparin and continue till 6 weeks.
Yeah, but theoretically, pregnancy itself is
Hypercoagulous.
So better to for safety purpose, better to continue.
But again, sir, daily we cannot give, no. If she is a known case of thrombophilia, फिर बंद कर दो, हाँ.
Oral
But
anticoagulant
if
should
she
be
is a known case of
started.
thrombophilia, if she is having history of pulmonary embolism or deep vein thrombosis previously also she had, then you have to continue with heparin till 6 weeks.
And that is high risk.
That is high risk.
There is no history of clinical thrombosis.
Huh.
Then also you should, because pregnancy is pregnancy.
Then maybe 3-4 days you can give and stop.
1 to 3 weeks. Early postpartum.
Early postpartum you can give.
Continue, but there is no harm in it.
Last month only, one of my patient on 6th post-operative day, previous history of 2 abortions, 1 IUFD, 1 live child, and this time it was a live child. On 6th post-operative day, came with abnormal limb movements, severe headache since 4 days, and weakness on left upper limb and facial muscles, some of the facial muscles. It was investigated and found to be a case of cavernous sinus thrombosis. So, thrombocoagulative disorders can affect at any point of time. Giving it for 3 or 4 days and suddenly you stop, you may end up in later on also.
So that's it. We finished, end the panel discussion with this. We are very thankful to all of you.
Thank you very much. No, बस मैंने phone आया घड़ी में.
We thank you all a lot for bearing with us and staying for this long on a Sunday eve. Especially Sunday is a family time for all of you. So we can understand, and yeah, that is an extended family. So thanks a lot to lot of you.
Thank you.
Thank you.
Our deal has to any care of it. Still